Saraswati, goddess of knowledge. So on this note, I will request Dr. Sharat Reddy sir, Dr. Nandana ma'am, Dr. Lakshmikant Reddy sir, Dr. Shrikant sir, Dr. Haridhara Krishna sir, Dr. Nikhil sir, Dr. Naveen sir, Dr. Naresh sir, Dr. Vikram Kishore Reddy sir, Dr. Meena Reddy ma'am onto the stage to grace the stage with land level.
ना bro
I thank all Medicover team for planning this wonderful program on infectious diseases. And I'm very grateful to all the delegates who don't want to miss even the first session in this program and who are sitting here for almost last 10-15 minutes. As an interventional cardiologist, often I feel like a space scientist sitting in, his console room of Chandrayaan-2. It's Chandrayaan-2, not Chandrayaan-3, because that is fresh in our memory. So after liftoff from Earth, it joined Earth orbit, drifted away from Earth orbit into Moon's orbit, that is elliptical orbit of Moon, and then slowly moved into a circular orbit, and before landing it separated from propulsion module. While landing it crashed. What made it crash is, yesterday I was speaking to one scientist in Skyroad. It is the dust particles which occluded deceleration module in lander. So after a 90% successful mission, we culminated into a failure just because of small dust sitting in an engine. So that's what happens to me sometimes after treating a patient with a cardiogenic shock in acute MI with an impella, complex PCI, and patient moved back into ICU we'll go through all the roller coaster emotions of ICU guys as well as patient hemodynamics and patient attendance, and we'll come off mechanical circulatory support, but then we caught off guard with an infection, something like a dust in lander module, and we lose the patient at the end. So infection is going to kill our patients despite the innovations which we have to save the patients, especially in complex scenarios. So in complex surgeries and transplants. We made major strides as a humanity against infection, especially in our country. So once infectious diseases used to be the most common cause of mortality, which is shifted down to, I think it's the third most common cause of mortality. So, and cardiac diseases and oncological disorders became the first common cause of mortality in our country. So we made major strides on one side. We became a world pharma center, but still we couldn't able to handle a small infection like COVID. So what strategies really made us successful in bringing down the mortality of infectious disease? Same strategies also added problem to our new generation. That is, once we used to do a carpet bombing of microorganisms using multiple antibiotics without an evidence, and that gave rise to antimicrobial resistance, and because of which now we are struggling with Acinetobacter's multi-drug resistant Acinetobacter, Klebsiella, E. coli, and stuff like that. So we have to move away from carpet bombing to precision bombing in this era of treating our patients. So I wish my team will bring all the inputs related to this precision bombing in this seminar, and as a responsible clinicians, we have to move away from our old practices, unlearn our old practices, and we have to relearn the newer ways of handling these microorganisms so that we don't let them resistant to whatever antibiotics we have as of now, and they won't dodge our strategies and win over humanity. So thank you entire team, and I wish a complete success for this program.
I request Dr. Nandana Ma'am, Consultant General Physician, Medicover Hospitals, to give the medical note.
A very good morning to all of you, and warm welcome to all the delegates who came from long distances and close by also. On behalf of team Department of Internal Medicine, I am Dr. Nandana Jasti. Very happy and take this immense pleasure and honor in welcoming to this conference of infectious disease update, which we are calling it as IVCON. It's hard to talk after Dr. Sharad sir because he gives exemplary speeches. Since he used sky and orbits and Chandrayaan as example, I am going the other direction, the ocean of infectious disease. When we have to select the topics for this conference, like Shira Sagra Madana, we also churned a lot to bring out what topics we have to present so that we will update ourselves and our audience. Initially got lot more topics, but finally I think we churned the nectar of 9 beautiful topics, which you guys, all of doctors assembled here will enjoy it and make this program grand success. Without further delay, I welcome you all once for this conference. Hopefully the knowledge flow across the room and it will be an interactive session. Welcome all of you once again to the IB Con. Thank you.
Now let's begin with the presentations. The first topic of the conference will be febrile neutropenia, which is the speaker is Dr. Smita, consultant hemato-oncologist and DMD physician, Medicover Hospitals. So please. And the moderators for this session is Dr. Savik Raghuram, consultant medical oncologist, Medicover Hospitals, and Dr. M.L. Lakshmikant Reddy, consultant general physician, Medicover Hospitals.
Good morning, everyone. I'm Dr. Rekla. I'm a consultant oncologist in Medicover Cancer Institute. At the outset, I would like to thank the management for providing me an opportunity today to present a topic on febrile neutropenia. In This leads to a higher chances of infection in these patients. The myeloid cells, predominantly the neutrophils or the macrophages, they execute inflammation. And in the absence of this neutrophil-mediated component of the inflammatory response, fever is sometimes the only sign or the earliest sign that is seen. On a side historical note, with a reducing neutrophil count, there is an increased risk of severe infections. In the eras of 60s, sepsis due to gram-negative bacilli was lethal in about half of the cases within 48 hours of first blood culture. So, handling these febrile neutropenia patients forms an important backbone in patients who receive cytotoxic chemotherapy. Coming to the definition, as per the IDSA guidelines, fever in a febrile neutropenia is defined as a single oral temperature reading of 101 degree Fahrenheit or a temperature reading of 100.4 degree Fahrenheit, which is persistent for more than an hour. Sometimes these neutropenic patients can be febrile because they might be receiving a concomitant glucocorticoid therapy. So, due to the antipyretic effect of the glucocorticoids, we must always have a high suspicion of infection in these patients, and these patients must be regularly monitored for the signs of systemic inflammatory response like tachycardia, tachypnea, and hypotension. Neutropenia, the definition varies. Some define with an absolute neutrophil count of less than 1000 to 1500, but the severe neutropenia is usually defined with an absolute neutrophil count of less than 500. This is not the only thing that is important. In a patient who has a normal neutrophil count prior to chemotherapy but develops neutropenia of less than 500 in the next 48 to 72 hours, these are also the patients who will be at risk of neutropenic infections. A profound neutropenia is again defined with an absolute neutrophil count of less than 100. The importance of this is as and when your neutrophil comes below 500, there is a high chance of developing invasive bacterial, invasive fungal infections. Or if the duration of neutropenia is more than 7 days, again the chance of having a bacterial or fungal infection is very high. The International Immunocompromised Host Society basically defines the neutropenic fever syndromes in 3 categories: a microbiologically documented infection, a clinically documented infection, or an unexplained fever. Microbiologically documented infection, patient is going to have fever, patient is going to have neutropenia, a clinically documented focus of infection, and usually the causative organism is isolated. In a clinically documented infection, The patient is going to have neutropenia, the patient is going to have a clinical focus of infection, but the focus of the pathogen is not isolated. In unexplained fever, they just have fever, they do not have any focus of infection, and the pathogens are not isolated. There are some additional terms that we should know, which are called a persistent neutropenic fever syndrome. In this, the neutropenic patient has a fever without effervescence for at least 5 days of antimicrobial therapy, a broad spectrum antimicrobial therapy in patients with high risk of neutropenic fever, or at least 2 days in patients with a low risk of neutropenic fever. A recrudescent neutropenic fever syndrome is a simple breakthrough infection which recurs following an initial antimicrobial therapy. There is something called a myeloid reconstitution syndrome, in which patients have a new onset fever or a new onset focus of infection, new signs of infection. This generally coincides with the recovery of neutrophils during or from equation. So what is febrile neutropenia? Why is febrile neutropenia more important? Febrile neutropenia is important because around 5 to 10% of solid organ tumor patients receiving cytotoxic chemotherapy develop febrile neutropenia. 20 to 25% of non-leukemic hematological malignancies develop, and 80 to 95% of acute leukemia patients develop. Coming to the epidemiology, the commonly cultured organisms are gram-negative organisms, gram-positive bacteria such as corns, staph aureus, and fungi. The rarer organisms such as viruses must also be kept in mind. Less commonly cultured organisms are gram-negative bacteria such as Proteus, Haemophilus, Serratia, Neisseria. Coming to the management of febrile neutropenia. In the management of febrile neutropenia, first is initial assessment. You have to check your body temperature, and oral temperature recording must be documented. Check for your absolute neutrophil count, and always assess the risk from neutropenia. The timing of antibiotics. The infectious disease working party of the German Society of Hematology and Oncology, they say that obtain a blood culture immediately and start empirical antibiotics within the first 60 minutes of presentation. Because studies have shown that a delayed initiation of antibiotics, the mortality is around 70%. And each hour you delay, there is around reduced survival by 8%. And early antibiotic therapy reduced the mortality from 30 to 20%. So the management of febrile neutropenia is a successful management is analogous to a management of a stroke or a ST elevation MI, but the outcomes or the results are something delayed. You must always recognize the importance of this non-specific presentation in patients who receive chemotherapy. There will not be any signs of inflammation, so a high index of suspicion of infection is always necessary. And the timing of cytotoxic or myelosuppressive therapy also should be kept in mind, because many patients who receive this therapy will develop neutropenia between an error of 7 to 14 days of chemotherapy, and the vital signs have to be monitored. The diagnostic evaluation, the physical examination has to be done, a proper biochemical analysis, the microbiological investigations, cultures, PCRs have to be sent for, and imaging have to be done. The treatment aim is to cover the most likely and the most virulent pathogens. So, is there a way to know the severity of the febrile neutropenia? Yes, there are some recommended scoring systems that were proposed. The Talcott rules, which were proposed in 1992, or the Multinational Association for Supportive Care in Cancer score, which was proposed in 2000, or the Clinical Index of Stable Febrile Neutropenia in 2015. These scores are not perfect because they do not assess the degree of neutropenia or the duration of neutropenia. But do they really help? Yes, they help us in deciding whether a patient needs an outpatient or an inpatient based therapy, or whether the patient needs an IV antibiotics or an oral antibiotic based therapy. This is the MAST scoring, which has a score of 26 points. A high risk patient is defined with a score from 0 to 20 points, and a low risk patient with a score of 21 to 26. But as whatever said and done, a single scoring system is not always advisable to be followed. So we consider multiple scoring systems and multiple factors that are to be kept in mind before deciding whether a patient is at high risk of febrile neutropenia or at low risk of febrile neutropenia. Patients who are at low risk of febrile neutropenia are those patients who have absolute neutrophil count less than 500, but their anticipated duration of neutropenia is less than 7 days. With a MAST score of more than 21, with a CISNE score of 0, do not have any comorbid conditions, and there is no organ dysfunction. But patients with absolute neutrophil count of less than 500, but with their anticipated duration of neutropenia of more than 7 days, a MAST score of less than 21 days, a CISNE score of more than 2, presence of an organ dysfunction, presence of comorbid medical problems, all classify these patients to be at risk of high risk of febrile neutropenia. You must also consider other changes like hemodynamic instability, new onset mental status change or respiratory dysfunction, oliguria, gastrointestinal mucosal disturbances, intravascular, presence of an intravascular catheter. Sometimes all of these predispose the patient to be at high risk of febrile neutropenia. Coming to the diagnostic approach, the initial diagnostic approach starts with history. You must always inquire about organ-specific symptoms, and all these symptoms have to be reviewed daily. Check for new symptoms that can lead to identification of focus of infection. Determine if there are any non-infectious causes of fever like blood transfusion or having an active malignancy. Determine if any comorbid conditions are causing fever like presence of an immobility. This leads to having a decubitus ulcers in patients, or patients with foreign bodies or venous or bladder catheters, prosthetic heart valves or orthopedic implants. And patients with diabetes mellitus or comorbid conditions are predisposed to high risk of febrile neutropenia. These should be checked for. Coming to physical examination, a physical examination has to be done. The physical examination has to be targeted, and specific emphasis should be placed on examination of skin, catheter sites, teeth, oropharynx, gingivas, lungs, skin, lungs, sinuses, and genital and perianal areas. The symptoms and signs are very subtle because of neutropenia. In patients with persistent fever, new sites of infection may become apparent over time, so they must be reviewed daily. And as and when the neutrophil counts starts to improve, the patients also develop new localizing signs and symptoms. So this is a form of this myeloid reconstitution. So this thing also has to be kept in mind when you see patients with neutropenia. The lungs and abdomen are generally examined for their common signs. The central venous catheters should always be examined, should be examined on a daily basis. Slight edema and tenderness may be only evident, only evidence of a tunnel infection. But you must also consider the fact that if there is a difficulty in infusion or withdrawing of blood, it could be a sign of infected venous thrombosis even in the absence of the problems at the exit site. So these patients must have a regular screening of their long-term venous catheters with ultrasound. The skin and mucous membrane should not be neglected. There are many signs and symptoms that can manifest of cutaneous manifestation in infectious diseases, like having a simple ulcer, could be a fungal ulcer, atypical mycobacteria, viruses. If the vesicles are present, you should check for viruses. If there are any nodules, then again fungus or non-tuberculous mycobacteria. Ectomogangliosum, most commonly seen with Pseudomonas aeruginosa, and are skin lesions with necrotic center, most likely to be an invasive fungal infection, Fusarium, Aspergillus or Mycorrhiza should be kept in mind. The perianal examination has to be done on a daily basis, but a digital rectal examination should be avoided in order to prevent damage to the fragile mucosa. They must always be inspected for any perianal fissures, tags or hemorrhoids. Coming to the routine laboratory investigations, we should check for a complete blood count, liver and kidney function test, lactate, urine analysis, blood and urine cultures and CRP. Sometimes when we do a targeted examination like a CSF, we may not find a CSF pleocytosis because the absence of neutrophils per se. So you must recognize that the absence of typical laboratory abnormalities is also a sign in these patients with febrile neutropenia. Coming to fungal markers, the two common fungal markers that are checked are galactomannan and the beta-D-glucanacid. In patients who receive an anti-mold prophylaxis, fungal markers are the checking of the fungal markers is of no use. But in patients who do not receive an anti-mold prophylaxis, these These patients should be monitored with their serial monitoring of their fungal markers. A positive test may further guide the evaluation and treatment by preemptive therapy. Microbiological and diagnostic testing. 2 sets of blood cultures have to be sent. Each set should have a blood volume of 20 ml. If the cultures are positive, they should be repeated until they become negative. If the patient is having diarrhea, common stool cultures as well as stool for C. diff toxin assay has to be performed. If you are suspecting a urinary tract infection, an ultrasound KUV along with urine cultures and susceptibility has to be done. If there are skin lesions, these skin lesions have to be biopsied. They must be sent for cultures and PCRs and TB-PCRs also. Respiratory infections, a nasal swab viral PCR has to be sent. A bronchoscopy, if possible, should be conducted. CNS infections are being suspected. The CSF has to be sent for cultures, PCRs and cryptococcal antigens. In patients who are neutropenic, they also have, many of the time, they also have a concomitant thrombocytopenia. This concomitant thrombocytopenia precludes us from doing many invasive investigations in them. Still, you must always give a SDT support and try to do the investigation as early as possible. Coming to imaging. In patients who are at low risk of febrile neutropenia, an initial chest radiograph is sufficient. But in patients who are at high risk of neutropenia, the guidelines differ. Some guidelines say that you have to do a chest X-ray and you have to do a concomitant high resolution CT scan also. This is because in maybe 20 years back, there was a study that has come up published in Journal of Clinical Oncology, which has said that there was at least a 50% difference, or 50% of the patients had an additional pickup of infections with pneumonias by doing the HRCT. This did not show a survival difference. This led to an early initiation of a better treatment modalities. Repeat imaging should always be obtained in case of increasing or persistent fever. The CT scan of other sites must be done as and when clinically indicated. Coming to the treatment principles. Treatment principles can be in the form of a primary prophylaxis, secondary prophylaxis, empiric therapy and a preemptive therapy. The primary prophylaxis is administration of an antimicrobial drug to prevent infection in patients at risk of increased risk. Secondary prophylaxis, administration of prophylactic dose of an antimicrobial drug to prevent a recurrent infection. The secondary prophylaxis is more commonly used in patients who develop fungal pneumonia or fungal infections. Empiric therapy is initiation of antibiotics at the onset of neutropenic fever, but before a diagnosis or a microorganism is isolated. Preemptive therapy, you screen the patient with a biomarker, and if at all the biomarker seems to be rising, then add a treatment in respect of the biomarker. Antibiotic are always administered. They must be broad spectrum. They must be having a bactericidal activity. These are generally given to patients who are at high risk in the hospital setting. And temporarily withholding the chemotherapy until stabilization is something which should always be attempted. And the spectrum of coverage must always include a gram-negative pathogen, a gram-positive pathogen, and anaerobic pathogens in certain specific situations. The duration of neutropenia increases, the risk of invasive fungal infection keeps on increasing. The initial regimen, it should always contain, it should be generally be containing a monotherapy with an anti-pseudomonal beta-lactam, preferably piperacillin tazobactam, or imipenem or meropenem or cefepime. The doses have been mentioned here. If the patient is having a second or a complicated infection or having hypotension or mental status change or findings of pneumonia or cellulitis, a second agent with a gram-negative activity should always be added. The skin and soft tissue infection or catheter-related infections, if present, then drugs with MRSA activity should be added. Anaerobic coverage is only given under specific circumstances such as necrotizing enterocolitis, mucositis, sinusitis, or periodontal cellulitis. Addition of a gram-positive coverage, vancomycin or other gram-positive organisms is not recommended as a part of initial therapy, but added if there is hypotension, pneumonia, or blood cultures being positive for organisms and skin, soft tissue, or the catheter-related infections are present. When do we modify this regimen? If the patient is having an unexplained fever in a patient who is otherwise stable. If the patient is clinically stable but continues to have fever, there is no need to modify the regimen. If the patient, when the patient has a documented infection, treat as per the antibiogram. If the gram-positive coverage was started empirically, stop it after 2 to 3 days if there is no evidence of gram-positive infection. If the patient is having hemodynamic instability or the fever is persisting with worsening clinical signs and symptoms, then add a carbapenem. If not responding to carbapenem, then you can widen the regimen to cover CRA also. And empirical antifungal coverage, this is considered only in high-risk patients with persistent fever for 4 to 7 days of antibiotics. And the presence of diarrhea or abdominal signs, always check for CF. The median time to defervescence for an initial spike of febrile neutropenia in hematological malignancies or stem cell transplant is 5 days, and in solid tumors is 2 days. When do we add an antifungal agent? An empirical antifungal agent should be added after 4 to 7 days of high-risk neutropenic patients, expected to have a total duration of neutropenia for 7 days, a persistent and a recurrent fever in whom the reassessment does not yield a cause. The choice of antifungal, it is either liposomal amphotericin B, echinocandin or azole. How do I choose my antifungals? If the patient is febrile, he is not on any antifungal prophylaxis, there is no obvious focus of infection, and echinocandin is preferred. If the patient is febrile with pulmonary nodules or infiltrates, and invasive mold infection is suspected, again a mold-active triazole or liposomal amphotericin B. If the patient is febrile and has already received antifungal prophylaxis, if the prophylaxis was initially with voriconazole or posaconazole, switch to liposomal amphotericin B. If the patient has received liposomal amphotericin B, then you switch to mold-active triazole plus echinocandin. If the patient has received an echinocandin, you switch to mold-active triazole and liposomal. Is there a role of dual antifungals? Yes, occasionally dual antifungals are used in the setting of a severe invasive disease in hematological malignancies and in those patients with profound neutropenia of less than 100. Preemptive antifungal therapy. We screen the patients with biomarkers such as galactomannan and beta-D-glucan but this is generally not used. It is generally suited for patients who are receiving prophylaxis with fluconazole. The duration of antimicrobial therapy. If the source is identified, the specific antibiotics for at least 2 weeks and until absolute neutrophil count crosses 500 and longer only if clinically indicated. If the source is not identified, the cultures are sterile. If the ANC has improved and febrile for 48 hours, if the patient is clinically stable, we can safely stop these antibiotics. If the neutrophils are less than 500, patient is febrile for 3 to 7 days, resolution of signs and symptoms of infection, you can switch the patient to an oral fluoroquinolone until the absolute neutrophil count crosses 500. In the setting of HST, broad spectrum antibiotics generally suppress the gut microbiome, so this increases the risk of GVHD in transplant patients, so there is an argument between the use of antibiotics. Catheter removal and antibiotic duration. CVC is the likely source of bacteremia. If the blood cultures are drawn from CVC, are positive at least 2 hours prior to the peripheral blood cultures. Catheter is only removed if the culture is positive for Staph aureus or aeruginosa or non-tuberculous mycobacteria, which is rapidly growing. In fungal infections, the catheters are not, it is recommended not to remove the catheter, but in my practice or in any practice, per se, people remove the catheter with patients with fungal infection with biological plausibility that this could be a serious thing. Antibiotic duration is for 14 days. In some conditions, 4 to 6 weeks of antibiotic therapy is advised if the CVC associated infection is complicated or the patient has developed endocarditis, septic thrombosis or a deep tissue infection. Prophylaxis of neutropenic patients is generally advised because to prevent the febrile neutropenia. Antibacterial prophylaxis is advised to patients with neutrophils of less than 500 with an anticipated duration of more than 7 days, with an absolute neutrophils of less than 100 patients who are undergoing LOHCT and acute leukemia infection. The drug of choice is levofloxacin 750. It is generally given until myeloid reconstitution has occurred. Antifungals are given with absolute neutrophils of less than 500 and more than 7 days. but the risk of invasive mold infection is more than 6%, then again mold active triazoles should be given. BCP prophylaxis and HSC prophylaxis are also advised. Secondary prophylaxis, a concept more valid for fungal infections, continue till myeloid reconstitution has occurred. Last slide. General precautions, hand hygiene should be followed. There is no need for any protective gear such as gowns, gloves or masks, but a standard barrier precautions have to be taken when they come with a bodily fluids or blood. The stem cell transplants of the neutropenic patients should be placed in private rooms with more than 12 air exchanges per hour and a HEPA filtration system. Plants or dried and fresh flowers should not be allowed. Hospital work exclusion policies should be created to encourage hospital staff to report their illnesses so that these people will not communicate those infections to the neutropenic patients. And avoid prolonged contact with environments that have high concentration of airborne fungal spores and neutropenic diet which has doubtful benefit. Coming to summary, febrile neutropenia is a medical emergency. Always watch out for the mucositis in urine catheters. The signs are subtle. High-risk patients do require IV antibiotics and inpatient. Empiric antibiotic therapy within 1 hour. Follow an algorithmic approach to antibiotic therapy. Antifungal therapy in non-responsive cases. Myeloid growth factors, better for prophylaxis than treatment.
Antibiotic lock therapy, cases where you want to salvage the quick line or the chemopole. They've been using antibiotic lock therapy and successful has been
antibiotic lock therapy is still a very big dilemma. It is generally given for patients when you suspect them to have fevers because of the lines. So the patient is getting an IV infusion and he still develops chills and virus. We try to do that. It can be tried, sir. This is like a therapeutic trial. You stop using the line, you put an antibiotic lock. So if the fever subsides, then most likely the cause of infection would be a central venous catheter. It can be tried. It is of doubtful benefit. If the antibiotic is really working with that lock, then the patient should receive that antibiotic through the same line.
Nice presentation, sir. So I just want to know what is the role of procalcitonin and febrile neutropenic patients which have the same significance as other sepsis patients?
Sir, procalcitonin I think has a very good role in patients who are non-neutropenic or immunocompetent patients, and its main role is to role in de-escalating the antibiotic rather than hiking up an antibiotic. In neutropenic patients, there are no studies first of all, and even whatever retrospective studies that have been conducted have shown that procalcitonin per se does not play a major significant role in deciding the type of antibiotic or reducing the antibiotic in neutropenic patients. Questions from audience? Sir, that's an idealistic guidelines because of flowers they have these fungal spores, so that is the reason other than that.
Okay. Thank you for the next presentation, sir.
Now I request Dr. Lakshmikant Reddy sir to felicitate Dr. Sthitaprajna sir. Now I request Dr. Satvik Raghuram sir to facilitate Lakshmikant Reddy sir. Now I request Siddhaprajna sir to facilitate Satvik sir. The next topic is adult vaccination, who needs what and when. The speaker of the session is Dr. Mithil sir, Consultant General Physician, Medicover Hospitals, Dr. Sirisha ma'am, Family Physician from Omega Clinic, Dr. Raj Manohar, Consultant Pulmonologist, Medicover Hospitals. I would request them to chair the session.
Hello, welcome. I am Dr. Mithil, Consultant Internal Medicine, Medicover Hospitals. Today we will be speaking about adult vaccination, who needs what and when. In today's session, we will see what is the importance of adult vaccination, what is the need for adult vaccination, what are the barriers for adult vaccination. We will see CDC recommendation for this year 2023, what are the recommendations. We will see about individual vaccine and what is their update in 2023. And we will look into Indian guidelines also. So let's start. So immunization through vaccination is a milestone achievement to public health, historically aimed for to protect the children. However, vaccine preventable disease can have significant impact on adult mortality, health and quality of life. Despite this, adult vaccination have been overlooked in favor of other health priorities because their benefits in the society were not well recognized. Adult immunization is the most ignored part of healthcare services in India. Importance. Vaccination prevents the disease and their consequences. It maintains the productivity by keeping the individual healthy and by thereby reducing the absenteeism from work. It protects not only you, it protects the vulnerable population around you like infants, pregnant women, older population, thereby reducing the risk of transmission of disease. It has a long-term benefit also, some certain vaccine like HPV, human papillomavirus vaccine, that can protect us from cervical cancer. It reduces the healthcare cost not only from individual pocket but total as a burden over the healthcare system. And it has global health implication also. By increasing worldwide vaccination, we can curb the disease and thereby eradicate the disease or at least control the disease, as in polio case. So this is the data regarding vaccine preventable disease. Vaccine preventable disease means any disease for which vaccine is available. So 50,000 adults die from vaccine preventable disease annually worldwide. 13,000 cases of influenza were reported in 2017, H1N1 pneumonia. The date is 2,270. WHO says 2 to 3 fold higher prevalence of diphtheria and tetanus in India.
we have almost 60% of diphtheria cases and 40% of tetanus. And adults are 350 times more likely to die each year from vaccine preventable disease than children. Cervical cancer is the second most prevalent cancer in India now, and we are the capital for cervical for the entire world. So every year 1.23 lakh new cases are recorded and 77,000 deaths are reported. In 2018, the incidence rate of pneumococcal disease in India was 22.7% in age group 44 to 60. And everyone knows about the COVID. The COVID death was reported as 5.31 lakh till now. It was the official data given to WHO. We know it is more than that. So let's see, in this slide you can see the graph. The immunity graph is shown the orange thing. The immunity, it's well developed in the adulthood, and once we go to older age, the graph is going down because of our less immunity. That phenomenon is called as immunosenescence. Once the immunity goes down, you can see the infection risk shown by blue chart, it is going up. So in this chart, two vulnerable population, infant, child group and adult group is there, but infant group is well protected by structured immunization program. There is a vaccine coverage is good and high awareness is there. That's why the vaccine preventable disease is less in this group. Compared to adult group, there is a low awareness, negligible vaccine coverage is there. What is the need for adult vaccination? Many adults, they miss vaccination series in the childhood. There are many new vaccines available, especially for adults. No long-term immunity after childhood vaccine. The immunity fade over a period of time, so you require booster dose. Chronically ill adults are more susceptible to vaccine preventable disease and their consequences. So, comorbidity is one factor. Change in the demographic profile in both countries, like India also, it's moving toward the elder population. You can see in this graph, this is India's graph. By 2036, we will have almost 27% of elderly population, that is 1/4. And infectious disease is also moving toward the adulthood. And a lifestyle factor also plays the role. One who is traveling, occupational health hazard, and who is engaged in the high-risk behavior. So what are the barriers of vaccination, adult vaccination? There is a lack of surveillance, there is no data, because if there is no data, we don't have proper information about the cost effectiveness of vaccine. So we can't form the concrete national guidelines. We don't have national guidelines. Lack of coordinated adult immunization program, lack of recording system, missed opportunity of vaccination. We should incorporate vaccination into regular checkup. Cost is always factor in India. Lack of provider recommendation. As a physician and primary healthcare provider, they are not giving the recommendation for vaccination. Treatment taking precedence over the prevention, lack of knowledge, recognition of benefit, efficacy and safety, and vaccine hesitancy because of cultural belief, religious belief. So this is CDC Advisory Committee on Immunization Practice. They give step-by-step guidance on how to approach for adult vaccination. So first is you have to assess the vaccination requirement according to age, then assess for any additional vaccine requirement according to medical condition, then you have to see the vaccine types, frequency, interval and special condition and any contraindication. So this is CDC's 2023 recommended chart for adult immunization schedule for age 19 years and above. Before going to this chart, let's understand color code. Yellow means you have to give vaccine once they meet the age requirement. Purple is if any additional risk factor is there, then you have to give it. Blue means shared clinical decision making, and grey means not applicable. So you can see there is no surprise. COVID-19 has made in the top row across all the age groups. So it has to be given in all age groups. Influenza also has to be given in all age groups. So I just simplify this chart according to this age basis. Everyone must get flu vaccine, COVID vaccine, Tdap and hepatitis B vaccine. If 26 years and younger, HPV vaccine, 50 years and above, zoster vaccine, and 65 above, pneumococcal vaccine. This is according to medical condition. Here 2 more colors are added. One is red. Red means contraindicated, and orange means precaution. So you can match the vaccine according to medical condition and it has to be given. So COVID is yellow throughout all medical conditions, so it has to be given in all people. Let's see, for example, pregnancy. So COVID influenza has to be given. Then it's all live vaccine are contraindicated in pregnancy. So MMR and varicella is not recommended. You can find out asterisk marks also there. It means that it can be given after pregnancy. Hepatitis B is recommended. Hepatitis A is when some extra additional risk factor is there, then it has to be given. So let's see each vaccine one by one. COVID vaccine. So COVID vaccine, everyone has taken the COVID vaccine, but now updated vaccine has came in USA. There is no, originally is monovalent, now updated is called as bivalent vaccine. So the now recommendation is that everyone must get one updated COVID vaccine. This updated COVID vaccine contains original Wuhan strain plus Omicron BA4, BA5 strain. So recommendation is for every adult one updated dose of COVID-19 vaccine, irrespective of their original COVID-19 schedule. For elderly people 65 and above, 2 doses has to be given, and 4 months apart. And one who is immunocompromised, 2 doses 2 months apart. Our government stand is that at present we don't require updated COVID vaccine because we have hybrid immunity. Saying though, biological key company and Bharat Pharmaceuticals, they are making updated COVID vaccine in India now. They are in the trial. This is the new COVID vaccine developed just launched 1 month back. This is India's first mRNA vaccine, booster vaccine against Omicron specific vaccine. It has to be given intradermal. The dose is 0.1 ml. And it is recommended for individuals 18 years and above. Hemophilus influenza type B vaccination. There is no change in this recommendation. Anatomical and functional asthenia, 1 dose is recommended. If electrosplenectomy is planned, 1 dose has to be given 2 weeks before. And in bone marrow transplant, 3 dose series has to be given 4 weeks apart, irrespective of your vaccination history. Meningococcal vaccine, meningococcal ACWY vaccine. It has to be given in special scenario, anatomical functional asthenia, HIV infection, persistent complement component deficiency, complement inhibitor like eculizumab, ravulizumab. Use 2 dose series, at least 8 weeks apart, and revaccinate every year, every 5 years if risk remains. Travel to endemic country like travel to hyperendemic zone like sub-Saharan belt, that is called as a meningitis belt. If you are traveling to that area, you require 1 dose of this vaccine and revaccinate every 5 years. Person who is traveling for Hajj Yatra and this is the vaccine is mandatory. And first year college student who lives in the residential housing, 1 dose of this vaccine is recommended. This is now meningococcal B vaccine. It has to be given in anatomical functional asthenia, persistent complement component deficiency, same as the meningococcal A, complement inhibitor, and microbiologists who routinely works with this bacteria. So the 2 dose primary series is there mainly, that is Bexero, 1 month apart, and 3 dose primary series, Tumimba, 0, 1, 6 months. These 2 vaccines are not interchangeable. And in pregnancy, you can give it one if a precaution is there. If risk is means benefit is more than risk, then it can be given. And now Sanofi is making pentavalent vaccine. It contains all A, B, C, Y, W. It is in trial phase now. So hepatitis A vaccine, routinely not recommended, but one who has a risk factor like chronic liver disease because of any cause, HIV infection, men who have sex with men, IV drug abuser, it can be given. The dose is 1 ml intramuscularly, and it has to be given 6 months apart. Pregnancy, if risk of infection is more, you can give it into pregnancy. Now the hepatitis B vaccine, now next two vaccines are the vaccine which can prevent cancer. This new vaccine is developed, Hepatitis B. It is FDA approved in 2018, and it contains novel adjuvant CPG. So it immunes better immune response to the population. So it has shown a superior seroprotection rate 90 to 100% compared with the current vaccine, which is showing 71 to 90%. And its response is good in vaccine poor responders such as older adult, diabetic, and those with CKD. So the dose regime is simple, only 2 doses. This is the first vaccine which can be given in only 2 doses and 1 month apart. The dose is 0.5 ml. This is another vaccine developed last year. It is approved by FDA. This is 3 antigen hepatitis B vaccine, contains S3, S1 and S2. The seroprotection rate in this vaccine is also very good compared to the currently vaccine we are using. So the dose is same 0.5 ml, but in 3 dose series 0, 1 and 6 months. So recommendation. So last year 2022 CDC recommends every adults 19 to 59 must get hepatitis B vaccine. For 60 and above, when risk factor is present, you have to give the vaccine. Like liver disease, HIV, IV drug abuse, risk for exposure, blood, sexual diseases, and anyone above 60, if they want to take the vaccination without risk factor, they can take it. So there is series are there. What vaccine you are using? The Hepatitis B is in 2 dose series, 4 weeks apart. Injurix B, Pre-Hevbrio, Recombex, HB, it is in 3 dose, 0, 1, 6 months. And there is an accelerated series is also there for hepatitis B vaccine, 0, 7, 21 days and followed by 1 booster at 12 months. This new vaccine is not recommended in pregnancy because of the lack of safety data at present. And in special scenario, in a patient who is on hemodialysis, 4 dose series regime of Injurix B, that is 0, 1, 2, 6 months, and the dose is 2 ml, not 1 ml. The dose is 11, that is 40 microgram. So HPV vaccine, the first is this vaccine can be given in both men and women. This is gender neutral vaccine. So it prevents against cervical cancer, vaginal, vulvar, penile cancer, anal cancer, oropharynx cancer. So first vaccine was Cervarix. It was active against 16-18 strain, which is most common for causing associated with 60 to 70% of cervical cancer. Then came the Gardasil 4, that is pentavalent vaccine. It is active against 6 and 11 in addition to 16-18. 6-11 strain is responsible for anogenital wart. And now came the HPV 9, Gardasil 9. It is active against 31, 33, 45, 52 and 58. These are additional types. So it covers 20 to 25 further cervical cancer associated with this strain. India has indigenously developed now HPV-4 vaccine, quadrivalent vaccine, and it will be rolling in the government sector soon. And in the USA now there is only Gardasil 9 is available. So the schedule is that it should be started before sexual activity begins. So it should be started at 9-year age, 9 to 15 year, 2 dose series is recommended. And in 15 to 26 year, 3 dose series, 0.5 ml intramuscularly, 0 to 6 months. It is not recommended in pregnancy. And now this recommendation has extended for vaccinating adult for age group 27 to 45 in 2019. So vaccination is not recommended for everyone older than age 26 because in this age provide less benefit as more people have already been exposed to HPV strain. Some adults in this age group can decide to get HPV vaccine based on their discussion with clinician. So this is shared clinical decision making has been recommended for this age group. influenza. So these are the WHO recommendation composition for 23-24. For northern hemisphere, 2 influenza A virus types is there, and 2 influenza B type is there. For southern strain, this Wisconsin strain is replaced by Sydney strain. Rest everything is same. So we in India we have usually 2 peaks of influenza. In Western world it's and temperate climate countries. They are usually having in the winters month. So the ideal time for there is at the end of October. But we have 2 peaks. One is in the rainy and one is in January and March. So better to give it April end. But this influenza activities throughout the year. So whenever the vaccine is available, you should give it. So in the elderly population, even after giving these vaccines, they have found that there is a lot of hospitalization is still there and death mortality is also there. So in last year, 2022, CDC recommends that higher dose or adjuvanted flu vaccine has to be given in 65 and above group. Higher dose means it has 4 times higher antigen compared to the standard dose, and adjuvant means it's a substance that that boosts your immune response. If any of the vaccine is not available, you can use standard vaccine. So everyone requires 1 dose, 0.5 ml IM, influenza vaccine, and 65 year above, the high dose is the dose is 0.7 ml intramuscularly. If someone has egg allergy, only hives are present, then it can be given safely. If it has some other complications like anaphylaxis, respiratory distress, then it has to be given under supervision. The one who is in close contact with immunocompromised people, who is taking care of immunocompromised people, they should not take live attenuated vaccine. If someone is taking live attenuated vaccine, they should avoid contact with such patient for 7 days. This live attenuated is nasal vaccine. The dose is 0.2 ml, 0.1 ml in each nostril. But someone who is not popularized in India because safety is there, but efficacy is same as compared to intramuscular injection. So this is the dose, 0.7 ml. Now for pneumococcal vaccination, new drug came up. In 2021, PCV20, that is Prevnar 20, has been came up, and it protects against the 20 serotypes of pneumococcal. This is recommended as a single dose only. So usually pneumococcal PCV is given followed by PPSV 23, but in this regime, only single dose has to be given. So the compliance is good in this case. So who should get the pneumococcal vaccine? Everyone above 65 and 19 to 64 with certain risk factor like immunocompromised, CSF leak, cochlear implant, HIV, all chronic diseases like liver disease, heart disease, lung disease, kidney element, alcoholic and cigarette smoker, they should receive this pneumococcal vaccine. So this is the schedule I simplified in a way. So PCV20 in single dose has to be given, and there is no need to follow the DPSP3. There is other vaccines also developed in 2021, that is PCV15. What we have at present in India is 13 and PPSV23. PCV20 at present trial is going on, so it will be available in India most likely in 2025. So one who has not taken any vaccine, any dose of pneumococcal vaccine, option A is just give PCV20, or option B is PCV15 followed by PPSV23 after 1 year in immunocompetent patient. If immunocompromised, give it after 8 weeks. Previously received PPSV23, after 1 year you can give PCV20 or PCV15. And previously received PCV13, after 1 year you can give PCV20 or PPSV23. And someone who has completed their schedule, PCV13 or PPSV23 in any order, so after 1 year you can take PCV20 or after 5 years you can take PPSP 23. Polio. There is not routinely recommended this vaccine for adults, but last year they found one case in New York, and the recommendation from this year that the one who is at high risk, they must take one booster dose of IPV vaccine. MMR vaccine, unvaccinated adult needs 2 doses of vaccine 4 weeks apart. Women of childbearing age who are not pregnant and who has no evidence of immunity should take at least 1 dose of MMR vaccine. Now these are 2 new recommendations. Additional dose of MMR vaccine has to be given in case of mumps outbreak to high risk group. And vaccine consideration for healthcare persons 65 years and above. Tetanus, diphtheria, pertussis vaccination. Every 10 years you must take booster for Tdap. And someone who has not taken primary series, the series can be completed in 3 doses. First 2 doses 4 weeks apart, and then third dose is after 6 months. In the pregnancy, 1 dose is recommended in third trimester, 7 to 36 weeks, and this is the only national guidelines we have at present that TT has to be given in every pregnancy. And in wound management, for clean and minor wound, administer Tdap if more than 10 years has passed. For all other wounds, administer Tdap if more than 5 years since last dose of Tdap. Varicella vaccination. If there is no evidence of immunity due to series dose 4 to 8 weeks apart, evidence of immunity is when someone is having varicella, history of varicella or herpes zoster, and lab evidence of immunity of disease. It is contraindicated in pregnancy, and if you have to give it after pregnancy is. And in HIV infection, it has to be given when the CD4 count is more than 200 for consistent 6 months, then it has to be given. Zoster vaccination. So herpes zoster is also common among the elderly people. The lifetime risk is 10 to 30%, and it increases to 50% those who are living 85 years and above. It comes with many complications like herpes zoster ophthalmicus, herpes zoster otitis ophthalmicus. The vision can be lost, vision complication is there, and 10 to 18% people will have post-herpetic neuralgia. This is a chronic pain lasting for months to years. So the new vaccine came, Shingrix. It is recently available in India also. So first was the Zostavac vaccine was there. It was live vaccine. So the efficacy was less, and the problem is that it can't be given in immunocompromised patient. So that's why the Shingrix came into picture. It was approved by FDA in 2017. It contains subunit vaccine that contains recombinant varicella zoster virus, glycoprotein E in combination with novel adjuvant. It does not contain live virus, and dose is 0.5 ml intramuscularly separated by 2 to 6 months. The efficacy is 97% in preventing shingle and 91% in preventing post-herpetic neuralgia. So the recommendation is that all immunocompetent patients above 50 years, we need to take one booster vaccine. This is the recommendation made in 2018. And that recommendation is extended in 2021 for immunocompromised group 19 years and above. So the dose has to be can be given as early, second dose can be given as early as 2nd month. Pregnancy, it is not recommended. The Mpox vaccination. Recently there is outbreak last year in 88 countries. So from that, this recommendation came this year. Post-exposure prophylaxis for people with known or presumed exposure to Mpox virus within 14 days of exposure. If it is given within 3 to 4 days, we can prevent the disease. And if it is given within 14 days, the severity can be reduced. And pre-exposure prophylaxis, people at increased risk of exposure or means high risk group who is engaged in high risk, and people who are requesting for vaccination. So the vaccine that was recommended was Gynu. It was approved in 2022 by FDA. So the dose is 2-dose series for a person aged 18 years and above who is at risk for Mpox during the Mpox outbreak. The dose is 0.5 ml. It has to be given subcut. It can be given intradermally also. Now the new vaccine came, this respiratory syncytial virus. In 2021 in US there was triple epidemic was going on, COVID, flu and RSV. So FDA approved just in the May month two vaccines, that is GSK Arexvy and Pfizer Abruzio. Both approval has been given for adults 60 years and above. The dose is 0.5 ml intramuscularly. It risk is reduced by 82.6% and severity is reduced by 94.1%. So just 15 days back, CDC endorsed the recommendation which calls for shared decision making on June 29. Means whether your clinician is suspecting if you are at risk for this virus, then vaccine has to be given. This is a chart I made just for in a simple word for pregnancy, what has to be given. In pregnancy, TDAP and COVID-19, flu, hepatitis B. For healthcare worker, COVID-19, chickenpox, TDAP, flu, hepatitis B, meningococcal vaccine for microbiologists, MMR, HPV vaccine, shingle vaccine. Vaccine for travelers, it has to be better to be given by before 4 to 6 weeks. And this topic will be covered by my fellow colleague Dr. Nanda. These are the end-stage renal disease, COVID-19, flu, TDAP, pneumococcal vaccine, hepatitis B vaccine. They may require chickenpox, shingles, and MMR based according to age and above. Diabetes, heart stroke, lung disease. This important is COVID-19, flu, TDAP, pneumococcal vaccine. May require chickenpox, HPV, shingles, hepatitis B vaccine, MMR. So this is the EPA guidelines from adult immunization. They have given in 2021. So DPT, MMR, influenza, pneumococcal, varicella, HPV vaccine and booster vaccine. These are the various recommendations by various medical society in India. So we don't have national guidelines. Every society is following their own guidelines. IMA guidelines, Society of Nephrology guidelines and FOXO guidelines. So in the conclusion, adult immunization is the need of our. It is a critical aspect of public health and it prevents the spread of disease. It benefits the society by preventing the transmission of disease to vulnerable population, reduces healthcare costs, and it is important for adults to stay informed about what vaccine has to be taken to prioritize their own health and the health of those around them. So by giving adult vaccination, we can save at least millions of lives in India alone. Thank you.
It's a very elaborate answer on adult vaccines, which is missed by most clinicians. I have a question. India being a diabetic capital of the world, young adults in 30s, 40s with diabetes HbA1c 7, 7.58, do you consider them immunosuppressed in general, or do you prefer any vaccines for that profile of patients? If yes, what are the candidate vaccines?
ACIP has given one who is a diabetic this recommendation is there for them. It is irrespective of whether your HbA1c is controlled or not controlled. One who is diabetic, they are at risk and they should follow this vaccine. So this vaccine, COVID-19, flu, TDAP and pneumococcal vaccine, it has to be taken. They have not mentioned anything about the control of HbA1c.
Thank you for the elaborate presentation. Sir, I have one question. What is the duration of avoidance for pregnancy when we give MMR vaccine for preconception care?
At least 4 weeks before it has to be given.
Because we usually in general practice we say 2 to 3 months is recommended to avoid pregnancy before the vaccination. Thank you.
Regarding with the hepatitis B vaccine, usually it is given by mistake, it's not used subcutaneous. That's the case.
See, the vaccine has to be given intramuscularly when it is recommended. If someone has given subcutaneously, the local reaction can increase, like skin irritation, skin discoloration, granuloma formation can increase, And especially still the vaccine if given subcute, means if it is intended to give intramuscular and if it is given subcute, the vaccine dose is still valid. But certain vaccine, like when you are saying hepatitis B vaccine, if it given subcutaneously, it is not valid. You have to repeat the dose. So hepatitis B vaccine, rabies vaccine, HPV vaccine, they has to be given intramuscularly. And one more thing I want to highlight here. The vaccine has to be given in deltoid region. Give it in deltoid, don't give it in the gluteus region. When some vaccines are given in gluteus region, many times they are considered invalid. So try to give it in deltoid region.
Hello. So all vaccines should be given in deltoid region. All vaccines.
Yes.
All vaccines.
All vaccines.
One more question is that in females, especially in girls, in 11 to 13 years, HPV is one dose is given. HPV vaccine. Above 15 years, in between 15 to 21 or 25, 2 doses are to be given. Can you please explain that?
The CDC ACIP recommends 2 doses for 9 to 15 and 3 dose series for 15 to 26. It is not single dose series. Now the study is going on, that coming to your thing, that study is going on, the paper has also given to WHO whether single vaccine dose can be effective for population. So that study is still going on, that WHO expert panel studying that, and sooner we'll get the recommendation on that also. But 9 to 15 age group 2 doses and 15 to 26 3 doses are recommended. See, rabies vaccine, the pre-exposure prophylaxis or post-exposure prophylaxis, dose series is 0, 3, 7, 14 and 28, and one booster can be given at 90. Pre-exposure is 0, 7 and 28 days, 0.5 ml intramuscularly. If the food if it's in the category 3, that means blood is coming out or oozing is there, mucosal break is there. So then rabies immunoglobulin has to be given in addition to vaccine. The dose is 20 IU per kg.
So what about the duration and spacing? Does the CDC recommend, suppose the schedule is missed by a... What about the duration specificity? If the schedule is missed, does the CDC recommend any changes, or are there any guidelines regarding the scheduling?
Yeah, see, that's to be taken on set schedule. But if someone has missed, no need of starting revaccination or extra dose. You have to complete as soon as it is possible. No need of extra dose or revaccination.
One question from me. Before the policy changes and the policymakers make adult vaccination as mandated as pediatric vaccination, as the healthcare providers, what we can do in corporate and individual clinics to make sure our adults get all the vaccinations done. What is your thoughts on it? How, as a healthcare providers, we can take a lead on this?
So, first thing is that when a patient visits us, we should make them realize that the vaccination requirement need is there. We should prime them regarding these vaccines are there. Because we are not giving them suggestion, that's why they are not also taking. So this is required. When the patient comes, we should tell them these vaccines are available for your age group, and we should take it because the risk factor is there, mortality, morbidity is there. So this is the first thing we should do it. Another thing, we should advertise or publicize this thing, adult vaccination, more to have more awareness. The HPV, last when it was recommended that HPV 2019, the recommendation came, it was in the radio also. This vaccine is available for this age group. So we need to publicly address this issue. And whenever for individual level, when patient comes, we should give them guidance that this vaccine is available for this age group, and we should incorporate this in our regular checkup. that this vaccine is there and you have to take it.
Maybe like in pediatric vaccines, we should have it as mandatory and we should use in the clinic.
We should also make chart like that, and they should be encouraged to take this vaccination.
Maybe we can use YouTube also. Maybe we can use YouTube also.
Absolutely, absolutely.
In our practice in our hospital, we see many patients come for traveling abroad. They get that visa papers or some papers stating that vaccinations are mandatory for them. And they are not sure whether they have been taken the vaccine when they were kids. They don't have any documentations available. In such scenarios, for few vaccines, we repeat the titers. But what if the titers are not there? How do you assess them?
See, if someone has who has not remembered whether they are taken vaccine or not, it is considered as they are not taken vaccine. If there is no documentation available, then you have to vaccinate such patients. Simple word. If someone, as you say, titers are there, if titers are good, means they are already vaccinated. If there is no documentation, then you have to give the vaccine.
And in this only, sir, is there any vaccine which the government only should give? Private practitioners are not allowed to give that.
That is one is yellow fever vaccine. There is a designated centers. We can't give it in hospital. There are designated centers out there. You need to go there and you need to take it. That way.
Thank you, sir.
Are there any specific guidelines for patients with multiple sclerosis who take prophylactic medication? They are not really, not actually immunosuppressed in the general sense, but their immunity is also partly suppressed. In your guidance, nowhere these things are mentioned. Any guidance are there?
No, the ACIP is not mentioned multiple sclerosis as immunocompromised or other. They should be treated according to various other age factors and risk factor. Multiple sclerosis as per se has not been.
Disease. Patients who are on immunosuppressants, those who are taking.
If someone is taking multiple sclerosis as such is not a risk factor. If someone is taking immunosuppressive drug, then they require vaccination.
Immunosuppression is graded. Interferon is a lower immunosuppressant compared to natalizumab and those higher drugs. Any specific guidelines for that?
See, if specific immunosuppressing drugs we are giving, then we have to consider vaccination in such groups. Not otherwise. Or otherwise, according to age, whatever vaccine is available has to be given.
I want to add a point to Sir's question. Patients who are on immunosuppression, especially those on hydrosteroids or protein immunosuppression like methotrexate, mycophenolate, you can continue the vaccination as per the schedule. Only killed vaccines, inactivated vaccines or conjugated vaccines. Lab vaccines are contraindicated. Suppose you are giving the T-cell depleting agent, still you can go ahead with the same vaccination schedule. If you are going with B-cell depleting agent like rituximab, then you have to give it gap of at least 6 months because the vaccine efficacy is not there. So give it period of 6 months after the rituximab, or ideally give the vaccine before then give rituximab. Because we have seen in some conditions, I'm not sure of multiple sclerosis, patients with RA and lupus, they usually fail. They tend to fail after vaccination. So we need to have a stable disease, then consider vaccination. Don't be in a hurry like we have a diagnosis, give vaccination. Because these are all immunological phenomena. Patients tend to fail in like autoimmune diseases and maybe multiple sclerosis.
Thank you.
I would request Dr. Haridada Krishna, sir, consultant urologist, Medicover Hospitals, to felicitate Dr. Nikhil, sir. Dr. Sirisha ma'am, Dr. Raj Manohar,
Dr. P. Sridhar.
As we are getting short of time, whoever wants to have a coffee or any snacks can get inside. And next topic is approach to neuroinfections by Dr. Vikram Kishore sir, consultant neurologist, Medicover Hospitals, which is chaired by Dr. Harinatha Krishna sir, consultant neurologist, Medicover Hospitals, and Dr. Shrikant Reddy sir, consultant neurosurgeon, Medicover Hospitals.
Good morning. I would like to thank the Department of Internal Medicine for giving the opportunity. So since there was a discussion about the vaccination extensively, which prevented most of the neuro infections, particularly in kids. So I was invited to talk on approach to neuro infections. It is difficult to cover all the neuro infections in a short time given, but I'll try to be as short as possible. So, to be precise, it can affect any level of the neuro axis, right from the meninges to the end organ muscle. So it can affect the meningitis, encephalitis, spinal cord, peripheral nerve, neuromuscular junction, and as well as the muscle. So when it comes to the brain infections, there is infection of the arachnoid matter, dura mater, and pia mater called as meningitis. If it spreads to the brain parenchyma, we call it as encephalitis. Cerebritis is again a brain infection, parenchymal infection in the early stage, which later, if not treated properly, can turn out to be an abscess. There are certain conditions called febrile lymphoma and epidural abscess related to the post-trauma. And coming to the spinal cord and as well as nervous system, peripheral nervous system infections, the spinal cord infections can be from discitis, then the vertebral body, then abscess causing some spinal cord compressions. So there can be infection of the spinal cord itself, which is called myelitis. Then that can involve either dorsal column, anterior horn cell, or the central cord syndromes. And the space between the spinal cord and the vertebral bodies, the epidural and the intramedullary, extramedullary abscess causing compression. And when it comes to the peripheral nerves, right from radicals to the nerves, to the neuromuscular junction, and even the muscles. So this is a spectrum of neuro infections. So pathogenesis, it's like again by multiple mechanisms like direct inoculation or host-related immunosuppression and then direct contagious spread or iatrogenic can lead to immune system activation leading to cytokine production, thereby changes in the blood-brain barrier if it is in the CNS system, or neuronal damage leading to increased ICP and then cerebral edema, causing the symptoms based on the location of the infection. So then how do I approach it? For any neurological disorder, for that any symptomatology, we do go by the history, which is most important, and then do a detailed clinical examination and relevant investigations to find out where is the lesion and what is the probable lesion. So coming to the history, it's again we have acute symptomatology, subacute, chronic neurological symptoms. Most of the acute and subacute symptoms are related to CNS infections, whereas chronic neurological symptoms are usually seen in spinal cord and as well as neuropathy related infections. Acute and subacute, most commonly they present with either headache, fever, altered behavior, seizures. So these point towards the CNS pathology. like meningitis, encephalitis, abscess. Whereas the subacute, they can present with low backache, with only having mild tenderness at the dorsal or lumbar level, with only just non-specific low backache. This can be the initial presentation, but sometimes we may miss that, thinking that it could be a mechanical pain. Later, if the patient develops any bladder symptoms or paraplegia or any asymmetrical weakness of lower limbs with sensory symptoms, we need to think of neuroinfections as one of the possible diagnoses. Whereas in chronic neurological symptoms, patient we have seen complaining with tingling and numbness of hands, with weakness of grip weakness, or sometimes having autonomic symptoms. So where we need to do a detailed examination to find out if there is any radiculopathy or neuropathy involved. Because these Hansen's disease, CIDP, mononeuritis multiplex disease, all can present with slow insidious onset of weakness and sensory symptoms. For all the symptomatology which pertains only to neurology, we need to think of associated signs and symptoms like skin rash, any history of head injury in the previous admission or previously, travel history, because there are few infections which are not endemic in the developed countries. If someone travels from India and then they come from US and then travel back to their country again, so then they get these infections which are there and prevalent in that area. Cattle exposure, heart diseases particularly, they are prone to have cerebral abscess, and then high risk behavior and drugs and then the transplant. Because in the drugs, like it was discussed previously, the patient who have multiple sclerosis, we give nadunolimab kind of immunomodulators. Those have made the people to develop certain neuroinfections like PML, which is because of JC virus, and even the post-transplant, like solid organ transplant or hematopoietic system transplantation. Post-transplant, if patient becomes drowsy or gets seizures, we need to think of atypical neuroinfections and high-risk behavior. And this is because most of this HIV and tuberculosis, they can affect the entire neuraxis. So the examination it starts with general examination. You need to look for skin changes if the patient present acutely with any encephalitis kind of or meningitis kind of picture, or subacutely or chronic having any weakness of a limb. Fundus examination is to rule out is done for all patients with acute meningitis or encephalitis to rule out any raised intracranial pressure. The signs of meningeal irritation to determine the neck rigidity, and detailed neurological examination based on clinical history, like if patient complains of low backache, then having asymmetrical weakness of limbs, we need to think of choroid vena or Brunner syndrome, or if patient comes with ulnar neuropathy kind of thing. We need to look in detail about the nerve involved, the muscles involved, so that we come to an appropriate diagnosis. So these are the few skin manifestation of infectious diseases. The first one is hypopigmented patch, most commonly seen in Hansen's. Because patient might not be aware of these pigmented patches until unless we examine and we ask them. And there is a hypothesis of this patch, and if we see this kind of patch presenting with some neuropathy presentation, we need to definitely rule out Hansen's. And the extremities having this kind of petechial rashes, Rocky Mountain fever, and then dysuria, and then syphilis. And this blister kind of presentation seen in oral mucosa or dermatomal distribution, which can point towards herpes simplex virus or varicella zoster virus. And this is a target skin lesion, which is seen in Lyme disease. And this is routine, the last one is the routine petechial or thin blanching, usually seen in most of the viral infections like dengue, arbovirus, enterovirus, etc. And coming to the eliciting of the signs of meningeal irritation, we do have two clinical signs. One is Kernick sign and Brugsch scan. In Kernick's, we ask the patient to lie supine, and then knee is flexed to 90 degrees, and then hip is flexed, then extended. Extension of the knee causes pain in the back and the difficulty in extension as well. Whereas the Brugsch sign, there is passive flexion of once we do the passive flexion of the neck, that can elicit pain and as well as hip and knee flexion. These are highly specific but low sensitive, difficult to perform and difficult to interpret in patients who are on ventilation or who are elderly, like more than 65 years, or sometimes with infants. So with having a proper clinical history and then examination, if it points towards any particular pathology, or if you divide it into CNS infection, spinal cord infection and neuropathic infection, based on the clinical picture and the examination finding, we tailor our investigation or diagnostic testing to find out where is the lesion and what is the lesion. Routine investigation for these CNS infections, we do for the fever profile, look for ESR, look for CRP, and in a dengue season we look for dengue, IgM, and then for this leptospira, all those things. Those all come under routine investigations. Brain and spine imaging is done usually to find out whether the meninges are inflamed or is there any brain abscess. The spine to look for any discitis, abscess, or even myelitis. CSF analysis is a very important tool which, if done carefully and then interpreted carefully, it can give a lot of information. And then microbiological diagnosis. This is to have some sensitivity pattern sometimes, or to identify the organism to tailor the antibiotics. Now, conduction test and EEG are limited only for few neuroinfections. If patient we suspect of any neuropathy kind of presentation, we go for nerve conduction studies to look for the pattern of the nerve involvement, whether it is axonal neuropathy, demyelinating neuropathy, or if it is a mononeuritis multiplex, etc. And EEG, we have some relevance in few neuroinfections like herpes simplex virus, where we have temporal discharges, or in cases of like SSP, where we have periodical discharges, we call that as the red complexes. So in neuroimaging, we do conventional MR sequencing, usually with contrast, because most of these infections enhance with the contrast. So the pattern can be of ring enhancing lesion, pattern can be of basal ganglia, SOLs, or simple grey matter hyperintensities or white matter hyperintensities. If it is a ring enhancing lesion, we need to see whether there is a blooming artifact. If so, think of fungal etiology. If there is diffuse restriction, then if it is a central restriction, probably a tubercular or bacterial. If it is only peripheral restriction, think of fungal. If not still clear, then go for spectroscopy. That can clear things like having a fungal thing, bacterial, or tubercular, and sometimes even malignancy can be picked up. Then coming to the basal ganglia lesions, these are most commonly seen in HIV opportunistic infections. So that can be seen as lymphoma, tuberculoma, cryptococcal, or even you have a toxoplasmosis. Then the grey matter hyperintensities, usually we come across commonly is HSV encephalitis. Typical predilection towards medial temporal lobe can be unilateral or bilateral. If it is basal ganglia or thalamus is involved, commonly is Japanese encephalitis. And if it is like Prions disease, CJD, it will be basal ganglia and pulmonary hyperintensities. Whereas white matter things, most common is HIV, and then PML, it can have asymmetrical periventricular white matter hyperintensities. So these are some of the images which can show optochiasmal and then basal exudation in one of the slide, and then ring enhancing lesion in cerebellum, one of the thing, and then meningeal or leptomeningeal enhancement in first line. There is difference between meningitic enhancement. The first one is showing the pachymeningitis, where the outer layer of the meninges are enhanced. And the second one is showing the leptomeningeal enhancement. The other important tool to diagnose central nervous system infections is CSF analysis. There is a debate that whether to do it in supine position or in a lateral position. If you want to check pressure, it is always left lateral position. If pressure is not needed, you can go for a supine sitting position. Then the sampling timing is most important, because most of the times we advise CSF to get in the morning, but because of the logistic reason, they do tend to go in the evenings and then send the labs. By the time the lab will be closed, they need to prepare the slides and all those things. The time lost in that will have an impact on both microbiological and as well as the biochemistry analysis of CSF. Like cells may be depleted or there can be abnormally low or abnormally high proteins. So the ideal time is like once the CSF is done, it is as early as possible. A pathologist or biochemist does the investigation in time. It will like not more than 1.5 hours. And checking blood sugar, ideal time is 1 hour before the procedure if you are going for an RBS. And if you want to do just check by the machine, you can do it at the time of procedure. The normal CSF is clear with specific gravity of 1.006 to 1.007 with opening pressure not more than 20. No RBCs, no 0 to 5 WBCs, preferably lymphocytes, proteins should be less than 40. Sugar should be like 2/3 of the blood sugar. If there is any abnormality, then what it could be. If the cells are more than 100 with more polymorphonuclear nucleotides like neutrophils with more than 500 cells with low glucose, it points towards the bacterial meningitis. And viral meningitis, the sugars may be normal, proteins may be normal, cells around 100, mostly lymphocytes. In tubercular, proteins will be more, glucose will be borderline or less, cells will be around 1000, and most of them are lymphocytes. And this, it may not completely give a picture sometimes because in a partially treated, there can be lymphocyte predominant if you do after a few days of antibiotic administration. Coming to the microbiological diagnosis, you go for either staining, CMV staining, gram staining, and then Indian preparation for fungi, culture and sensitivity, PCR based assays, and the new pathways like metagenomic next generation sequencing, where they have a genomic library of all the available viruses so that they match with the available viruses and then come to a diagnosis of newly or unidentified microbes. So this is sometimes PCR is mostly useful for viral illnesses, less sensitive for cryptococcal. Cryptococcal antigen is more sensitive for cryptococcal infection rather than PCR. And serology like IgG and IgM are more sensitive for arboviruses, VZV, Lyme's and neurosyphilis. And we have a multiplex PCR, it's like broad-based PCR which does identify like more than 8 to 9 bacterial and viral and then 4 fungi. This is a new thing like metagenomic changes where they identify the prevalence of uncharacterized or emergent or novel microbes. This is the EEG which is seen in a patient who had herpes encephalitis. Typically involves immediate temporal lobe. Here the patient had left temporal lobe hyperinterstice and then left temporal spicular discharges. So with that it is like we have see a patient with clinical history and then examination and then based on the tailored investigations we have come to a conclusion that whether it could be a central nervous system infection, meningitis, encephalitis, abscess, or spinal cord infection, or a nerve-related infection. So meningitis, it is just information of meninges, dura mater, arachnoid mater, and paramater. If dura mater is only involved, it is pachymeningitis. If it is arachnoid and then paramater, it is leptomeningeal. And we need to rule out certain non-infectious inflammatory causes of meninges, where we do some autoimmune tests and then rule out that. So the tetrad of symptoms like fever, headache, neck stiffness, and altered behavior is seen in only 40 to 45% of people who have meningitis. But headache is seen in 50% and then fever in 85%. They can also present with seizures, stroke, hydrocephalus, and cranial neuropathy. Then, see if the patient comes with acute history of headache, fever, and then altered sensorium, we think of meningitis. If there are certain things which can last for more than 4 weeks, then we categorize them into chronic meningitis. And this chronic meningitis population, mostly they have either fungal or tubercular infections. Then we need to see whether they are immunocompetent or compromised because the spectrum of infections are little differently immunocompromised. Look for skin rashes and also signs of major irritation. CSF analysis and microbial isolation is needed. So fundus is usually enough to do before to check the raised ST before lumbar puncture. It is a neurological emergency because because some infections can be fatal. So we can do it empirically and go for the CSF test. You can incubate up to I think 1 to 2 days even after giving the antibiotic, but that will not going to change the CSF pattern of analysis. Commonly what we see is the tubercular meningitis. Tuberculosis is one disease where it can affect meninges, parenchyma, cranial nerves, spinal cord, nerves, radicals, probably not muscles and neuromuscular junction. The presentation can be acute, subacute or chronic. So there is a beginning of the attack of the infections. These are the people who have more complications compared to other infections. Because they can have very locally, if there are a lot of applications or accidents around the disease, then can cause to meningitis and arthritis, leading to hydrocephalus, sometimes those because of vasculitis. This can occur without pulmonary involvement. Coming to the clinical part, it is different from pulmonary tuberculosis because of the extended disease. Maybe sometimes requiring 1 year. It can be about till 2 years as well. Overall period, you need to see that if the patient is not having tuberculosis, whether it is tubercular meningitis, encephalitis, abscess or even tuberculosis. Coming to encephalitis and abscess, encephalitis is life-threatening sometimes. These can have same organization as meningitis, but altered behavior is more common, seizures are more common in encephalitis. Whereas an abscess being an anti-infection, fever may not be the manifestation, most of them are headache or seizures. And encephalitis is mostly viral, and abscess is active. Almost all viruses in the universe can cause encephalitis. We also need to know that autoimmune causes like the newer autoimmune encephalitis is a panel. Then bacterial causes most commonly is Streptococcus pyogenes. Abscesses can be because of urinary infection or directly heterogeneous spread or direct complication followed by post-trauma. Then the most qualified microbiome. MRI very complex and MRIs can be useful for abscesses. These are like target of the viruses on specific areas of the brain and other organs. The other parasitic infections, commonly seen parasitic infections is neurocystic fibrosis and cerebral malaria. Neurocystic fibrosis is common cause of new onset seizure. So any patient who comes with first episode of seizure is always better to take an MRI done to rule out this neurocystic fibrosis. It is caused by larval form of T-game. It has 4 stages. This is usually asymptomatic, followed by granular or acute diseases which can be symptomatic, and sometimes capital lesion, having infection some time early days, and then they can have seizures maybe after 20 days. So when one severe infection, they should have capital lesion. So these capital lesions can also cause seizures. They can see in spinal, ocular and muscle. Cerebral malaria defines it as carbohydrates after termination of seizure or production of hyperglycemia with sexual forms of plasmodium, hyperglycemia, and no other cause which is added to the cocoa. Fever, headache, these are the associated diseases. Cardiac infarct and CNS thrombosis can also happen because of different coagulation. There is an interesting malaria detector which just came across in the morning. So this is a high sensitive and specific kind of fundus examination where they have widespread malarious result situation and they have whitening. This is around 95-98% of sensitivity and specificity. This is SSC latent infection of variants, usually adult childhood onset. Child comes with slow myelinosis and with neuroregulation. EEG characteristic, and this myelinosis correlated with the paranormality. This is highly common and we don't have any treatment options for this country. Spinal cord infection, which is this is very, and the neuropathy, it can affect the radical plexus, cranial neuropathy, special mention about line diseases where they can have bilateral variation of environment. Multiple neuropathy is the common analysis. Axonal and imbalance neuropathy, HIV, HTLV1, HCD, and then HGSAG. And then neurovascularization, body mechanism, can be handled food degradation and then proposed trauma. Myopathy, also associated with myelitis and myositis. Pyrolysis is commonly in patients who have drug-resistant or long lines. Combination of weed, streptococcus aureus, and then streptococcus. Thank you.
Presentation. It is a very vast subject, to put it in a short form is very difficult. Any question from the audience? And there are also three points like what is the medication? There is a barrier called blood-brain barrier, because of which you have to give high doses of antibiotics and some antibiotics are not related to the CS. So that is one point and then very big decision. And there are diagnosis also when you are making diagnosis is infection and paralysis, both are different. So supposing there are any COVID infection is there, then there is maybe probably GBS. So both are different and paralysis is infection directly. So these are certain conditions you have to remember while diagnosis.
One question, sir. Which particular diseases especially require intravenous administration for diabetes?
It again, if it is ventilated,
Or is it particular organisms?
there is no specific organism related delivery kind of method. But in ventilators, usually what we give in IV may not reach the ventilator. So for all ventilators, it is better to do intravenous administration. And even in cardiac the complication of EDB. There are a lot of suggestions for administration of hyaluronics or hyaluronic radiation.
How long should we give?
Antibiotics.
That makes 4 to 6 weeks of ventilators.
There are no other questions. Thank you for the session.
By Dr. consultant oncologist, Medicover Hospitals, and shared by Dr. Ramakrishna Reddy, consultant oncologist, director of Medicover Hospitals, and Dr. Srikant Reddy, consultant, Dr. Meeta Dasabana, consultant oncologist, Medicover Hospitals.
Good morning, everybody. At the outset, I would like to thank the Development Department of Medicover Hospitals for giving me this opportunity. So, the topic of today's discussion will be PPD updates, diagnosis, and treatment. Coming to the introduction, tuberculosis affects almost 10 million population per year, and it is one of the world's leading infectious diseases. It is responsible for 1.2 million deaths among HIV people and 2 lakh deaths among HIV positive people. So out of the 10 million people affected, so 70% of the diagnosed infected will be reported to the WHO, resulting in 1 million complications of the national tuberculosis. So the risk of TB infection after infection depends on several factors, mainly immunological status. So the risk is 20 or 25 times more among contacts of bacteriologically confirmed TB patients compared with the general population. 16 to 21 times among HIV infection and 3 to 4 times in other immunocompromised states such as diabetes. So coming with the ED timeline, so in 1865, Gene and me proved that it is contagious, and as we all know, Robert in 1882 we discovered microbial tuberculosis, and in mid-1980s there is an unexpected rise in ED cases. So coming to the evolution of ADE, so Government of India has launched a national tuberculosis program in 1962. In 1997, Government of India revised the national tuberculosis program to RNCP, and in 2020 it revised RNCP to National Tuberculosis Elimination Program. So in 2021, TB Mukh Bharat Abhiyan, this is a campaign by the Prime Minister Modi. The main objective of this is to provide additional patient support to improve treatment outcomes of TB patients. Coming to the main topic of the day, diagnosis of treatment, I will be discussing under the following headings: history and physical examination, X-ray, CT, sputum examination, culture, immunodiagnosis, tuberculosis skin testing, and molecular diagnosis. Coming to the symptoms of TB, any cough more than 2 weeks is a person who should be classified as TB suspect. So the most common symptoms will be cough with sputum, fever, mostly night sweats, weight loss, shortness of breath, malaise, hemoptysis, chest pain, and loss of appetite. Coming with the radiological, so in chest X-ray, most commonly seen findings are obesity, mainly in the upper zone, patchy or nodular opacity, presence of cavity or cavities, presence of calcifications, bilateral obesity, especially in the upper lobe, and the difference of us in the lower lobe of the obesity. So obesity that are first after present, and thus they are less likely due to acute pneumonia. Coming to the CT chest, most common lesions which are seen are green verticals with satellite lesions. This is the most common feature which is seen in TB. So in some cases there is enlargement of hilar or parietal lymph nodes. Tuberculosis is also seen. Coming to the laboratory diagnosis, morning hemoglobin samples, these are recommended for the diagnosis of TB. And this test advantage is it is cheap, rapid, and it is easy to perform, higher rate value more than 90% and the specificity of 98%. Disadvantages, sputum sample needs to contain 5,000 to 10,000 AAP per ml. And in temperature and development and HIV affected persons, they may not produce sputum as an other diseases. Coming to the microscopy, most commonly recommended is serial staining. The other staining may be fluorescent staining by carbon fluoride. Coming with the cell staining, the acid fast these are seen as bright red cross against the blue background. And coming with the fluorescent staining, bright yellow against dark background. So the other acid fast which are seen other than microbial tuberculosis, NAM, microbial lethargy, low rhodococcus, nocardia, cyst of Ribosophilia, isospora, cyclospora, and endotoxicoma. So coming with the interpretation of sputum staining. So before declaring as a site as negative, it is essential that at least 100 feet should be examined, at least taking 10 10 minutes of time. So the microbiologist experience also which should be there while doing this. And if the number is scanty, that is 1 to 980 and 100 oil which should be, the number of bacilli just seen, that is the number should be particularly mentioned. Coming to the culture, this is the gold standard, which is higher sensitivity 10 to 100 ml per 100 per element of bacilli detected. Disadvantages, it takes longer time and contamination might be there. So 3 cultures are considered solid, liquid and automated trap culture. Coming to solid culture, domestication medium, this is a negative medium. So the advantages, this is more sensitive, need lower the number of bacilli. It can differentiate between decomplex and non-complex bacteria. And sensitivity of an antidote can be better using this system. Only disadvantages is it takes up to 12 weeks. Coming to the liquid culture, based on the product. So detection of microbacteria coming from white solid, it increases by 10%. So drug sensitivity testing is better than liquid medium. Coming to the rapid culture, mainly by active toxicity. It is cultured in liquid medium containing C14 related aromatic acids and antibiotic mixture. So the advantage with this is it takes within the 12 days and it differentiates between PD and non-tuberculous bacteria. At least 6 weeks is required for a negative culture and it is a coming to the HGI 90. So the system holds 960 plastic tubes which are continuously monitored. Early detection as the machine monitoring and reading the tubes every hour. The mean time for growth detection is 80 days in smear positive cases and 2 to 6 weeks for smear negative cases. So when the conventional methods of obtaining bacterial contamination of suspected TB have failed, then fiber-optic colonoscopy is done. This is mainly to provide diagnostic or culture positive specimens by using robotic washing, brushing or transrobotic devices. Coming to the molecular methods, genotype testing is mainly used to identify microbacterial tuberculosis by detecting the presence of TB-specific microbacterial DNA. So this genotype testing, it detects mutations in the TB genome associated with specific drug resistance. So 3 genotype tests are recommended by the data culture and also by the that is gene expert and genotype MDR, this is for the first one, and genotype DRS for the second. Coming to the gene expert, also called as CDN, characterization nucleic acid identification test. It is a real-time PCR, automated polymerase chain test. It detects entity and inflammatory resistance status. It only takes about 1 hour or 5 minutes for the test to be done. It is used both in the positive and also the negative and extrapolate samples also. So both diagnosis of TB and inflammatory resistance can be identified. So coming to the results of TB, once the entity is detected, inflammatory resistance either will be detected or not detected or maybe intermediate stages. This is a separated line. Coming to the false positive of CB9, it is most commonly when the dead bacilli are seen. Dead bacilli will also be detected with this CB9. False positivity is increased in previously treated patients after 5 years of dead bacilli. So coming to the gene expert mostly gene expert or gene ultra are almost the same, but gene expert ultra it is lower level of bacilli. That is the only difference. Mechanism is almost the same to put it. So coming to the roadmap, this is a battery operated device. So in rural centers where gene expert is not available, then there is roadmap, it is endowed by the PMT of India. So it detects microbacterial tuberculosis within 1 hour. Advanced can be used to detect inflammatory resistance. Coming to the Medicover, it detects both inflammatory and also sensitivity status. So the principle is mainly by reverse solidity hybridization by RPOE gene, isomers by CAT gene and INH gene. So use LEA only for CM positive and culture growth specimen, both for pulmonary and extrapulmonary TB. It is not recommended for results will be given within 25 minutes and then the QG 1 hour. This test will be discussed in detail by Dr. Nidhi. Coming to the linear diagnosis of TB, tuberculosis skin test and TBR test, these are the tests which is done. Tuberculosis skin test, 1 tubercular unit of TBTR T20 with the TB80.1 ml. This is an recommended. So it should be stored under 2 to 8 days. So administrative site will be left for So satisfactory tests should raise lab ACC with the very quantitative order. So after 72 hours, we can read whether the radiation is now accessible to the organizations. Coming to the interpretation of the results, if it is more than 15 ml, then it is association with tuberculosis. 10 to 15 ml, BCG vaccination, NAM, tubercular radiation. 5 to 9 ml, NAM, BCG vaccination. Less than 5 ml, it indicates absence of NAM in the absence of immune suppression. Coming with the data, this is a cell-based assay that measures IIF interferon gamma released by the sensitive lymphocytes in response to antigens. So, whatever TB and antibody both are almost the same, except that sensitivity is slightly more than whatever TB. But no antiviral test is recommended for the diagnosis of TB because of the false negatives. Coming to the treatment, in drug susceptibility, the main objectives of these updated WHO guidelines is to provide new emerging evidence of drug susceptibility and to provide summary of changes. So there are 11 recommendations. Coming to the recommendation 1, so 6 months regimen, that is 2 HR and 4 HR. So India being a high TB burden country, there are also PMIT guidelines for us. But in the world there are which is low TB burden countries, there are which recommendations for us. So for us, it will be 2 HRZE plus 4 HRE. And whenever feasible, the optimal dosage frequency for your patients, it should be daily treatment rather than thrice daily regimen. And use of fixed dose drug combination tablets is recommended over separate drug combinations. And other recommendations, rifampicin should be given throughout the treatment, and if positive smear is found at the completion of intensive phase, then extension of intensive phase is not recommended. People aged more than 12 years or older, they will receive 4-month regimen, that is with isomia and rifapentine, moxifloxacin and pyazamide. This is initially all these 4 drugs for 8 weeks, followed by all the 3 drugs other than pyazamide for 9 weeks. In children between 3 months and 16 years of age without with non-severe TB, 4 months treatment regimen is recommended. That is 2 HRZ plus followed by 2 HR. Ethanol should be avoided in the age group because of the side effect of optic neuritis. So the other recommendation is people who are receiving with HIV, the same drug regimen should be given as HIV negative patients. Coming to the recommendation 9. So ARV should be started as soon as possible, that is within 2 weeks of initiating TB treatment regardless of the CD4 count, except in TB meningitis, because TB meningitis immediately more diagnosis as TB. So at least after 4 to 8 weeks, ARV should be started. So the use of adjuvant steroids in TB meningitis is very practice. In TB meningitis, at least 6 to 8 weeks of steroids should be given, and tuberculosis pericarditis, initial adjuvant steroid can be used or not used. Coming to the TB preventive treatment options, this is mainly for the latent TB. 6 to 9 months of daily isoniazid, or 3 months regimen of daily isoniazid plus isoniazid, 3 months regimen of daily isoniazid plus rifampicin, 1 month regimen of daily rifampicin plus isoniazid, and 4 months daily rifampicin. Coming to the treatment in children and adolescents, there are 4 recommendations. 3 to 16 years as already discussed, with non-severe TB 4 months regimen. And bacteriologically confirmed or clinical cases of TB meningitis, 6 month regimen, that is 6 HRZ should be given instead of 12 month regimen with 2 HRZ plus 10 HR. Coming to the recommendation 3, not included, and both the drugs from 2, 3 should be included. So, if drugs are not included from either A or B, then a combination of 2 to 3 drugs should be taken. This is the WHO recommended standard treatment, 6-month treatment with beta-alanine, predominant, linezolid and moxifloxacin. It is CPAP regimen. This is the recent 2022 by the WHO regimen. So coming to the PMDD regimen, these guidelines are slightly different when compared with the WHO regimen. So coming to the shorter regimen, it contains 4 to 6 months of beta-alanine, levofloxacin, chlorozamine, pyrazinamide, eclampidol and hydroxyzine, ethilenamide, followed by 5 months of levofloxacin, chlorozamine, pyrazinamide and eclampidol. For the longer regimen, for 18 to 24 months, they should be treated with levofloxacin, beta-alanine, linezolid, chlorozamine and cyclosporine. Coming to the SNLs mono resistance, 6 to 9 months of levofloxacin, rifampicin, eclampidol and pyrazinamide should be given. So this is the 9-month regimen which is given, which I have already discussed. This is the same in isoniazid resistant TB, 4 drugs treatment. It is recommended for 6 months, rifampicin, pyrazinamide, eclampidol and levofloxacin. These are the drug dosages which are available for shorter treatment, and dosages should be adjusted according to it. The drugs are already discussed. So, monitoring the patient response to MDR treatment using culture. In drug-sensitive cases, repeat sputum sample is not recommended, whereas in multiple resistant or rifampicin resistant TB, repeat sputum culture is recommended to monitor the treatment response. Coming to the starting antiretroviral therapy in patients on MDR or rifampicin resistant TB, antiretroviral therapy is recommended for all patients. Irrespective of the CD4 count, within 8 weeks it should be started. Coming to the surgery, further research is needed for following areas, that is when the surgery should be done and whether the partial resection should be done on lobectomy or wedge resection treatments. So it should be used along with MDR treatment regimen. Coming to the treatment in context of drug-resistant TB, this is the PMDD. So in rifampicin resistant cases, daily 6 months of daily levofloxacin should be given. The dose is adjusted according to weight. And in cases of isoniazid resistance, 4 months of daily rifampicin should be given. Thank you.
Any question from the actually, diagnosis of pulmonary tuberculosis is easy, but from extrapulmonary tuberculosis, like most of the time, consultation from ophthalmologists or gynecologists, they send suspecting ocular TB or infertility. How to diagnose or confirm the tuberculosis?
I think even the cultures also play a role. So AFP culture also setting upfront is important because once we don't get a senior or chief expert, then at least we have a culture after 4 years. And one more point. Histopathology specimens also with a lymph node or any histopath specimens are taken mostly because they are taken from the surgical specialties and other departments. Sometimes along with the pathology specimen, we can also set as a line another for gene expert. So most of the time we get a granuloma of the histopathology later on, but initially we will be suspecting malignancy. So in such case, again going back and getting a specimen for saline gene expert is difficult. So after we can get an extra sample for saline sampling will be ideal. Yes, and the lymph nodes, cervical lymph nodes.
Next topic is approach to area burst in ICU. Speaker Dr. Nandakishore sir consulted critical care medicine Medicover Hospitals, which is chaired by Dr. Pati, very senior consultant critical care Medicover Hospitals, and Dr. Kali Kumar sir consultant general physician Medicover Hospitals.
A very good morning to all. The delegates who have attended this symposium. In the upfront, I would like to thank my Medicover administration for giving me this opportunity to present this important topic, approach to microcurrent resistant organization and ICU. So, why is antimicrobial resistance more important you see this data which has been published in the WHO consensus meeting, which is held in 2014, India seems to be the major, having a major instance of antimicrobial resistance, and this antimicrobial resistance is now the leading cause of death after diabetes, cancer, and reproductive accidents. And if you extrapolate this data to 2015, and the number is quite staggering, and you can see almost 10 million deaths per year are expected secondary to this antimicrobial resistance, and it contributes to the major decrease in the GDP, and among Asia, India is undergoing the major incidence of AMR. So it's very much prudent that we discuss this topic today. And India acquiring the microbial and antimicrobial resistance seems to be a natural process, but it is complicated by aggravating factors and is a global concern. So antimicrobial resistance have become more complex, and the knowledge about studying antibiotics is probably suboptimally there nowadays, and many of the listeners would agree with me that we are treating patients as sepsis, and we are trying to use overuse antibiotics in the garb of suspected sepsis, and many of us tend to emergency label non-infectious conditions as sepsis and start using antibiotics, and probably this is one of the major reasons why we are facing this problem, and as a result we are seeing the spread of powers that we are facing today. So, if you see the carbohydrate sales in different countries, this is a disclaimer slide, I don't have any problems with this, but if you see the carbohydrate sales in different countries, this reflected that the increase use of carbohydrate in our country. If you see the data, India seems to be the third largest consumer of carbohydrates worldwide. And probably this is one more reason why it is very much prudent to discuss this topic today. There is an overuse of antibiotics in the garb of suspected sepsis, and we are commonly, we generally find any prescription patients being referred from elsewhere or hospital. They straight away are starting carbohydrates for patients with community antibiotics. It's very common, isn't it? We see a lot of patients coming to our hospital, getting treated outside for a couple of days, then coming here. You see a carbohydrate prescription commonly finding for a community antibiotics. So this is one of the reasons why we are facing this problem in our country. And this is not which is anticipated now. It has been anticipated way back in 1940s, where this noble person like Alexander Fleming was first identified the penicillin. He has clearly mentioned in his autobiography, telling that the time may come when the penicillin can be bought by any common man in the shops, and there is danger that this man can easily underdose himself, and by exposing his microbes to non-lethal quantities of the drugs, and making them resistant. And this is not which is very much unexpected. He expected way back in 1940s, where he showed that microbes can acquire resistance if you are using a suboptimal dosage. If you see the timeline of emergence of resistance, there is evolution of antimicrobial resistance. Time and then the moment the new antibiotics come into the market, the resistance has been acquired in the next few years. If you see the antibiotic resistance like in the early 1940s where penicillin was produced, immediately 3 years down the lane, a penicillin resistant organism has come onto the picture. If you see 1950s, tetracycline and erythromycin, the macrolides, they acquired resistance in the next couple of years. So the same pattern is being very commonly being extrapolated in the next coming few years. And even in the recent times, where 2018 and 2019, we have got new antibiotics in the picture, the resistance developed within the subsequent years. So, what are the causes of this antimicrobial resistance, and how actually the bacteria evolve the antimicrobial resistance? So, if you see the evolution pattern of antimicrobial resistance, the first and foremost important thing is the selective pressure. You treat a patient with an antibiotic, the susceptible bacteria probably succumbs to the antimicrobial but the resistant bacteria, one or two resistant bacteria, gain resistant mechanisms, and they proliferate, and probably they produce genes which are resistant to the antimicrobial, giving a selective pressure. If you see, due to the overuse of penicillins, way ahead back, that resulted in the production of beta-lactamases, increasing the need for beta-lactam inhibitors and cellulose. And then we started using more beta-lactam inhibitors as a PLA combination along with the cellulose. And this overuse of cellulose and beta-lactam inhibitors resulted in a production of extended spectrum beta-lactamases, requiring the need for increased carbamazepine usage. And the moment we are using carbamazepine resistance, the antimicrobial resistance has increased on to a carbamazepine producing organism. And this resulted in production of carbamazepines, which we are now facing the issue. And these carbamazepines are more commonly various strains which I will come and discuss in the next slide. The regulation of beta-lactamases with the application of successive classes of antibiotic shows the development of antimicrobial resistance as a function of overuse of the same antibiotic. So this is nothing but a selective pressure which is a common driving force of the antimicrobial resistance. So how do you define drug resistance? So there is a specific definition for a resistant category. Either it is a multi-drug resistant, a band resistant, or an extreme drug resistant. How do you define? Multi-drug resistant organism is defined as resistant to more than one agent in 3 or more antimicrobial categories. For example, E. coli, which is resistant to all your penicillins, which is resistant to all your cellulose, probably beta-lactam antibiotics, and probably only susceptible to your carbamazepine and the polymyxin is probably listed as a multi-drug resistant organism. Extremely drug resistant organisms is resistant to an agent in all but one or two classes of antibiotics. Probably it might be resistant to the carbamazepine, but it might be sensitive to one of the classes of either polymyxin or a fosfomycin. So pan drug resistant is resistant to all the categories of drugs, which we have not very uncommonly seen. We have seen pan drug resistant organisms, patients presenting with DDR organisms. So the interest of organisms which we are more concerned about is the escape group of organisms. The Enterococcus faecalis and Asian, the Staphylococcus aureus, probably penicillin resistant Staph aureus, Klebsiella pneumoniae, Acinetobacter pneumoniae, Pseudomonas aeruginosa, and Enterobacter bacteria. So the escape group of organisms are the organisms which are of interest. So the WHO have prioritized the list of antibiotic resistant bacteria. If you see, they are prioritized as a critical, high, and medium. So the critical is the most important group of organisms which we are considered. The Acinetobacter, the multi-resistant Pseudomonas, and the multi-resistant Enterobacter. So how do organisms acquire resistance? So to deal with this, I would like to discuss about the various mechanisms of resistance. To understand what exactly antibiotic resistance is, one should have a basic knowledge of acquiring how a bacteria acquires resistance. So basically, it's the 4 mechanisms where your antimicrobial area resistance. The first is the increased drug effects through the production of blood compounds, decreased drug uptake, the drug modification or alteration of the target binding site. For example, the penicillin binding protein. When we use the penicillin, the organism they have a penicillin binding protein site. So these organisms might alter or modify the target site, and they develop resistance to this mechanism. And probably alteration or loss of the coding channels, where the drug has to enter into the cellular membrane, or to the enzymatic pathways. This is the most common mechanism of acquiring the resistance. If you see the organisms, most of the organisms gain resistance by this enzymatic pathway. So either producing different types of enzymes, beta-lactamases or penicillins or the carbamazepines. These are the different types of enzymes which they produce and probably cause the antimicrobial resistance. So what are the different types of enzymes we see? Classification, different extended beta-lactamase classification. So need to only remember there are 2 types. One is the serine beta-lactamase and the metallo beta-lactamase. Serine beta-lactamase are the amylase class A, C, and D, and the amylase class B comes under the metallo beta-lactamase. So what is the importance of this? You will come to know in the next slides. So The thing to take into consideration is majority of the multi-resistant organisms, like maybe it's an enterobacteriaceous issue, maybe it's a pseudomonas, maybe it's an acinetobacter, they gain resistance through multiple mechanisms. We have discussed there are different mechanisms of attaining resistance. One is the enzymatic pathway and non-enzymatic pathway. But these bacteria, brilliant bacteria, they have enormous mechanisms of acquiring resistance. They not only produce different classes of enzymes, but they also act through different mechanisms of action. Like for example, if you see the enterobacteriaceous issue, the major mechanism of action of resistance is producing the beta-amyloid carboxylases. They also produce the amino acid which is modulating enzymes. And if you see the pseudomonas, not only the enzymatic production, but there is a deletion of membrane coatings, there is production of efflux forms, there is also alteration of the target. So how to detect antimicrobial resistance? So antimicrobial resistance, how to detect it is basically by doing an antimicrobial susceptibility test. So possibly to detect the various mechanisms of antimicrobial. So what are the options available? There are automated systems, there are semi-automated systems, and the manual. The manual antimicrobial susceptibility test is the older one, which is still being done in many teaching hospitals. It's a time consuming. Now we are well versed with the automated systems, the Vitec and the BioFires. So the manual versus automated, obviously the turnaround time is less and the decision is much faster. If you see the what is the how to read an antimicrobial susceptibility testing. This is a susceptibility pattern of the patient who has been admitted with us. We have taken bronchoscopy and the bronchial lavage fluid was isolated acinetobacter and it is a multi-resistant organism. If you see, they have reported as resistant to cholecystine and it is susceptible to TGCSI. There are no much options available for this patient. So how to go forward, how to interpret this antibiotic, how to choose an antibiotic for such patients who are coming with a multi-resistant organisms. So prior that you should have knowledge about what is intrinsic resistance. For example, if you see another patient of the same, the blood culture report of a patient, the antimicrobial susceptibility report, if you see this, he has isolated serratia, which they have reported as resistant to cholecystine. But it is sensitive to almost all the antibiotics. It is sensitive to amikacin, aminobutyric, it is sensitive to fluoroquinolones, it is sensitive to carbamazepine. So you should have a knowledge about the intrinsic resistance. For example, organisms which are intrinsically resistant to cholecystine. That means these are the specific group of organisms. No matter how many tons of cholecystine you give, it may not respond. So the intrinsic resistance pattern is must. For example, the organisms which are intrinsically resistant to cholecystine are Proteus, Mortadella, Providencia, Serratia, Burkholderia, Harnia, and some species of Citrobacter. So, if you are treating a patient with a suspected sepsis and the patient is not responding to your conventional cholecystine therapy, and this patient isolates the disease organism, probably go back and check your antibiotic. And if your patient has isolated these organisms, please stop cholecystine and probably choose another antibiotic which is susceptible. Similarly, if you look at Pseudomonas, this organism is intrinsically resistant to carbamazepine. So it is also intrinsically resistant to your PLA combinations, your third generation cephalosporins, your atazanine, meropenem, aminoglycosides, monobactam, and phosphorus. So if somebody isolates a Pseudomonas and is already on carbamazepine, probably you think of adding another agent which is more susceptible to Pseudomonas. So intrinsic resistance, we are more concerned about this the Pseudomonas, the Citrobacter, and the Klebsiella. Pseudomonas is intrinsically resistant to atazanine, though it is sensitive to other organisms. Many of us do not have knowledge about it. The moment Pseudomonas is isolated from the urinary tract, and if you think that atazanine is easy to dosing, as it is a daily dosing, atazanine doesn't actually work for Pseudomonas. So, if somebody is getting an atazanine and they isolate Pseudomonas from the urinary tract infection, it is your job to switch on your other carbamazepine or another agent which is more susceptible. So, it is also intrinsically resistant to TGCSI, the chloromethazole, and trimetazole. And though they are sensitive to aminoglycosides, if it is isolated from a non-urinary site, suppose the Pseudomonas is isolated from your bronchoscopy, a patient with a bladder or structural lung disease like bronchitis or COPD, aminoglycoside may not work for the respiratory tract infection. So, if the Pseudomonas is isolated from a non-urinary site, aminoglycoside as a monotherapy has a worst clinical outcomes. Probably you can use it as a combination therapy or as a second condition. If you take Acinetobacter complex, it is intrinsically resistant to your monobacter like Yersinia, Tetrabenum, Trimethoprim, Phosphorus. And though Acinetobacter is sensitive to TG-cycline, FDA has clearly given a black box not to use it as a monotherapy. Maybe use it as a combination therapy along with a polymyxin, but never use it as a monotherapy. Probably you can use it for a subcutaneous or soft tissue infections or a nosocomial pneumonia, present contraindications for nosocomial pneumonia. So the Klebsiella is intrinsically resistant to your cefamycin, ampicillin, amoxicillin, and clazicillin. So if you take a gram-positive organisms, the Enterococcus faecalis, Medium, or the Vector cancer, and these are intrinsically resistant to your cephalosporins, aminoglycosides, corticosteroids, trimethoprim, and acetic acid. So if you get a report of Enterococcus Medium labeling it as sensitive to cephalosporin, probably you need to check the validity of the report. Probably you need to again go back to the microbiology department and see what's happening with the validity of that antibiotic resistance. So they should not be reported as a sensitivity. So these organisms are intrinsically resistant to all these group of products, except the Enterococcus gallerium and Cassidialis, because they are resistant to vancomycin. Especially when you get these two organisms in the culture, it's very much good that you stop vancomycin and probably this is your better gram-positive change. Coming to MRSA, MRSA is intrinsically resistant to all beta-lactams. No beta-lactams will work except your fifth generation cephalosporins. No BLA combination works. Probably your fifth generation carbapentins might work. If you are treating an MSSA, which is usually sensitive to oxazolin and oxazolin, it's always good to check that it is whether there is an individual clindamycin resistant pattern in that subgroup of MSSA. If it is positive for an individual clindamycin resistant, that means the probability of that organism being resistant to clindamycin is much more higher. You either use a high dose of clindamycin or better you use other gram-positive which is much stronger. So one should have a clear idea or about CLS and UCAS guidance, what they will, and one should have a clear knowledge about what is the organism you are associated and what is the probability it is resistant to that organism. So the take home point of the CLS guidance is if an organism is reported as susceptible to your first or second generation cephalosporins, then it can be considered susceptible to other cephalosporins. If Staphylococcus aureus is reported as susceptible to your non-fluoxetine, which is commonly used as a product for your antimicrobial susceptibility, can be treated as susceptibility to other fluorochemicals as well. Organisms reported as susceptible to tetracycline can be treated as susceptible to doxycycline and minocycline. TG-cycline should never be used as a monotherapy, except can be considered as isolated soft tissue infection. For non-urinary site infections, aminoglycoside as a monotherapy has the worst outcome if the organism is Pseudomonas, and avoid all beta-lactams in multi-resistant cons, whereas they use that. And ceftriaxone susceptibility can be extrapolated as sensitive to all third generation cephalosporins, especially for the Enterobacter species, that is E. coli, Klebsiella, and other non-lactose fermenters. So, especially for the lactose fermenters, if you are treating it, the take-home point is the susceptible dose dependent. It is most important. You have to ask the microbiologist who give the susceptible dose dependent, because it might be sensitive to a cefepime, but if the MIC is only less than 2, then you can probably choose this antibiotic, and if the MIC is more than 4, probably you need to double the dose or choose another agent. So the other variant of these kind of organisms is the spice organisms. Serratia, Pseudomonas, Positive, and Citrobacter. These organisms, the unique feature of these organisms is they develop resistance to the beta-lactam during their therapy. In the initial report of these organisms, they might be reporting as susceptible to strains. The moment you treat them with the beta-lactam agent, they may acquire resistance within a couple of days. So it is therefore it is very much necessary that if beta-lactams are formed susceptible in vitro are already being used as a therapy, a repeat AHT test is recommended after 3 days, especially if these 5 group of organisms are isolated with a specific AMC-producing gene. If they are AMC producers and if you are isolating these 5 organisms, it is very much mandatory to repeat the anti-tuberculosis susceptibility test. So, if you put this apart, the one more important thing is the breakpoint of the MIC coefficient. So, also known as the MIC therapeutic index. So, you know, you get a report, say, suppose it's an E. coli, it is sensitive to your asparagus, it is sensitive to your cefepime, it is sensitive to your aminoglycoside, and it is also sensitive to your carbohydrate. So, which one to choose? You can choose either asparagus, you can choose aminoglycoside, you can choose carbohydrate as well. So, how do you choose that? If the organism is susceptible to all the antibiotics, probably applying this rule might help you to look at the MIC therapeutic index. This is the number, the ratio of susceptible breakpoint divided by the MIC of the chest LCA. The higher the bone marrow, the breakpoint to the MIC coefficient, BMU, the better the therapeutic efficacy. For example, if a laboratory report isolates an E. coli, as I told, which might be susceptible to efficacy, but the MIC is 4 and the breakpoint is 16. And the same organism is susceptible to cefepime, which is MIC 1 and the breakpoint is 2. The BMU, the breakpoint of MIC coefficient or the therapeutic index is for efficacy is 4, which is 2 as compared to cefepime. So, efficacy is probably a better agent compared to cefepime. It's always prudent for the lab to use the breakpoints that they report. So many of the labs doesn't report the breakpoints. We just give the MIC and they just give us whether the organism is susceptible or not. So if you ask your laboratory or the microbiologist to include the breakpoints, probably include the therapeutic index along with the MIC values, the clinical report. So what is the importance of molecular testing? So the conventional phenotypic antimicrobial susceptibility testing will provide you only whether the organism is susceptible to a particular antibiotic. But these novel molecular methods, they also give you the report whether what type of enzyme it produces. We have a lot of extended spectrum methods. We have CXLI, we have TEM, we have SHG, the sulfide ingredient, we have oxo-producing strain, we have NDM, the interlimital beta-lactase, which is more concern. We have other enzymes. So how do you exactly know what is the enzyme which is the organism produces? So there comes the molecular testing. So you have, these are all the different testing mechanisms for gene resistance. So you have the Medicover, you have the real-time PCR, you have the microassay, the biomarker which is regularly sent. So you see the accuracy at the turnaround time. The turnaround time you get the report of the same day or probably within 24 hours, and you see the accuracy is definitely high. This is an example of a multiplex PCR study report. We have sent for a patient on whom we did a bronchoscopy and we have sent the blood sample to a pneumonia plus RNA. You have a different group of organisms, you have a virus. Basically, this is a preliminary multiplex PCR where you check the nucleic acid of different organisms. In this, apart from isolated organisms, you see on the left hand side, there is a gene resistant pattern, the CDXL, the NDM, carbapenem resistant, the OXA48 ecosystem. So why do you want to know these strains? The moment you know the importance of these strains, you can choose your antibiotic as per the gene resistance. If the organism is equal to CDXL producing organism, probably my DLL combination can work, and probably I can think of a specific myself with carbapenem. If the organism is producing a NDM strain or OXA-producing strain, then it is no doubt a multi-resistant organism, and the carbapenem may not work. I might go for a polymyxin in the newer generation approaches. So, understanding of OXA48, this is the strain which has been the talk of the town. It has been the probably the main gene which has been attributed to the antimicrobial resistance in the recent times, because the gene has been constantly changing its state. The initial target has been called OXA48. Now there are almost 11 variants of OXA strains, and the mortality remains high in patients who are producing OXA48. The moment you isolate an organism which is an answer 48, then you can probably think of hitting hard with the appropriate antibiotic. And one more point we observed is whenever the patient produces these kind of oxasortate producing strains, it's also associated with co-production of other ESBs. Probably it also co-produces your NDM strain, it also co-produces your IAB strain, co-production of the NDM strain. So this is the gene resistance of another patient who isolated Enterobacteriaceae, the Cystobacter complex, and also the staphylococcus. You can see both organisms have been isolated. So if you see the gene resistance, whether you are in a dilemma whether to treat staphylococcus aureus or not, right? So if you see the pattern, no gene resistance pattern has been reported for a staphylococcus. It has been only for a Cystobacter, the NDM producing strain. And the copies are around 10 power 4 for the staphylococcus. Probably a colonizer or it could be a cons, or it could be a MSSC. So regarding the carbapenem resistant organisms, there are 3 types: the carbapenem resistant Enterobacteriaceae, the carbapenem resistant Pseudomonas aeruginosa, and the carbapenem resistant Cystobacter. So if you see the Indian data which has been published in the ICMR in 2019, see if you look at the non-susceptible percentage of the GNM isolated from all the specimens, the imipenem and meropenem resistance have been significantly reduced. If you see the FCL is close to 50%, if you see the Cystobacter it is almost 90%, and if you see the Pseudomonas it is close to 30%. So this is the rate with which we are dealing with antimicrobial resistance. And what not much of options are left for treating these agents, these drug bugs. So how to tackle this MBIRS? So the first and foremost thing is not all fevers attributable to infection is the thing which we should consider, and definitely most of us would agree that we are overusing antibiotics and we are probably treating every fever as a sign of infection, and probably avoid antibiotics whenever possible. Not every fever is caused by bacterial infection. We should consider non-infective cause of fever, and there are such things. There are many autoimmune conditions, there are many other non-infectious conditions where they exactly look like sepsis. And non-infectious causes of fever like pancreatitis, trauma, burns, connective tissue disorders, ICD, CVD, thrombosis anywhere in the body can cause fever, and you should focus on these parts. And tropical infections are the more common things in India you should consider while writing your antibiotic prescription. So the 10 points which will help in approaching the management of MDI infections is it really a bacterial infection? Do I need to give antibiotics for this patient? Is it a community acquired infection? For a community acquired infection, simple what is the exact focus of infection? Is this patient immunocompromised? This is the most important point. You assess the patient's risk factors and the community risk factors. Is the patient dialysis dependent? Is the patient keep on coming to the hospital frequently? Is there any recent admission on hospitalization in the past 90 days? Is the patient on immunosuppressive therapy? Is the patient having immunocompromised condition? Knowledge about the local, this is the most important. If I say in my ICU, probably Klebsiella and Cystobacter are 2 organisms prevailing, I should have a decent idea about what organisms are prevailing in my ICU. So you should have a knowledge about the local organisms, and preferring a bactericidal agent over a bactericidal agent is the most important thing. And you should prefer a combination therapy whenever needed. The combination therapy is must, and dosing and duration of antibiotics. Thank you.
Thank you, Madam Bishop. Excellent presentation. Go to open questions.
That's an excellent talk. Does it ever happen that you send a sample, you go in the laboratory, it takes 3 days, the culture just come out with something. The same example you said where you go and by a different I mean, my question is what is the real component? Is it ever happens that there is no correlation between the culture bug, the bug identified by a bio, and if we say simply only bioweapon instead of the culture, and we go by the report, it does never happen to me going the wrong way because an artificial based test is very sensitive compared to the culture in the bug is much better.
So there is a huge paradigm shift in the way we treated patients with multi-drug intolerance in the lab. You treat a patient, you initially start on therapy, the patient doesn't respond, you send a dialysis for 3 to 4 days, you escalate empirically, that adds to the cost, right? So in the initial phase itself, you probably send a PCR based study, you get an organism so that you are, I agree that the PCR based tests are a little bit expensive compared to the conventional white antibiotic with susceptibility testing. But you have an exact PCR based therapy. You cannot question the sensitivity of that report. And definitely the sensitivity pattern, apart from that, they also give the gene resistance pattern. That will actually help in choosing the antibiotics. So there is a paradigm shift, the way we think about antibiotics has been changed. Previously, probably you add an erlopilim or a carbapenem along with some combination therapy. The patient is not responding for the next 48 hours. Maybe you think of empirically escalating the antibiotics to all in itself. So if you have the knowledge about the patient factors, the community factors, and the local antimicrobial thing, and also probably sending a early PCR would be a better option to all. It might be expensive, but it might again reduce your cost. If the PCR based assay is not isolating any organism, or if it is a rescue organism, probably you can continue with the same antibiotics, and that will reduce the expenses.
And to add on this, the sensitivity of any PCR based test is very high, but the specificity is a question. Because specificity is also very high. But the only thing is that it is colonizer or because you only need to have few bacteria to say that this is the test will come positive. Because it's an amplification test. Even if one gene is there, it is being amplified multi-fold to give you a positive report. You will definitely get a positive report if you even have one bacteria. And the example for that is there was a sample which was sent, and by taking the sample, the person has sneezed, and that came positive. So you can understand the contamination which can occur by processing this thing. So if your lab is very good, where no contamination is there, yes. And for secondly, what sample you are sending is important. If you are sending urine or sputum for bioweapon, that's a different thing. But if you are sending a bowel fluid, if you are sending a CSF analysis, if you are sending blood, which are usually should be negative. If your CSF blood should always be negative, sterile disease. But if you are getting a positive order, and on top of that, if you are able to identify a gene which is multi-drug resistant gene, then you are business and targeting the therapy is easier. First thing, what sample you are sending and without any contamination. That will give you a very good option if you have all these PCR resistance. What are all the question what are all these resistance patterns developing? If you are being given one option to choose, what test would you choose?
So I would choose any test. I would just go clinically because there are not much antibiotics left in the pipeline. The patient getting treated outside a couple of days, he comes to the hospital, right? And you know the source. By the time you see the patient, you obviously see the patient, do a radiological examination, along with the clinical examination. I know pretty much where is the source of infection and what would be the likely source. And based on that, I would empirically choose my antibiotics. If he is responding to the antibiotics, probably I won't change the antibiotics and everything. If he is not responding, then probably I go back and think whether it's a community acquired or a nosocomial. If it is a nosocomial infection, I am very much I know what's the organism in my ICU. Probably according to that, I will choose the antibiotic and see. But if, based on your question, I would go for definitely for the PCR testing because, as I told, it offers you the luxury of knowing the organism, knowing the resistance patterns.
Now you have all these kinds of tests like PCR based tests, nested PCR, double nested PCR, secondary sequencing, nested sequencing, microarrays,
Medicover is the most, till date, Medicover is the best and highly sensitive test. The turnaround time is just less than half an hour, and but it requires more skillful lab, it's also expensive and it's not easy there.
This is where the paradigm shift is happening now, where you are not going to start any empirical antibiotics because no person is going to die because of antibiotic deficiency. So there is a paradigm shift is happening where empirical antibiotics are being discouraged. If you can get to a narrow spectrum in half an hour or 1 hour, then why not choose that particular antibiotic rather than just bombard the patient with all other antibiotics? So this is the paradigm shift which is happening in the last few years. There is a lot of research going on in this field where you can identify the organisms, at least it's protein, in proteomic analysis, at least it's protein, in less than half an hour, which are essentially, and by knowing the organism, if you think that it is a hospital definitely, I accept that the principles of antibiotic therapy are first, you should know your bus, then you should know your drugs, then you should know your process, and also you should know the disease of the patient, whether it is immunocompromised or immunosuppressed. So all these things put together, you can formulate definitely in the future, at least not now, at least in 5 years now, empirical antibiotic therapy will be going out of the shelf. I foresee. Thank you.
In fact, the new insight is like the Vision 2050 is like not using carbapenems. The more you use carbapenems, the more carbapenems produces organisms disease. We already have the beta-lactamases, we already have the penicillins, they are gone back. Now we are dealing and fighting with the carbapenems. So the new vision target is avoid carbapenems wherever possible, and probably start with a lower antibiotic, especially for the complicated infections. And I see many prescriptions, even the patients that it is a viral pneumonia, being treated with the antibiotics. So this is where the situation where probably we need to look forward and probably stop using antibiotics, because generally viral pneumonia doesn't need any antibiotics.
If there are no further questions,
It's a very critical disease. Just the patient has a respiratory and critical resistant, but doesn't mean that the patient is probably infected with that. It can still be a problem if the patient is being in the hospital for several days. So probably you need to balance the clinical picture along with the test reports you have. If clinically the patient is stable, if there is no oxygenation issues, if the respiratory mechanisms are fine, if the patient is not very intelligent support, if it is comfortable, not having any kind of sepsis or shock, probably you can neglect the report and consider treating with whatever antibiotics you have started before. If the patient is clinically sick and if you have a proven culture report as you told it's a market organism, then there is no point in waiting. Because if people will not question all these statistical reports or your theoretical aspects, people will question why do you treat the market resistant organism. So it's all clinically healthy. If you feel that clinically the patient needs the antibiotic, it has to be given.
To add to this, you need to have good source control. Say, if it is, you are saying that it is a pneumonia, if there is a lung abscess which is erupting, that has to be taken care of. If there is an empyema, further stage is not growing. If there is an abscess, drainage of the abscess, all these things are important. That is the reason why source control takes more importance if it is not responding. Once you have good source control, then only we will try to change the antibiotics or with the antibiotics.
PCRs,
It usually requires a combination of your gram-negative and gram-positive, and probably antifungal. So generally we choose a DLA combination. Generally to start with, we start with either a cephalosporin sulbactam or a cetipine azobactam or a piperacillin azobactam along with a gram-positive agent. So this is the empirical therapy which we do. There are different types of therapy, there is preemptive therapy, empirical therapy, culture-based therapy. So preemptive therapy is what we look into this neurologic patient. It's not empirical therapy. Preemptive therapy is the therapy which we deal with neurologic patients. You know this patient is a probable candidate who can acquire infection. So it is more of a preemptive therapy. You probably choose a gram-positive and gram-negative coverage. So we usually choose the DLA combination along with the gram-positive bacterial coconut and the lung, then probably the result is the choice.
Still not responding, what are the criteria you suggest to add additionally or
so in this patient, if the patient is already in cardiac dimension and is not responding, probably this is the patient where I will probably look at different perspectives. Probably I look at biomarkers, what's happening to the rate of cholesterol, what's happening to the rate of eosinophils, what's happening to the clinical picture overall, and is there any culture report being available. If the culture report is not available, if you don't have a PCR test, you go clinically see what's happening to the patient. Sir? Yes, the PCR is also negative. Probably you need to look at non-infectious causes of fever again. And you cannot afford to delay antibiotics in these subset of patients. These are the subset of patients where you cannot go back and think about other organisms. At the same time, you have to be a little bit aggressive. You have already started carbohydrates. Probably a combination therapy of gram-negative. Even if you see the data of ICM, it is gram-negative organisms which are more prevalent in our country rather than the gram-positive. Apart from the Western world, the gram-positive is more. But in our area, still it is the gram-negative which is the more predominant. So if your patient is not responding to your carbohydrate, maybe think of adding MLL along with the carbohydrate. Maybe think of adding another gram-negative agent along with the carbohydrate, which might be.
Here I am thinking of adding antifungals, if at all is not responding. And secondly, if it is an ADM strain, may not respond to carbohydrate at all. So
my question is this: what are the drugs that you prefer when you have CR? What are the combinations that you go with?
So not much to the pipeline. We have recently approved especially it doesn't work as a monotherapy. It is an NDA producing strain. You have to combine a monobacterial and STM. So ceftazidime and avibactam with STM is the combination which is currently working. There are many randomized controlled trials, reprise study, the EPA study, all they have been done. They have shown that if it is a carbapenemase producing organism and if it is especially an MDM producing strain or an AMSA producing strain, your ceftazidime and avibactam in combination with your monobactam is definitely a good option. So definitely when you start using an antibiotic for the last 2-3 years, the organisms are they find some resistant pathway or other resistant to these organisms. So the other option you can think if it is a pseudomonas is the ceftazidime. Ceftazidime is an excellent pseudomonas coverage. If it is an and ceftazidime is not available in India, but it has been recently approved by FDA. Ceftazidime is one drug which can be adding if it is resistant to. Ceftazidime is a fifth generation in combination and the avibactam, the biapenems, the neurofluoroquinolones like the plasmomycin, the iravacycline, omadacycline. There are many antibiotics which are coming in the pipeline, but I don't think all these antibiotics work as a magic bullet. Right now, the FDA targets only avoiding the use of carbapenem, and if it is a carbapenem producing strain, and look at the gene resistance pattern. If it is an OXA48 producing strain, probably your Zaracentrol should work. And if it is an MDM producing strain, which is much more common in India, this is New Delhi Metallurgical Academics, that's an MDM producing strain, which was first isolated in 2009. This is, if it is an MDM producing strain, probably you should add a monobactam along with your think of adding either polymyxin with phosphomycin or a combination of other agents like cephalosporin as well. Actually, this levothyroxine, which is the branded drug, it is given as 800 mg per day. This drug came to the market predominantly for the dialysis granule into the market, but subsequently also found to have some good gram-positive coverage as well. So the FDA has approved it in 2019. This drug is not very much. It is approved in 2019, but it has come to the market in India in January 2021. So this is a good antibiotic which can be used for immunocompromised patients and if you are dealing with multi-resistant organisms. So, we have our experiences with levothyroxine has been close to like 100 patients, and probably most of them responded well to these antibiotics. But we didn't use it as a monotherapy. We always use it along with the combination therapy, like along with the pyrrolizine, along with the 4-generation along with the carbamazepine. Especially we wanted because levothyroxine is one antibiotic which is an analog of your fluoroquinolones. It also has a typical coverage like your mycoplasma and so the patient coming with a computer antibiotic pneumonia where you have to cover the critical organisms. Probably levothyroxine is one drug which you can choose along with your various combinations. So as of now, there are no head-to-head randomized controlled trials around this specific drug. The trials are ongoing, but as per the latest knowledge, levothyroxine is a good choice which has a very broad spectrum. It covers both gram-negative and gram-positive as well, and critical coverage as well. So it can be used as a combination therapy. Monotherapy we haven't tried. If the studies tell that monotherapy is good, probably there will be a paradigm shift. In future, patients coming with acquired pneumonia, background elderly patient, immunocompromised coming with acquired pneumonia, you think of straight away starting levothyroxine. We might come to that stage. We are not sure. As of now, the evidence is not much in favor of monotherapy.
I will discourage definitely using the representative. I will use it in hospital setting. I patient going from hospital setting to the house. When we discharge, I use it as a monotherapy at that point. Why? Because these fluoroquinolones, we say no fluoroquinolones. I said fluoroquinolones are very notorious for developing resistance. Very notorious. So if you get resistance, if you use it community, you won't get resistance to one. So I think the drug will be going out outside. So I will probably use it off the community inside the hospital.
Just about to mention, Dr. Meghna in the presentation she has mentioned the second line of agents in that fluoroquinolones. They have been used, even linezolid is the second choice, even carbamazepines are the choice. So all the second line agents of ADT are your actual antimicrobials. So we are very much focused on discouraging the use of fluoroquinolones because we have not left much drugs for the tuberculosis part. So if you see our ICU practice, we never use fluoroquinolones for just reason because we have additional agents apart from this.
I think we have run more time, so part of that, so we will control this.
is approach to tropical diseases admitted in ICU by Dr. M. Lakshmikant Reddy, Consultant General Physician, Medicover Hospitals, chaired by Dr. Pradeep Reddy, Senior Consultant Critical Care, and Dr. Naresh, Consultant Critical Care Medicine, Medicover Hospitals. We need active participation from young and residents.
Good afternoon, everybody. So today we will be speaking about approach to tropical infections in ICU. Right? Tropical diseases are often defined as diseases that are prevalent in or unique to tropical and subtropical regions of the world. It can be caused by viruses, bacteria, protozoa, and other parasites. These are responsible for several million deaths annually in tropical areas of the world. So, what are the causes that can cause sanitation and consumption of contaminated drinking water and good food may cause infections like typhoid, amoebiasis, viral hepatitis, travelers diarrhea, neurosis, cirrhosis. Diarrheal diseases, malaria, dengue, typhoid, rickets diseases, and leprosy are common causes of critical illness. So, the spectrum, some study has been shown the spectrum of several tropical infections in Indian ICUs is available from a recent multi-center study from 34 ICUs across India found that dengue has highest incidence, followed by typhus, encephalitis, meningitis, malaria, leproviruses, viral hepatitis, and typhoid. These are more common, what the common tropical infections see, and it can change depending upon the region of again across India. So coming to epidemiology, tropical infections account for about 30% of all intensive care unit admissions in published data from Asia and South America and Africa. In the INDICAP study of 4,038 patients from 124 ICUs in India, 5.7% had tropical infections and 21.7% of those people have died. So in monsoon months, almost 80% of ICU beds in public hospitals occupied by patients with tropical infections. And viral history forms the first step in the diagnosis. Illnesses were most frequently acquired after travel to Asia, followed by Sub-Saharan Africa, Latin America, the Caribbean, the North Africa, and the Middle East. Geosentinel database showed that 82,825 e-travelers returning from tropical and subtropical areas, and with 3,655, almost 4.4% had an acute, potentially life-threatening diagnosis. So coming to approach to the diagnosis of tropical infections, the first thing what you have to know is the history of travel to endemic areas. So what is the first? First you have to ask other places where they have visited, consider the geographic variation and ethnicity of the diseases. Next, the activities done by what they have done, swimming in the lake or river water, wading through monsoon floods. Next, foods, what food they have consumed, any exotic foods and any undercooked food have been consumed. And contact with animals, small animals and wild animals. So any history of insect bites like ticks, fleas, sandfly and mosquito, proper history has to be taken. Next, coming to in the interval between the exposure and onset of symptoms, the incubation period should be considered. So, and the following questions like prophylactic measures followed during travel, whether the patient has taken vaccines for typhoid, cholera, yellow fever, meningococcal vaccine, and any chemoprophylaxis for malaria, leprosy, have been taken on should be asked. And spectrum of organ involvement like syndromic presentation should be carefully assessed. Presence of fever along with any thrombocytopenia, coagulation disturbances, hemorrhagic fever, liver involvement, renal syndrome, neurological involvement, rash, and any pulmonary syndrome. There should be a symptomatic presentation or approach should be followed. So coming to first thing, acute undifferentiated fever. The patient will have only fever without any localizing signs. Then fever with rash and thrombocytopenia. Then fever with ARDS. Then fever, acute febrile encephalopathy. Followed with fever with multi-organ dysfunction. So each syndrome approach has to be
taken into consideration to have a probable diagnosis. So first, acute differentiated is a fever with no localizing signs of fever 101 degrees within 14 days. So what are the common things which you have to evaluate is like dengue, consider dengue, malaria, leptospirosis, scrub typhus, typhoid, and other viral infections should be considered. So coming to each syndromic evaluation, if a patient comes with fever with rash and thrombocytopenia, which is less than 1 lakh, following diseases has to be considered: dengue, leptospirosis, meningococcus, and viral example fevers should be considered. And in any patient with fever with AIS, first the things which you have to suspect is scrub typhus, falciparum malaria, influenza H1N1, severe community acquired pneumonia, followed by diffuse alveolar hemorrhage, secondary to bronchial infections. Next, any fever with acute febrile encephalopathy, encephalitis, HSV, definitely B encephalitis, meningitis, streptococcus pneumonia, Neisseria meningitis, H influenza, leptospirosis should be considered. Scrub typhus, cerebral malaria, typhoid encephalopathy should be taken into consideration. And fever with multi-organ dysfunction, first bacterial sepsis, malaria, scrub typhus, leptospirosis should be thought of. Followed by dengue, hepatitis A or E with fulminant hepatic failure. And next, macrophage activation syndrome. So once the syndromic approach is done, we have to look for any physical findings which can lead to some others. Any patient with lymphadenopathy we should be suspecting TB, Leishmania, rickettsia, dengue, malaria, lymphatic filariasis, and brucella. Hepatomegaly, malaria, Leishmania, typhus, amoebic liver abscess, leptospira, viral hepatitis, and tuberculosis should be considered. And splenomegaly, malaria, Leishmania, typhus, dengue, and tuberculosis. And jaundice, we have to suspect hepatitis, viral hepatitis, malaria, and leptospira. And wheezing, we have to see local syndrome, cocktail allergy, sophilia. So, you have to look for any skin lesions. So, maculopapular lash, we have to suspect again typhoid, viral exanthemus, arthropod, whites, disseminated gonorrhea, meningococcus infections. We have to suspect that there is a maculopapular lash. And when the patient presents with petechial lashes, we have to suspect viral hemorrhagic fevers, dengue, leptospira, septicemia, and EIC. Next, any eschers are there, tick bite fevers, scrub typhus, and anthrax should be noted out. Next, coming to lab investigations, since many clinical syndromes have an overlapping presentation, lab investigation should be guided by the local epidemiology and the common infections. So whatever the more local epidemiology is there, first those things. And the next thing what we have to follow is most life-threatening and potentially lethal conditions should be evaluated first. Empirically treat life-threatening infections should be taken by evaluating the lab results. So what are the lab investigations that we have to do? First, depending upon the date of the onset of the disease or dengue, we have to send for NS1 antigen increase the first to second day, and which will be positive maximum up to 5 days, which can be completely negative up to 5 days. Then blood cultures in typhoid, it will be most probably comes positive only after the first week. And IgM antibodies for scrub and dengue and leptospira typhoid second week. They will be second week, and the dengue and typhoid antibodies can be positive in second week. Then followed by fever with any hepatorenal involvement is there. Rule out first thing malaria, leptospirosis, scrub typhus, and weak fever. Jaundice, which is there after fever, first you have to rule out viral hepatitis, hepatitis A and B, which can be followed with fulminant hepatic failure. Then fever with, if there is any pulmonary renal involvement, first which you have to rule out is scrub typhus, leptospirosis, and complicated malaria. So again, fever with rash, scrub typhus, dengue, viral hemorrhagic fevers, chikungunya, leptospirosis, and purpura fulminans and meningococcus meningitis. So same again, fever with any ARDS, first do a chest X-ray to confirm the diagnosis, and we discuss scrub typhus, leptospirosis, H1N1 influenza have to be ruled out, and complicated malaria also. So fever with encephalopathy, do a CT brain, MRI brain, and CSF analysis and EEG for herpes simplex virus, hepatitis B, encephalitis, scrub typhus, cerebral malaria. These things have to be
And fever with MODS, serum ferritin levels, LDH, triglycerides, and FTP fibrillary liquidating products to rule out the severity inflammatory response, followed by infective causes like again dengue, malaria, leptospirosis, typhus, hepatitis A and B with permanent hepatic failure to be checked. And fever with MODS again immunological disease which normally which we should not with macrophage activations syndrome should be checked for. So coming to treatment, again this has following according to the syndrome based treatment is always advisable. Fever with rash, thrombocytopenia, jaundice, ARDS and MODS. So assess the stability, assess and stabilize airway, breathing and circulation. See for the flag features, cells for more than 1 time respiratory, more than 20 and echo touch. So if you have find out any focus of infections identified, so then you have to see for any focus like pneumonia, pyelonephritis, disease, cellulitis, set appropriate investigation like culture and integrated treatment as well as source can be started. If you don't find the focus of infection, so rapid test has to be done to suggest any diagnosis. So what are the rapid tests that suggest? If you do any test has some positive, like for malaria, you have to start the particular treatment for malaria, dengue, symptomatic management has to be started, and typhoid, and the antibiotics should be done. If there is no rapid test, again comes negative. So empirically treatment has to be started because we are suspecting syndromic approach is a start with ceftriaxone, doxycycline, plus or minus azithromycin, and further workup has to be done like serology for typhus, IFA method, dengue, IgM, IgG, leptospira, IgM, ELISA for white cell, USG abdominal, bone marrow examination, cultures have to be sent out. So followed by if there is any fever with encapsulopathy. So assess and support see, maintain, check for the glucose, see whether it is normal or low or high, followed by adequate hydration should be given, whether the patient is hydrated normally or dehydrated. If there are any seizures or not, we have to look for it. And good history and examination is needed. Then focal signs or features of raised of ICP are there or not there, you have to see. If there are no features of raised ICP, you have to plan for lumbar puncture, CSF analysis for counts, protein, glucose, downstream latex, accumulating the downstream viral PCRs should be done. So if you have any signs of raised ICP and the raised ICP measures like 3% selenium, mannitol, steroids have to be started and followed by imaging with CT contrast with MRI has to be. And routine investigations, ABG, CDP, LPLEX, RFT, LFT and EG have to be done. Followed by malaria students if suggest to start artesunate. And depending upon the CSF cultures and imaging, you have to start preventive therapy like antibiotics and flaxone, followed by if you are suspecting viral hepatitis, start antivirals. Ongoing evaluation, re-evaluation should be done depending upon the symptoms and the condition of the patient. And followed by if you find out any particular reason, you have to start the specific therapy. So we'll just go through few of the topics which are the most common in our areas. Or scrub typhus. Outbreaks are reported from all over India, starting from the South Himalayan belt to more eastern areas and South India. Clinical features normally include fever, headache, and myalgia, breathing difficulty. See, the most common escape we have to see for any bite marks. This thing has to be seen. The most overwhelming pneumonia with the ARDS can be a presentation in scrub typhus. It can also have hepatitis, septic meningitis, myocarditis, and DIS. So lab investigations, weak physics, which is not being done routinely these days, which has have a very poor sensitivity and specificity. IFA method indirect fluorescent antibody is the gold standard, followed by ELISA for IgG, IgM, which has sensitivity and specificity more than 90%. Treatment is doxycycline, 100 mg for 7 days, followed by azithromycin, rifampicin, chlorpheniramine, and albumin can be used. So leptospirosis is one of the most common diseases which happens during these monsoon seasons. Peak incidence is during rainy season, rapid in southern, western and eastern India, increasing incidence in non-endemic northern India also. It has a biphasic clinical presentation, acute leptospirosis, where there is the upper temperature fever, cirrhosis, which is Leach disease, occurs in 5 to 15%, where the patient will be having jaundice, proteinuria, hematuria, oliguria, and or anemia, and with pulmonary hemorrhages, ARDS, and myocarditis also can be seen. And diagnosis rates, CPK levels is not significant thing for persistent present in leptospirosis compared to other tropical fevers. Cultures and positive serology, microscopic accumulation tests can be done and followed by IgM research, which is routinely done. And first line of treatment is penicillin, and alternatively, which we do give regularly, septagenation cephalosporins followed by doxycycline. So dengue is another disease which is common in our West. The incubation period is 4 to 10 days. They have classical symptoms like headache, report, pain, myalgia, and rash. Dengue hemorrhagic fever is thrombocytopenia less than 1 lakh. Skin mucosal gastroenteritis disease can be very severe thrombocytopenia. Third stage is accumulation of fluids and a rise in hematocrit. And dengue shock syndrome, there will be weak pulse, cold common extremities, pulse rate will be less than 20, and there can be hypertension. Diagnosis is by doing non-structural protein 1 antigen detection, which is a Latin card test, and again IgM, IgG serology can be done. And treatment is more of symptomatic and supportive care. And clinical features of malaria is the paroxysm of fever, shaking, chills, and sweats that occurs for 48 to 72 hours depending on the species. Hepatosplenomegaly may be present. Manifestations of severe malaria which we have to consider is several malaria, sometimes with coma, severe anemia, hypoglycemia, metabolic acidosis, acute renal failure, ARDS, shock, DIC, hemoglobinuria, hyperparasitemia. And diagnosis is by smears, microscopy, and rapid diagnostic tests. Malaria is ruled out if 2 negative and rapid diagnostic tests are there. And run-of tests are artesunate, which can gain doxycycline, and cooling also can be used. So, endemic fever, the manifestations in the first week will be fever, headache, related bradycardia. In second week, there will be abdominal pain, diarrhea, constipation, hepatosplenomegaly, and encephalopathy. And third week, there can be intestinal bleeding, perforation, clots. Typhoid or rapid test sensitivity has 95-97%, specificity 89%. Vital test is non-specific, which is not that useful these days. Blood cultures are still gold standard, positive in 40 to 80% of the patient, and bone marrow culture sensitivity is 80 to 95%. And treatment is ceftriaxone, first line is ceftriaxone, and azithromycin and ciprofloxacin are available. Consider dexamethasone followed by 3 mg per kg, followed by 1 mg 6 hours, and encephalopathy and hypertension or DIC. Coming to, there is a study which was a comparison of leptospira and acute viral hepatitis, because both of them comes with fever with jaundice. There was a comparison with all the tests, how to differentiate what could be more likely. So if you see the CPK levels, leptospira has most of the patients in leptospira, the CPK levels are elevated. And as usual, ALT, AST elevation will be almost there with every viral hepatitis. And thrombocytopenia is more with leptospira. ESR will be more elevated with leptospira. Anemia is more common with leptospira. Jaundice is more prevalent or more common with viral hepatitis. Hepatomegaly is also more common in viral hepatitis. Oliguria patients can now renal involvement more with leptospira. And congenital hemorrhages also are more common with leptospira. And fever also with leptospira. So in a way, if CPK levels are high, thrombocytopenia, more of anemia, oliguria, congenital hemorrhages, we have to think about who could be leptospira. And the comparison of leptospira with other acute febrile illnesses is like, say, again, acute other febrile ALT is more elevated, ALT also, and the exterior names are more commonly elevated than other acute febrile illness. Elevated creatinine is more seen with leptospira. ESR again more elevated with leptospira, and TSS are more elevated with compared leptospira. So I will show you few of the recently cases which we have treated in Medicover Hospitals. This is a 28-year
and SOP. Routine investigation showed serum creatinine as 18 when he came to the hospital. Total bilirubin was 13. ALT was 1069, AST 205. His serum amyloid was elevated 173. USG abdominal release showed edematous gallbladder, bilateral grade 1 renal iron changes with bilateral pleural effusions. Okay, so on infective workup, hepatitis A was found to be positive because his enzymes were more than 1000. Firstly, what we call is a viral hepatitis. Patient was started on ceftriaxone, doxycycline, and inflammation suspected it could be leptospirol. Initially, patient was unused with creatinine 18, was dialyzed for a total of 7 times during the hospital stay, and subsequently creatinine improved to 1.3. So renal biopsy was also done, and it showed severe acute tubular necrosis. You see, on the day of admission, his creatinine was 18. On the day of discharge, his creatinine was 1.38. His bilirubin on the day of admission was 13, and on the day of discharge was 2.54. So his hepatitis A and hepatitis A HAV IgM antibodies was positive. Okay. So next, this is the second 39-year-old male with no comorbidities, presented with same symptoms like anuria since 2 days, 5 to 6 episodes of vomiting and loose stools with fever and abdominal pain. Routine investigation showed TLC 5700, weighted from 2000, creatinine of 10.41, bilirubin 2.56, ALT 2986, and AST 5450, with serum amyloid 250. So USG abdominal pelvis showed bilateral, slightly bulky kidneys with perinephric edema, the history of AKI. ABG showed mild metabolic acidosis and tropical infections of the leptospira IgM was found to be positive. So further hospital stay, patient was started with ceftriaxone, doxycycline. Patient was initially admitted with creatinine 10.4, was dialyzed for total 5 times during hospital stay. Subsequently, creatinine improved to 6 and urine outputs of 50 to 60 ml at the time of discharge. On reviewing OPD discharge, patient's creatinine normalized to 0.8 milliliters. So the same thing, if you see the graph, the first day on 23rd, 5th, 2023, May, his creatinine was 10.41, and on the day of discharge, because of financial problems, they got discharged early. His creatinine was 6, bilirubin was 2.54, enzymes were 2986, which you can say by the time of discharge. And case 2 is like this thing, leptospira IgM came positive. And this is the last case, 35-year-old male with known comorbidities presented with fever of 1 day, 10 to 15 episodes of vomitings and loose stools, and 1 episode of focal seizure. On arrival, patient was drowsy, arousable, and GCS was E4, E2, M5. Routine investigation showed TLC 2023,100 and platelet counts of 45,000. His creatinine was 2.56, total bilirubin is 6.67. Enzymes were 202 and 249. USG abdomen showed mild hepatomegaly, and LP was not done in the view of thrombocytopenia. So his MRI brain was done in the view of one episode of focal seizure, which showed sulcal space hyperintensities in place sequences, which was suggestive of meningoencephalitis. So leptospira IgM was found to be positive. Patient was started on ceftriaxone, doxycycline, sensorium improved. Patient is conscious, potent. Urine outputs were 70 to 80 ml per hour. Patient is required. As of now, he is still in the hospital. So, on arrival, his counts were very high, 28,600. Now they are still 24,000. And when he came, creatinine was 2.56 and 0.8. So, leptospira is presenting as meningitis also was seen in this patient. So, his bilirubin was 6.67, and in 2 days it was decreasing, and enzymes showed 202 came to 96, and AST 249, which was 71. His leptospira IgM was positive, 11.2. Thank you.
Good presentation, Rajna. One question. What is the role of steroids in tropical disease?
See, it depends upon
each district presentation stage of the debut, if the patient is on the stage of HLH, whenever that is happening, then there is a lot of steroids. Like each and every, in malaria, if you have ARDS, yes, you have to use steroids. Like each and every disease has got specific indications. Any more questions? I think everybody is waiting for lunch. Okay. Thank you. Thank you.
I request Dr. Hari sir to felicitate Dr. Ravi Reddy sir to felicitate
Yeah. जैसे फैमिली खुले चीप है
Our next topic is rheumatological mimics by Dr. Mohammad Irfan, consultant rheumatologist, Medicover Hospitals, chaired by Dr. Jyoti Pakupalli, consultant rheumatologist, King's Hospital, and Dr. Ranjit, consultant interventional neurologist, Medicover Hospitals.
చాలా గట్టిగా ఉంది. వేస్ట్ ఉంటుంది రికార్డింగ్ దాని వేస్ట్ ఎట్లా ఉంది. కెమెరా ఆన్లైన్ ఉంచాలి దాని మీద పెట్టి ఆన్లైన్
Good afternoon. I am Dr. Mohammed Irfan. I am consultant rheumatologist at Medicover Hospitals. And my topic for today is infectious diseases which are mimicking as rheumatological conditions. So you should remember that there are many conditions which can mimic rheumatological conditions, out of which infection is one of them. There are many malignancies, both solid organ and hematological malignancies which can mimic rheumatological conditions. Also there are drugs like anti-thyroid, anti-tubercular, they can also mimic, they can present with symptoms of rheumatism. And other conditions like metabolic conditions like diabetes, hyperthyroidism, parathyroidism, they can also come with complaints of rheumatism. So, as we all know, infections and autoimmune conditions are closely linked. There are many infectious agents which are implicated in the pathogens of autoimmune conditions like RA, lupus, and for the sake multiple sclerosis, also there are many viruses which are implicated in the pathogenesis of those conditions. So, there have been many mechanisms which have been proposed to explain the role of infectious agents in the pathogenesis of autoimmune rheumatic diseases. Some of the mechanisms which are important ones are epigenetic modification for microbes, epitope spreading, molecular mimicry. I will not go into the detail of this because of time constraints, so I will skip this. I will directly come to the clinical cases. So, there have been in a day-to-day practice, we see infections, especially chronic infections, which can cause a plethora of autoimmune phenomena and thus mimicking autoimmune rheumatic diseases. Coming to case 1. This is a 55-year-old gentleman who is a farmer. He presented with deforming arthritis of left knee for the last 3 months, for which he was taking symptomatic treatment from local place. And since last 1 month, he had severe pain and swelling in the left hand. It was so severe that he was unable to close his left hand. And outside RA factor was mildly positive. So he was being treated as rheumatoid arthritis with NSAIDs, hydroxychloroquine, and low dose of steroids. When he came to my OP, it was around 2 months ago. On examination, you can see the left hand which is diffusely swollen and it was very extremely tender to touch. It was not even letting me touch the hand. And you can see the left knee which has gone into valgus deformity, which is swollen, and the knee showing valgus deformity. On further clinical examination, he had a chronic ulcers over the leg anteromedial aspect, which was non-healing with some serious discharge. And to my surprise, there was a hypopigmented patch on his forearm, which was hypersensitive to touch. He was not feeling the touch and pain on this patch. I think by now you can guess that what is the diagnosis of the patient. Coming to the routine investigation, his inflammatory markers were mildly raised. ESR was 50, CRP 16. Routine evaluation was normal. His serology for anti-CCT was negative and chest X-ray was normal. This was his X-ray of the hand, which showed sclerosis in the left PIP and DIP joints, third and fourth finger. And the X-ray knee showed left destructive arthritis. So a split skin smear was done, thinking suspicious of leprosy in view of hypopigmented patch and destructive arthritis of the knee and acute presentation of left hand arthritis. The SSS came positive for leprosy. He was started on MDT along with NSAIDs. So the lesson from this case is leprosy can mimic as various rheumatological conditions starting from RA to spondyloarthritis or sometimes vasculitis with necrotizing ulcers over the extremities. And the proposed mechanism for these rheumatic manifestations are reaction state, which is type 1 and type 2, as we know. Type 2 is ENL reaction, or sometimes they can be direct infiltration of the cytokine from the labral vessel. And we also know target that is neuropathic joints because of peripheral sensitive neuropathy. So, any patient with rheumatologic complaints, a diagnosis of leprosy may be considered, or we should suspect, especially in the presence of uric lesions. So, this is a case review from India, where there are multiple studies they have compared. Roughly 20% of the patient of leprosy they can present to you with acute symptomatic polyarthritis, sometimes with sacroiliitis and back pain. And this SHF is swollen hand and feet syndrome, which our patient had. That is also seen in around 20-25% of cases. And the important point is this leprosy can have low titer of autoantibody positivity, especially rheumatic factor seen in around 20 to 25 patients. Rarely they can have anti-CCP also. Most of the studies they have found no anti-CCP positivity in their series, but one study has found 10% positivity. And this leprosy can have ANA and ANCA positivity also. So what are the different articular forms of leprosy? Most common is lepra reaction, which present as acute symptomatic polyarthritis involving small joints of the hand and feet. There may or may not be erosions in the X-rays, and we can find lepra vessel in the cytopenia. And the response to MVD is very good. These are the other types of muscular manifestation of leprosy. So coming to case number 2. This is again a 50-year-old male who presented with chronic swelling at left wrist extensor surface for 3 months, followed by tingling sensation in the left, second and third fingers. The pain was severe. He was unable to extend his left wrist. There was no other joint pain, swelling, fever, rash, psoriasis or systemic complaints. Initially he was seen by our orthopedician. We got an ultrasound of the hand and which showed diffuse synovitis more in the extensor compartment at the wrist with median nerve compression. So this median nerve compression was causing carpal tunnel syndrome. His routine investigation is normal. This was the hand at the presentation, diffusely shown at the wrist. In the palmar aspect also there was flexor tunnel synovitis that is giving us a diffuse swollen pattern, and he was operated for this carpal tunnel. During this surgery, the routine investigation, ESR-CRP was okay, serology for RA factor and anti-CCP was negative, a CT chest was normal, MAC2 negative, and ESR was normal. His X-ray of the hands looked pretty okay, only there is mild osteopenia at the left wrist joint. So he underwent a carpal tunnel release, and meanwhile a synovial biopsy was also done in draw, and this synovial biopsy showed necrotizing granulomas with few lymphomononuclear cells and few multinucleate giant cells of possibility of tuberculosis. And during this procedure, I think only TB-PCR was sent and culture was not sent for some reasons. This TB-PCR showed non-tuberculous mycobacteria. We wanted to do a TB culture, but we didn't have the sample. We counseled the patient that it is NTM. We might need a culture if he doesn't respond to the treatment. We started him on 3 drugs, rifampicin, azithromycin, and I think ethamazole. We gave him for 6 months. The synovitis resolved. He was able to slightly move the movements, and the pain had completely gone. So final diagnosis was NTM tenosynovitis. Presently, as the only manifestation, CTS was normal. And the third case, he was a 30-year-old male who was a driver of one of our colleagues, doctor in Medicover. He just routinely came to my OP asking for a painkiller for his parietal ankle pains. When I asked him, he told he had some fatigue and reddish rash over his left leg for the past 2 months. There was no other symptoms, no fever, cough, or systemic issues. When I examined him, he had bilateral ankle synovitis and erythema nodosum-like lesion over his left shin. I told him to better to get a biopsy done, and meanwhile I asked for a routine investigation. Those were normal. I asked him to get an immediate chest X-ray which showed left hilar lymphadenopathy. My first suspicion was it is tuberculosis or sarcoidosis in view of ankle arthritis and hilar lymphadenopathy. That's why I asked him to get a biopsy of the skin lesion. But he was not very listening. I got a CT test the next day, it was suspected active tuberculosis. He was started on ADT, and after a period of 1 to 2 months, his ankle pain had gone and there were no recurrence of PA lesions. So final diagnosis was pulmonary tuberculosis presenting as bilateral ankle arthritis and erythema. So this is one more case which was referred to me from my cardiologist 6 months ago. She is a 46-year-old female. At home she had sudden onset giddiness, and nearby she was found to have ventricular tachycardia of the ECG, and she was referred to Medicover. Initially she was evaluated by the cardiologist. Routine investigations including echo and CAG were normal. So the cardiologist got a cardiac PET scan done, which was a history of inflammatory cardiomyopathy, and there was a incidental finding of left axillary lymph nodes. So with this picture of inflammatory myocarditis and lymphadenopathy, the possibility of sarcoidosis with tuberculosis and lymphomuscular and axillary lymph node biopsy was done. For sarcoidosis, age level pattern which was normal and calcium was normal. MAT2 was strong positive. Lymph node biopsy was again such of granulomatous lymphadenopathy. Again, a TB PCR was which detected NTM. We were suspecting tuberculosis bacteria, but it was NTM which was detected. Again, culture could not be done because of same. The sample was received formally. So final diagnosis: NTM infection causing myocarditis and lymphadenopathy. We started again treatment for NTM, and after a period of the patient is been following almost 6 months. The repeat PET scan showed no uptake in the myocardium. He never had a VTs in last 6 months. So this is a brief chart showing rheumatological manifestation in patients with tuberculosis from 100 patients. This is an Indian study. You can see almost 20% patients can have fibromyalgia, and they can have sinusitis, erythema induratum, and sometimes they can have dactylitis also. Coming to the next case, this is an interesting case. This patient is a 23-year-old female who is a dentist. She complained of left buttock pain for the last 25 days, which was insidious, progressive, with early morning stiffness of more than 1 hour, suggesting inflammatory in nature. She had mild relief in anesthetics, and she denied any issue of any peripheral joint pain, swelling, skin lesions, or any systemic issues. At examination, she had left sacroiliitis, tenderness, other joints were normal, other systems were normal. Again, for our pre-investigation normal, chest X-ray was normal. In view of unilateral sacroiliitis, we always have to think of infection like tuberculosis. MAT2 and X-ray was done, those were normal. HLB-27 to our surprise is negative. MRI was done, we showed only left sacroiliitis. Right sacroiliitis was perfectly normal. She was given tablet digoxin 250 BD with Corvin. She had 50% reduction in the pain. This was happening outside. She didn't come to us at this point. She came now 1 month later after using some NSAIDs for pain. She now came with pain and redness of fingertips in both hands, swelling of bilateral toes with redness and pain, and fever which was low to moderately associated with chills. And she used some antibiotics for this fever outside. And she also complained of mild blurring of vision in both eyes, which was painless. And for the last 1 week, she had severe bouts of cough and hunger for drink at the night, which was getting relieved with upright posture, suggestive of PMD. So when we saw her in the examination, positive findings were she has this reddish rash which was tender over the fingertips, and she had dactylitis of bilateral toes. And cardiac examination, she had a massive murmur in the mitral area. And after the evaluation was done, it showed bilateral rock spots. So I think now the diagnosis is pretty clear. Thinking of infected endocarditis, we got a blood culture done, which 3 sets all came negative, maybe because she used antibiotics outside. And we got a 2D equivalent transferences, which showed a vegetation over the ankle and the with severe MR, fine tear, and dilated LA. So the final diagnosis we made was infected endocarditis, which was culture negative, manifesting as left sacroiliitis initially, followed by hotspots, dactylitis, and jam lesions. She was started on broad spectrum antibiotics by the cardiologist. And after a period of 15 days, a repeat of the evaluation showed resolution of hotspots. And the patient was planned for mitral valve repair by the cardiologist, but unfortunately the patient died due to acute heart failure. This is a study of 46 patients of infected endocarditis, which are having rheumatic manifestations. You can see sacroiliitis is one of the rare manifestations. Most of the time it is myalgias, arthralgias, or arthritis, around 10 to 15%. But sacroiliitis 36-year-old female who presented with 6-month history of generalized myalgia and arthralgia, but no obvious weakness in the upper limb or lower limbs. She had dryness of mouth, bilateral carotid swelling, and low-grade intermittent fever for the last 2 to 3 months. There was no history of any dryness in the eyes, no history of cough, shortness of breath, or rashes. On examination, she had mild hypertension, 150/100, with cervical and axillary lymph nodes. There was bilateral parotiditis with swelling and tenderness. In the mouth, the salivary pool was increased, and she had multiple rectal caries. Systemic examination was normal, and musculoskeletal, there was no crying symptoms. We got a routine investigation done, which showed positive mild leukopenia 3500, ESR mildly raised, SBMC normal, and the renal function showed AKI-like picture, creatinine 1.4 and urine showing 1 plus albuminuria, quantification showed 0.8 grams of protein. Liver function, chest X-ray, echo normal, viral markers, HBV and HCV negative. So our first thought was it is Shorthand syndrome presenting as Zika symptoms, arthralgia, myalgia and renal involvement. So we got a serology done, AMA by immune process was 2 plus better, which is considered borderline positive, and anti-RO and anti-large specific for Sjogren's, while isovectin they were negative, complements were normal, RA factor again being positive and anti-CCD was negative. So the patient was counseled to get a kidney biopsy done in view of possibility of Sjogren's syndrome or any other mimic. To our surprise, there were no globular lesions. The positive findings said that venous interstitium was infiltrated with a large number of inflammatory cells, mostly lymphocytes, plasmocytes and fibrosis. There was also tubular destruction and tubulitis. On immunostaining, the lymphoid cell vectors CD3, CD8 and CD138. I think by now we got the diagnosis. The biopsy of cells of diffuse infiltrative lymphocytosis syndrome, which is one of the rarer manifestations of HIV. So on retrospectively, the patient was asked, she had not told that her husband is positive and she was never diagnosed with HIV. We got a HIV done. She was HIV positive, the CD count were very low. The patient was started on ART and she is under follow-up. So these are what is the manifestation of HIV. You can see tails is very common before starting ART. After ART it is very less common. The other manifestation which can be seen in HIV are cryoglobulinemia, again positivity for autoantibodies like RA factor, CCP, AMA and anti-viral. So on a similar note, chronic viral infections like hepatitis B and C, they can also present with rheumatic manifestations like arthritis, serum sickness, polyarthritis nodosa, and fibromyalgia. So this is the last case. A 50-year-old female presented with inflammatory joint pains in the small joints of hands, wrist, knee, along with generalized myalgia for 6 months. And there was a history of fever with transient rash 6 months ago, which was treated symptomatically. And at that time, the patient remembered chikungunya was positive. Now they will know the systemic complaints. On examination, there was active synovitis of bilateral wrist, all the VIP and MCP joints. There were no deformity seen, and the other system examination found. Now the investigation showed routine CPP, electric and wave function normal, ESR was raised. Again, RA factor was weakly positive, anti-CCP negative, and AKI was negative. X-ray was done, which showed there were no erosions or deformities. So the probable diagnosis was post-chikungunya chronic arthritis versus rheumatoid arthritis. These are the typical symptoms of acute chikungunya, which is already discussed. So in acute phase, up to 1 month, 15 days to 1 month, they can have, most of the patients will have arthritis, sometimes arthritis also, along with some rash in 36 to 80%. But once the patient crosses 3 months to 4 months, that period is called chronic chikungunya. And the manifestation can be in form of chronic inflammatory rheumatism. It can present as polyarthritis, resembling RA, spondyloarthropathy or differential arthritis. Sometimes chronic chikungunya can present as sphenosynovitis or exacerbation of pain in the previously injured or osteoarthritic joints. Most of the patients can suffer from chronic fibromyalgia for a period of 6 months to 1 year. So these are the, again manifestation of chronic chikungunya. Sometimes they can present with sphenosynovitis resembling carpal tunnel, subaortic tunnel and tarsal tunnel syndromes and also Raynaud's syndrome. So the patient was treated symptomatically, and but the patient didn't have much response. So DMARDs were added and the patient responded. So in short, the take-home message: infectious diseases can be accessible revealed by rheumatic manifestation. So any patient presenting with unusual manifestations like a hypopigmented patches or a hypostatic patches or a non-healing ulcers or monoarthritis of the waist or knee for a chronic time, we have to suspect chronic infections like leprosy, tuberculosis. The improvement of articular and infectious disease depends on rapid diagnosis and adequate treatment of the underlying infection. Thank you.
Great talk, sir. And collection of cases are very interesting and nicely evaluated. So, any questions?
If there are no questions, just two things from our rheumatological aspects. It's easy to diagnose a rheumatological case, having a rheumatological diagnosis. Always look for head-to-toe examination, including the nails, skin, hair, eyes, ears. If a patient presents with arthritis, always do not have rheumatoid arthritis as the diagnosis in your mind. Please look for extra-articular manifestations. And always keep in mind, RA factor positivity doesn't mean the patient has rheumatoid arthritis. There are several false positive cases as well. It is also seen in 5% of the individuals. And the other thing is, I would want to make sure rheumatology is not always about steroids. It's about when to give steroids and how much to give steroids. So always have an multidisciplinary action and see that the patient will have the correct diagnosis. I request Dr. Ehsan sir to felicitate Dr. Irfan. Dr. Spurti. Dr. Ranjit. Now we all can wait for a lunch and get. Please, I request you to be back here around 2:15.
And out of 38.4 million people, 650,000 people have died from HIV-related causes in 2021. So HIV in Indian perspective, with the national adult prevalence rate has significantly reduced from almost from 0.54% to 0.22% in 2020, which is almost 33.3 decline in last 10 years. With the advent of new ART drugs, almost AIDS-related mortality has come down from 24.34 to 2.37 by the end of 2020. That's the impact of newer ART drugs and the goals and the regimen followed in ART drugs. So the AIDS mortality has significantly reduced with ART drugs. So coming to the after brief introduction of HIV, we will be discussing more on HIV management, what is the site of action of newer ART drugs and the new old ART drugs, and what are the latest guidelines that we have to follow in treatment of HIV. So if you see this HIV infection window period, how you diagnose HIV? So if once a patient gets infected with HIV virus, there will be incubation period of 3 to 4 weeks. So we can't detect HIV virus in this incubation period with the old conventional first generation and second generation or third generation HIV ELISA methods. with the introduction of 4th generation HIV antibodies assays, with combined with P24 antigen assay, we are almost able to detect as early as 16th day. And the new HIV testing, like nucleic acid testing, we can detect HIV RNA virus by the end of 12th day. So if we want to detect as early as HIV infection, if a patient comes for post exposure, we can detect HIV within 12 days by means of nucleic acid testing. The same slide, 4th generation enzyme immunoassay has a sensitivity more than 99.5, and the 4th generation can detect as early as 12th day. A newer method, nucleic acid detect can as early as 12 days. The Western blot method, which is previously used for confirmatory method, is no longer used for confirmation of HIV. So if you see HIV life cycle, here once the HIV virus gets infected, the HIV virus gets infected into the host cells, where they have process of fusion and binding to the host cells, where by means of reverse transcriptase, HIV RNA is transcribed to HIV DNA by an enzyme called as reverse transcriptase enzymes. This process is main, previously the old and the reverse main initial drug site of action for ART drugs is reverse transcriptase, which includes nucleoside receptor transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors. And once this HIV RNA is formed, this HIV RNA by means of integrase inhibitors, once it enters the host nucleus, where HIV DNA into the host DNA by method called integrase, where integration is done by means of integrase. So now the new site of action for the integrase inhibitors and the most effective drugs are integrase inhibitors, where antigravir and dolutegravir are the drugs that are effectively used for ART regimen. So once the host DNA is transcribed to HIV DNA and it enters the nucleus, by means of transcription, it forms mRNA, new genome mRNA, and with the help of protease, the new budding immature virions has come out of host nucleus, where they proliferate and form new virus, and the new virus will infect all the helper T cells and cause immune suppression. So if you see the site of action of ART drugs, there are four major sites of action where we initially used to have reverse transcriptase inhibitors like NF-protease and protease inhibitors like lopinavir, ritonavir, atazanavir and darunavir, and the new fusion inhibitors and CSR5 receptor antagonists where HIV gets binding to the host cell. So the site we target was fusion and binding. So these are the site of action of all the ART drugs. So if you see this is classification of ART drugs. So main drugs that are useful for ART drugs include zidovudine, lamivudine, abacavir, emtricitabine, and nucleotide reverse transcriptase includes tenofovir and tenofovir alfanamide, TDF or TAF, and fusion inhibitors include enfuratide. If you see non-nucleoside reverse transcriptase inhibitors like nevirapine, epavirenz, and doravirine, a new drug that is included, integrase inhibitors like mainly dolutegravir, raltegravir, and cabotegravir, and CCR5 entry inhibitors like maravira. Protease inhibitors mainly will be discussing on ritonavir, lopinavir, atazanavir and darunavir. Post-attachment, this is a new ART drug that is useful, that is approved by FDA for the treatment of HIV. Post-attachment maturation inhibitors like ibalizumab. So if you see overall the new ART drugs and the old new ART drugs in single classification. What are the main examples of, we won't be discussing all the drugs. So we will be discussing only the main important drugs for the treatment of NRTS. So we will be discussing more with tenofovir, which has renal toxicity, which can be given in 300 mg, minimal side effects, but we have to be careful in renal toxicity. Zidovudine with side effects like anemia, neutropenia, bone marrow suppression. Lamivudine, which is baseline for ART regimens, which has minimal toxicity and rash. Abacavir in the patients which have hypersensitivity to tenofovir or lamivudine, nucleoside or nucleotide reverse transcriptase inhibitors that are generally commonly used right now for ART regimens. And non-nucleoside reverse transcriptase inhibitors, mainly efavirenz and nevirapine, are almost nowadays we are not using much with this after the invent of integrase inhibitors. Only in the children will be using more of nevirapine. Efavirenz, even the patients are efavirenz old drugs has to be changed to that we will discuss in next slide. So efavirenz has a side effect of central nervous system symptoms, mainly dizziness, somnolence, insomnia and confusion. So it has to be given in the night time to suggest decreased central nervous side effects. And nevirapine mainly which have a side effect with skin rashes. So with the advent of integrase inhibitors, non-nucleoside reverse transcriptase has come down. So dolutegravir 50 mg once daily, and it has a minimal side effects like insomnia, headache, dizziness, tiredness, and minimal allergic reactions. Previously we used to give raltegravir, now we have to give dolutegravir. Raltegravir 400 mg twice daily, but it has side effects with rhabdomyopathy, rhabdomyolysis, myopathy, SJ syndrome, toxic epidermal necrolysis. So after the invent of dolutegravir, raltegravir has come down. So dolutegravir has rapid viral suppression. It reduces the viral copies to less than 50 copies, reduces chances of transmission, and dolutegravir has fewer side effects and minimal drug interactions. It is effective against both HIV 1 and 2, and there is no substitution for dolutegravir if even the patients, HIV patients with comorbidities like TB, hepatitis B and C. Even the patient has co-infected with TB, HIV, B and C, we can safely give dolutegravir. So protease inhibitors, when the patient is not tolerating dolutegravir, we can safely give atazanavir, ritonavir, the doses of 300 mg and 100 mg, ritonavir, lopinavir, the doses of 250, and darunavir and ritonavir if the patient is not tolerating lopinavir and ritonavir. So with the brief introduction to ART drugs, what are the goals of ART is clinical goals. You should increase the survival rate of patient. You should improve the quality of life of ART HIV patient. Virological goals, greatest possible reduction in the viral load. Immunological goals will be to have a better immune reconstitution, better CD4 count and decrease the HIV viral load. Therapeutic goals, we will have the rational sequencing of drugs that decreases, that achieves clinical goals, virological goals and immunological goals, and preventive goals to prevent HIV transmission to by suppression of viral load. So ART eligibility, so all people living with HIV are eligible to start ART regardless of age, CD4 count and clinical staging. So there is no CD4 count, there is no need for any age restriction, there is no need for any CD4 cell count, and there is no age restriction for clinical stage. We can start ART if there is for all clients without any contraindication. ART can be started within 70 days, if possible, within 7 days, if possible on the same day itself. And pregnant women, infants, children under 5 years, and children with advanced HIV disease can be started on ART on the day of diagnosis. So before initiating ART, there is a slide we should evaluate baseline evaluation. So you have to have a thorough history and clinical examination. You should screen for TB symptoms. You should take history for cough, night sweats, recent weight loss, and we should send for HIV RNA viral load to see for viral load, CD4 count, and routine mycobacterium tuberculosis or gene expert TB. It has made mandatory before starting ART. And sometimes we have to do baseline CBP, sugar levels, fasting lipid profile, and the RFT and LFT, because all these side effects, we have a baseline evaluation before starting all the regimen. We should have a stable CK, stable serum creatinine levels and stable liver enzymes. So baseline evaluation, we should screen for symptoms of meningitis also. If the CD4 count is less than 100, automatically we should send screen for cryptococcal antigen test. If the cryptococcal antigen test is negative, we can refer ART. If it comes positive, we have to subject the patient for lumbar puncture. If in the lumbar puncture, if CSF analysis comes positive for cryptococcus, we have to go for cryptococcal antifungal test. So we have to screen for cryptococcal antigen test. and we have to screen for other virus, comorbidities, cervical cancer screening. And in addition to baseline evaluation, we also should screen for non-communicable diseases like diabetes, hypertension and epilepsy, and mainly mental health issues of depressed, sexually transmitted decision. So we should look for opportunistic infection. We are not going to discuss opportunistic infection in this seminar, but only the main, what are the treatment regimen. So if you see, this is a slide that we have to see. So all adults and males, females, including pregnant women, more than 30 kgs, more than 10 years of age, we should be giving tenofovir, lamivudine, 2 NRPS and dolutegravir with integrase inhibitor. So the regimen will be TLD. So tenofovir, lamivudine and dolutegravir. If the patients, if the neonates, infants, children 0 to 10 years of age, if the patient weight is less than 3 kg and the birth to less than 4 weeks of age, we have to give judovidine, lamivudine and nevirapine. So these are the regimen that has to be followed below 4 weeks of age, and from 4 weeks to 10 years we can give ALD. ALD means A stands for abacavir, L stands for lamivudine, D stands for dolutegravir. So infants less than 3 kgs, judovidine, lamivudine, nevirapine. From 4 weeks to 10 weeks, ALD, abacavir, lamivudine, dolutegravir. More than 10 years, irrespective of weight, more than 30 kgs, simply remember TLD, tenofovir, lamivudine, dolutegravir. So any other drugs, the patient is on any other drugs, like this is a complex treatment algorithm. The basic here, dolutegravir, in place of dolutegravir, if the patient is not tolerating dolutegravir, we can shift over to any protease inhibitors as I discussed, lopinavir or ritonavir. If the patient is not tolerating any tenofovir, we can go for judovidine or we can go for abacavir. So this is a complex regimen, but mainly you should remember, if you see all the regimens, the baseline will be, lamivudine will be there for all the regimens. Only if the patient is not tolerating dolutegravir, shift over to protease inhibitors. If the patient is not tolerating to tenofovir, you can safely give judovidine or abacavir to suppress viral load. So pregnant and breastfeeding women with HIV, the same regimen has to be continued. Tenofovir, lamivudine, dolutegravir, TLD regimen, and it has to be given lifelong. And patient presenting in active labor with no prior ART, and we have to quantify low risk or high risk. So the same regimen has to be given on the day of labor also. We should give TLD, tenofovir, lamivudine and dolutegravir, and we have to continue TLD lifelong. So if you have a low risk, infants born to mothers who have suppressed viral load have a less chance of getting HIV transmission from mother. So we should be giving single antiretroviral prophylaxis, either nevirapine or judovidine. If the patients and the infants born to HIV positive patients who are not on ART, high viral load, patients presenting in during labor, so we have to give dual antiretroviral prophylaxis with mainly syrup nevirapine and syrup judovidine. So if you see single antiretroviral prophylaxis for 6 weeks, up to 6 weeks, if the patient born to mother who are already ART and viral load less than 1000, high risk infants, we should use dual antiretroviral prophylaxis. The same guideline can be put in case discussion. Mr. G was screened for HIV and is found to be reactive to finger prick test performed in the labor group. What is the next step in the management of mother? So all pregnant women, irrespective of trimester and irrespective of presentation, we have to start the patient on TLD regimen, tenofovir, lamivudine and dolutegravir, and we don't know the viral load of mother. So some countries encourage to give single dose of nevirapine to prevent mother to child transmission, which can transmit through placenta, and a lifelong ART has to be given for the mother. So what advice needs to be given to the baby who delivered of same case scenario who delivered a baby of 2.8 if mother opts for breastfeeding? So this is a high risk case. So high risk infant born to a mother. So we have to give a dual antiretroviral prophylaxis, both syrup nevirapine and syrup judovidine for at least for 12 weeks. So this is a regimen that has to be followed if you see clinical scenarios. So in all adolescent males and males, female pregnant women, we have to remember tenofovir, lamivudine and dolutegravir. So why to defer ART and when to defer ART? Why to screen for TB symptoms is iris. The main complication with ART is iris. So what is iris? Immune reconstitution inflammatory syndrome. The worsening of signs and symptoms due to known infections or the development of disease due to occult infections that results from inflammatory response by regenerated immune system following the initiation of ART. So once if you start ART, almost any patient, almost out of 100 patients, 10 to 30
So, this is the topic I choose, travel medicine. I just put up my education here, not to show off, but to say that during my education as 7 years and internal medicine residency, then working in US for a few years and coming here, half the world I practiced a little bit. So this travel medicine, I think I grabbed the roots in US. Now that's the reason I did this one. The topic, although it is a broad topic of travel medicine, my particular question is travel and infection. Is at all to travel medicine to practice in India? How relevant is travel medicine to our practice as a primary care physicians or super specialty consultants also? So if you see the news or papers, this is what we feel about the world. It's a very unsafe place for so many things, not just infections, traveling, kidnapping, money laundering, lot of things are happening. Is it even safe to step out of the house? So as a physician, it's our role to make patient comfortable by watching the effects. At the end of the topic, we will make, I'll let you know how should we make the patient feel, to see the actual reality and not get out of the house and make them couch potatoes or live in the altar world, or we should just let them go safely, enjoy close to the nature. Okay, if I do that, I'll feel happy at the end of the talk. The sources are mostly, it's a guideline from travel medicine and obviously WHO and CDC, the mother of all infectious disease networks. ISTM, which is International Society for Travel Medicine, and various journal articles. But we have very minimum articles from media, because I'll tell you the reason why it is. And the layout of the presentation will be like in this pattern. Actually, my friend, my colleague, Dr. Mittal and Dr. Lakshmikant made my job easy because they cover both vaccinations and tropical infections. So there's not much I have to jump and reduplicate at this hour. I'll try to see what I can do. So very first topic I'm going to do is definition. It's not a big definition, it's a simple thing. It's a travel medicine is basically health of travelers during visit to the foreign countries. Mostly that was the thing which was coined when in somewhere in 1980s and 90s. And it's an interdisciplinary. What does it mean is, I'll show you the next slide. This is the first editorial in 1994 from Journal of Travel Medicine. This is the first picture they had in that editorial. So what they meant at that time is, irrespective of your subspecialty, your patients are going to travel within the country or outside the country. You should be aware of where they're going, why they're going, how they're going, and sometimes you need to take multidisciplinary approach to ensure the safety of the patient. So as I said the first slide, it's a traveler's health with interdisciplinary approach. And what are the origins? Is it something of modern medicine after we started air travel? That this all started because air travel is less than 24 hours, you can reach across the globe. So the infections are still persistent in a symptomatic way and spread into pandemics, epidemics and all, which we recently encountered COVID-19. So you can understand the magnitude. Prior to that, the travels were very long journey. If it's infectious related, patient would either recover or would have perished by the time they reached the destination. So is there any relevance in history? Is it only recent or past? The same editorial in 1994 journal, this is the thing I came to notice. Can you identify the first picture, the man who is lying on the bed? Anybody? Okay. It's Alexander the Great. After conquering the world, on the way back home, he died of typhoid. That's what the editorial says. But when I searched internet, they said typhoid versus malaria. They think it's more typhoid from the symptoms. So even Alexander didn't have travel medicine at that time. Otherwise, he would have lived longer and conquered more. We don't know. And even Shakespeare also commented about travel in something in a theatre called As You Like It. I think all of you know the common phrase, they say the word is stage and everybody is acting the same play. This is the one they quoted in that editorial. They're saying these exact words of Shakespeare. I'm not a stage actor or anything, so I don't know, I can put emotions in it. Basically what he's saying is what danger it was made as we are to travel so far. So if you travel far, we can be stuck first documented travel medicine related research, you can call it, is done in 1747 for scurvy in long voyages. I know voyages means traveling on the ship. James Lind actually did a control study. 1/4 of the group he gave 2 oranges in lemon, the rest of them he gave different concoctions. But and I think the oranges group did well. That's how the treatment came for the scurvy. So these are the exact statements from that editorial thing. So enough of origins and all. Around 60s and all in Mexico, travelers diarrhea studies started. Same time in Europe, they started systematic approaches to the infectious disease. And this is a slide which can explain the whole thing. If you see somewhere around 60s, the travel, this is from the Western literature, I think mostly USA. This is where the air travel taken has happened around 60s and 70s. So the societies and travel medicine started forming around 87, 88 and 90s. So travel has increased. So do we have enough data or exact data to say mortality and morbidity from travel to foreign land can cause significant travel? Yes, we have the data saying for every 100,000 travelers to a developing country, mostly these are Western data from temperate climate to developing countries like tropical. These are the data from 70s and 80s. So at that time, most of us are still developing countries. So 50,000 would fall. Will develop some health problem. 8,000 will have to see a physician. 5,000 will be admitted, and 1,100 will be incapacitated roughly. 300 will be admitted to hospitals. 50 will be air evacuated and bundled death. So definitely there is some degree of morbidity and mortality, and it's the same slide in different pattern. So what are the leading causes of health problems to the international travelers? I know tropical diseases are more common, the incidence is high, but the death most of the times happens from the motor vehicle accidents, and motor vehicle accidents is also a leading cause. The next in line is diarrhea, malaria, hepatitis, and malaria. This is, remember, this is from the Western literature. So those people are coming to tropical climates. So these are the things for them. I don't think we have enough studies people going from here, there, what is happening, how are they coming back, are they visiting, the systematic fashion so that we can evaluate at this point of time. At the same time, so as I said previously, this is a pattern of the lesson. What way do these, what I meant is, so around this 90s, these are the societies which have developed in Western. Green Book is essentially WHO, Yellow Book is CDC, and ICTM first meeting happened in 88, journals have happened, and around the same time the Asian Pacific Travel Health Society around 1990 started in Singapore or Malaysia, but so far they are active with the Western societies, but the activities compared to Western societies is still low. Then why in India we need a tropical hour, and as physicians and super specialty, why we need to familiarize ourselves? I have some data to show you. I just wanted to compare Western travel to us so that we can draw some comparisons. So most of the travels in Western is 30 to 50% is still to tropical climates like Mexico, China, Dominican Republic, India, Brazil. Most of the travels are to UK and Canada for them. And if you see this first, their travel is more for the tourists, 50%. Only 27% is for visiting friends and family. So why I have compared this both is we think when you are visiting your family and friends, you are in more safer environment. But the problem is you end up staying longer. The longer you stay in a different climate, you are more prone to adopt to their local environment and not paying attention to simple rules. Most of the times, these visiting friends and relatives type of passengers bring all these tropical diseases and multi-drug-resistant bugs to the Western world. That's what it means. So we have to see in comparison to West, are they in the similar patterns or different patterns? Definitely, I'm not sure how clear it is. These are the from air travel from Indian government website from 2000 to 2020. Please ignore 2020 because that's a COVID time. That data is not relevant for obvious reasons. The take place. And if you see the purpose of travel, sorry for this one, the leisure travel is same as the Western, and visiting family and friends is also about the same. But we are going from tropical climate to temperate climate. The infections will not be a challenge for us as we think from people coming from there to here. So these are different pictures of India with different numbers saying that we started traveling more starting from 2000. So the prime location, most of us are going are United Arab Emirates. And there is some tropical travel, but most of it is to the westernized society. And the most common reason for it is residency reality. I think 90% of our relatives are in other countries, so we know only 10% are staying here. So most of the travel is from India to foreign is non-resident Indians who are going back for their jobs and other purposes. Tourists is still second place, but students, employment and all, but most of them are entering back for their pre-residency entrance. And what about international travels within the country? This also has increased dramatically. As we see, people who are born in 80s and 70s, you notice prior to 2000 the travel was very limited, but after 2000 everybody, for multiple reasons, the travel has enhanced even within our family. So that is all reflecting. And these are the popular states. Apparently Tamil Nadu has the most visitors in compared to other states. This is the top 10 states which have visitors compared to other states. As I was telling earlier, it's a statement I want to reiterate. Travel medicine not just taking care of individual patients, but it is a sport where we can prevent pandemics. Because in one of my topics later, it is even post-travel care and all. This will be talked. So you have to identify things earlier, isolate, and so that you can protect your masses. So travel across the globe from India and to India has increased as well as within the India. And positive data is there. So we cannot just take what is available as a guidance for us, applicable totally to us unless we all start doing some research, put in some data and find out what are our real problems when our people are going outside for both visiting and then tourist purposes. So I'll just introduce the travel clinic before I go to the other topics, specifically individual cases. So I checked how many travel clinics we have, any designated travel clinics. The reason I checked is in CDC or in the International Society of Travel Medicine, if you go and try to look for travel clinic in a specific pin code or country or in a particular area, it will give you a list of the travel clinics, which will help us in pre-travel, during travel and after travel. In India so far there are only 5 registered travel clinics in Delhi, Mumbai and Chennai. Because I think mostly infectious disease doctors were there a little longer and they have registered their clinics in that societies. Typically, the travel clinics are run by the infectious disease doctors most of the times, but most of the primary care and internal medicine, other subspecialty do practice it off label, but most of the clinics are run by them. Until all infectious doctors, we have so many infectious doctors to produce and serve this country, we all have to step up and take up this role, not just for the patient purpose, even for friends and family reasons too. So, in India there is travel clinic. Doesn't really mean all travelers will go and get themselves checked before going some foreign country. No, only 40% of them go to their visits. Even in this 40% and they go, only 50% of them who visit the travel clinic will follow the rules that too for 2 to 3 days. So there is a huge degree of non-compliance. Even these patients go to the clinic. So it's not really translating having clinic. It doesn't mean it will translate into following the guidelines. The effectiveness of how you convince them and they follow and they take care of themselves so that they come back safely. Visiting family and relatives, as I said earlier, is the main reason for endemic infections. They bring back the infections to their country and spread it there. So usually this travel clinic works in 2 models. One is the physician will have the one-on-one consultation with the patient, get all their information in detail, demographic, their immunization status and their any comorbidities and decide where they are going. They go in detail about their itinerary, where they are going. Are they going, for example, a person in Chicago is coming, let's say go to India. If they are going to Delhi, stay there for 14 days is different compared to somebody who is coming to Chhattisgarh and doing safari for 14 days. The travel itinerary is so much different for the person in Delhi to the person who is visiting the forest in Chhattisgarh or who is coming from Mount Everest. How we approach and what we have to guide them will be very different based on their itinerary too. Not just the patient factors, even the travel itinerary also matters. And the second model, it is usually done by nurse practitioners and physician assistants. For them, there will be standardized templates to follow, and they have to work in close association with the physician. If there are any questions, they can call them. But it is run by the nurse practitioners and physician assistants, so that they can do all the checklists, and this checklist has to be updated every 2 months or 3 months based on the CDC and WHO guidelines. So ideally, in ideal world, you should visit 6 to 8 weeks before international travel so that you can sort out all the chronic problems under control. Make sure what immunizations you will require and what kind of precautions you have to take and make necessary arrangements. Usually these consultations are not like a OP 10-15 minutes, you have to schedule 45 minutes because you need to go in detail. And as I was telling in the previous slide, you have to take detailed history of all comorbidities, allergies. It's almost like HNP for an admission, so you have to know everything in detail. This is the same thing I was telling. I'm sorry it was a poor print. It's basically we dissect the itinerary of the patient, where they are going, how they are landing, how they are reaching, what is their mode of travel, and regarding the patient detailed history, their immunization history, and what are the where they are going to be staying continuously. Are they going to stay in hotels or are they going to just bunk up in some Airbnb? I don't know what are they doing exactly. You need to know. And patients also should be forthcoming to give you that kind of information. We should have that kind of time to do that. Same thing in a different pattern. So the most important thing is this: as you identified everything accordingly, you could get the information. The patient was very honest. Then comes the main deal: how you are going to deliver the information without scaring them to stop going to that place, or you give them certain precautions so that they can take care of themselves without falling in much bigger dangers. So it's about convincing them to take the certain immunizations. The main trouble is with chemoprophylaxis. I think for us it won't be a big trouble, but in Western world, chemoprophylaxis has to be started at least 4 weeks for some drugs, for some it's 1 day or 2 days, and follow up for 4 to 6 weeks. It's a huge burden on the patient's family. Usually when they come, they don't come singles, they come with a whole family. So a lot of things goes into that. So the same thing I put it here. Now the infections. So we discussed, they came to the travel clinic and we gave some more instructions and all. But how to go about these instructions? I'll go in this one. Infections. So the common infections seen in international travelers, again remember this is from people coming from temperate climate to tropical. They bring back malaria is the number one. Then leishmaniasis, diarrhea, rabies, dengue, meningococcal meningitis, encephalitis, and the rest of it. And luckily Dr. Ashikant covered most of it in the afternoon, so I will not go in detail. But I will roughly tell. So as a physician, once you get the information where they are going, you can go simply to CDC or WHO website. You can plug in different things where the patient is going, what are the current problems, what are the chronic problems, what does your patient need. So this is the prevalence of diarrhea across the globe. The problematic zones are the red obviously, and yellow is intermediate risk. These are the most common pathogens. For acute diarrhea, it is enterotoxin E. coli, mainly in Mexico and South America, Salmonella species, Shigella. Campylobacter is more problematic when people travel to the Southeast Asia. This is what we have to remember, and Vibrio, cholera, and essentially obviously Shigella, Salmonella, Campylobacter, E. coli and all. But 1% of the patients who develop Prader's diarrhea will develop chronic diarrhea in in-depth TRDR, end-up evacuation, cytospora, these have to be evaluated. So, this is the guidance from CDC to prevent the traveler's diarrhea. It's very simple, boil it. That is, you boil your water, it is 30 minutes. Cook it. You should eat only cooked food. Raw food like salads and all has to be avoided at any cost. Fruits has to be peeled. So if your fruit is not peeled in front of it, you forget whole thing. You should boil it, cook it and peel it. This actually goes good for even for us during the summer season, because that's when we see the explosion of diarrhea cases in the OP and in the hospital. And prophylactic antibiotic has no role, as the studies have done. So when to give antibiotics and what to give antibiotics. This is where the pathogens become important. So somebody who is having severe incapacitating diarrhea, fever more than 101, abdominal pain in some girls, if they are coming to Southeast Asia, we should think about Campylobacter, and we can guide them what to take if they are immunocompromised or if they have echo symptoms, as I said. If it's mild to moderate, no need of diarrhea, no need of treatment, just supportive treatment in the form of lot of oral liquids and ORS. So these are the antibiotics. Why this is important? Because the Campylobacter no more, the levofloxacin doesn't work for us, it stopped working long back. We have to give azithromycin either 1 gram once a day or 100 mg once a day for 3 days. If it's Mexico and all, rifaximin and rifamycin, levofloxacin, ciprofloxacin still works there, so that can be the choice you can suggest to them. So malaria, I don't think I need to reinforce again. These are the areas where it is mainly important. So if you see, the African subcontinent is a place where you have to be very careful about this malaria prophylaxis. Although there are places in India, but I think chemoprophylaxis, it depends on the way where their patient is going. If they're going in urban area, it's reasonable, but if you're going in the rural population or close to the nature, then you have to suggest them to take the chemoprophylaxis. This is the slide showing, mimicking the rainfall and the intensity, how the peaks and valleys of malaria happens. So these are the peaks of rainfall with this is the temperature. These are the dark black are confirmed cases, and white boxes are basically malaria peaking is very obvious after the heavy rainfall, and there is so much huge disparity between confirmed cases and suspected cases. If you are not sure, patient going to different country, you are not sure about the malaria situation of that, there is an excellent page in CDC which goes by each country. I just did few. For starters, I did 8. So they give you what type of malaria is common, what is the preferred thing, and what are the months we should be careful. I just put in India. This is what we get. So if you are not sure, you can check that and then guide the patient accordingly. So for us, it won't be much problem because we are anyway in endemic zone. But you can always guide. They're going to Africa because the safari is a big thing. Most of the people are traveling. You should still be able to guide them back. These are the few. These kind of handouts will help patient to how to protect them safely from malaria, what to do and what not to do. Of course, clean the doors and protective care, complete covering of the body and repellent if possible, not emptying the containers and water holders frequently, and having a fan and nets, and especially to avoid mosquito exposure between dawn and dusk. These are the simple things which can prevent. Even if they don't take chemo prophylaxis, something like that if they had it here, at least the chance of infection will come down. These are the chemo prophylaxis for different types of malaria. I am not going into detail. This is something which everybody can easily understand and guide your patients accordingly. I just put it different, and this is one more big thing, but the chart is not clear. For dengue, it is the same thing. You have the maps again from CDC based on where they are going and season. You can always guide them how to take care of it. Same as the mosquito bite prevention kind of situation. And dengue activity, this is as of today morning, the CDC's dengue activity for last 3 months. So everything is there, it's easy for us. It's a dengue is notifiable, this is even for us. So everything we notify, it will go to the WHO and CDC and we can see the activities. Japanese encephalitis is more common in this part of the world, but it's usually in the rainy season. But we need to have not just mosquitoes, we need to have even aphids and ticks as a host. Then only the proliferation of virus happens tremendously and the transmission of the disease can happen. Having just mosquitoes will not do the trick. You need to have the zoonotic part of it. This is what it's saying. And this is for people staying in rural areas more than 1 month in proximity of the animals which I just spoke together in a proper right season can cause you this Japanese encephalitis. And I'm not going into detail of treatment at all, that is already covered in the molecular. This is an Ebola epidemiology, not much concern for us, but if anybody is going to South America, you can go and back and check in CDC and guide. Yellow fever is akin to sub-Saharan and African area. As the morning the question was posed, where can anybody yellow fever? No, it's only Institute of Prevention Medicine. We have one in Narayanpura, I guess, that's the only place, and that certification is only valid. We cannot give at our own use and practice the yellow fever vaccine. Now coming to the vaccinations. Sure, it is clear. So the final conclusion in vaccination in different papers is, one is definitely how to make sure the patient is updated with the current vaccination according to the age and the season, like flu and all. Specific vaccination is only recommended based on the place where they are going. Mostly it's for the Western. For the typhoid, fever and hepatitis A, I think it's mandatory even in the Western. Now here also it's given to the kids. So the typhoid and hepatitis is something which we have to be careful. The Japanese encephalitis and all is basically if they're going to stay in that particular area, as I said earlier, then only it's recommended. And rabies is for veterinarian workers who are going to work in that kind of situation when they're coming for the work-related issues. Major focal is actually they're staying in the, mostly for the students, they're going to stay in the dorms before 20 years of age. Even that has a parent waiver. If the parent doesn't want the kid to get major focal, they can write the waiver, but that is usually recommended. But usual consensus is just to give the vaccines which are obtained, and especially if you vaccine, Tuesday to Friday. And typhoid vaccine is the one which is recommended for the Western when they coming to the Southeast Asia to give the vaccine, because most of the typhoid cases are from the Southeast Asia. You have two forms, oral and injectable. Injectable is single dose, but oral is 4 dose every alternately. And the safety starts immediately after you finish your 4 dose. So infections, vaccinations is covered. Is that all travel medicine? That's what the bottom line of my topic. There's a lot more preventive things we have to do when we are going, either coming from temperate to tropical or tropical to temperate. The very first thing is DBT prophylaxis. How to talk to your patients. It's not something we can, I gave vaccines, I gave them guidance how to take care of themselves from malaria and all, that's not enough. There are so many other things we have to educate which can kill the patient much more dangerous. As malaria happens, typhoid happens, but at least it's relatively treatable. But most of these kind of scenarios are not, they are very actually severe form of diseases which can kill the patient if action is not taken immediately. I'll talk about DVT next. There are few things I'm going to talk here. Chronic medication during travel, including psychiatric medications. There are a lot more people cannot bear of psychiatric diseases because of in foreign land and mission situations, being isolated. They can have both suicidal and homicidal thoughts. Food and water safety talked before, avoidance of animals, and this basically prevent rabies. Road accidents, because the road, across the globe we are not having the same road rules, so you need to be aware of the road rules of the country you're going. Pregnancy is a high-risk situation to avoid travel, but second trimester is usually definitely reasonable to go. But pregnant patients or anybody who wants to get pregnant next 3 months, avoid foreign travel in places where there is malaria. That is rule. Rule has to be followed because there's not much medications that can be given as chemoprophylaxis or treatment, at least in first trimester. Then patients with immunosuppressive status. So all of us now doing transplants and also all transplant physicians and surgeons should be aware of travel medicine because they are the patients will go to them first, so they have to be aware of where they are going, what they are going to do and all. So every specialty or subspecialty of medicine has to be aware of travel medicine nowadays. CKD patients on dialysis, now we cannot let everybody stay in one place, just take care of your dialysis. If somebody wants to travel to dialysis, they are based at dialysis, the place of destination, but that will take time and arrangements, but that can be done. So the other thing, high altitude, as a physician sitting in Hyderabad, this is the first year I got in April, around 4 or 5 patients coming for clearance for this mountain base camp climbing. It was surprising, 50% of them think that if you're safe enough to go, the how sickness will not happen to them. That's what their thinking process. When I have talked to them, they were surprised, but they really understood it and they wanted to take the risk. Even it's an informed concern. Understanding the risk, going to base camp, it's okay. Not understanding the risk, just thinking, doctor writes clearance, nothing will happen to me. That is not fair for the patient to go through such a trauma. And scuba diving also needs a certain clearance here from trauma bar or trauma, those are important. Jet lag will talk later. These are the special travel. I think the time is over. I'll skip this one. And these are the prophylaxis medications for malaria, altitude, estelazomide. If they don't want to descend, that is the one you can give. But if the first sign of any visitors, if they want to come down, then DEXA can be given for 3 to 5 days. Motion sickness, copalmin, patches, and that. DVT prophylaxis, these are the risk category, low risk, more than 40 years, obesity, recent surgery. High risk patients, major surgery lasts 4 weeks, thrombophilia, previous cerebrovascular accident, current cancer, palliative. These ones you have to give function stockings and low molecular weight for injections. Basically, any travel more than 4 hours is considered high risk. So you have to ask them to walk every 2 to 3 hours once, hydrate themselves. If they fall into high category, high risk category, give them low molecular weight to take with them travel clearance is the one which can bring us trouble in terms of medical legal. You have to be careful when giving travel clearance, especially air travel. All the airlines have guidelines for what disease, how many days, what is the patient situation. You cannot just, because they are friends and family, they insist, please don't do it and don't put yourself and your loved ones in risk post and discharge long distance air travel. And it's very specific for disease diagnosis and patient condition. And especially if you are discharging somebody on oxygen or conditions that decrease oxygen delivery like cardiac diseases, anemia, and respiratory, you have to consider doing high altitude stimulation tests. Basically, you give a lot of nitric acid and oxygen mix in you mimic the cabin as if they are in 8,000 feet and see if their oxygen levels falls or not. This is actually, that's where in Chicago when I worked, I was aware of it. I don't think we are doing it in Hyderabad. At this, I think so far it's not that much for us to travel immediately when we're sick, but in West it's a broken system. So there are more of the families, and it's a central, O'Hare is a central airport, lot of ins and outs from the O'Hare happens, there are connecting flights. For them to stay in Chicago itself will be very costly. You have to put them on the test. If they require supplement oxygen, needs to clear, but rarely 10% of them you couldn't clear for 6 weeks. So this is something we have to think when the patients have cardiac diseases, anemia, pulmonary hypertension, whether to really give the clearance or we have to put them through this test. Resources for the patient travel. Not necessarily if it's an educated smart patient, you can give them the CDC and WHO websites and they can go and do and see what they need. Most of them are educated like that. And how to self-educate as care providers. We have so many journals, CDC and WHO, ISTM is enough. And there are a lot of textbooks. And good news is in 2024 they have travel medicine, 14th conference in India. So any of you who are interested and want to learn, you can join there. And we just did our own memo for physicians. How many patients we are seeing here who require travel clearance. 60% of them were students and 20% were visiting family and relatives. This is the group where we have to make sure they're long, chronic, non-communicable diseases, stable like diabetes, hypertension, or there is for any cardiac diseases or routine screening clearly how you do. And mountaineers and tourists for other part and pilgrims. So few tips, it's a 30 to 45 minutes appointment time. Maintain list of patients who are going to the international travel and try to follow them if there are any issues so that you can collect your own data and you can do your own papers and publish so that there is a data what exactly we should know when our people travel across the globe. And pre-printed handouts will have detailed itinerary, patient history. Once they cross your room or town, please don't try to give advice over the phones and try to manage the patient over the phone. Ask them to seek the advice in their local area where they are. They should know whom to go, when to go. We cannot manage patients, even though if they are your own relatives or friends. Please ask them to seek the advice. And advice should be beyond infections. That's what I felt at the end of the reading, detailed reading. And what is the take-home message? Yes, it's dangerous out there, but we as a guardian angels, I can call ourselves like that, we can make their trip pleasant, safe, we both safe and return back in health, and update ourselves, and any physician should, whoever is interested in especially infectious disease should update on these kind of things. And even any discipline you are in medicine, you should update yourself of these travel restrictions and all. And try to collect the data, especially computerized note system. You can collect so much information and make research as part of your profession so that the next generation can use it and improve on it. And thank you for being part of our journey.
Thank you, madam. This travel medicine branch of medicine is also a neglected branch. So we need more and more awareness about this. Thank you for enlightening us about this branch. Anyone want to ask any question?
Ma'am. been really an eye-opener. Basically a great travel medicine, but your talk was excellent. Do we have any pre-structured questionnaires in CDC, like for any travel, anybody who's traveling, do we have a downloadable forms for clinicians?
Yes,
where
yes.
they can
There's
download
lot of information. It's just if you're practicing in a single place, probably you have to do it. But if you're in a corporate setup, you can take help of some nursing or somebody. You can download those pre-printed forms, and there is plug-in things. Even the patient, even not necessarily you need to do your first consultation. You can train a nurse or a nurse practitioner or physician assistant, or if you have a students who are in OP, you can train them. So that once they have the information, you can save time for both patient and yourself.
any prescription, your thoughts about long-term medication prescriptions, like they go for 6 months. So do you advise them for 6 months?
So what I do is, usually if they are my patient, at least see me once or twice, or they came up with a recent record for last 2-3 years, seeing other doctors, I give the prescription. I don't give any hypnotics, I don't give any antibiotics, standard medications. I tell them if you have a fever, take Tylenol. If you have cold and cough, go get Erythra. And if it's anybody above 50 with comorbidities, I make sure they have insurance. I ask them to get in touch with the primary care doctor appointment immediately. Most of the travelers' insurance is qualified for urgent care and emergency and even a primary. So if their kids or family is there, they can take most of our population visitors and relatives who I see in the clinic. Travelers is not aware, we have to make aware of this branch, and you need to. So most of my clinic patients are only visitors of friends and family. So for them, I make sure they take an appointment with the doctor there so that they have access to help. That's all you have to do. No problem.
Excellent, Dr. Nanda. I think this is an area where prophylactic medicine can be practiced very well, and educating the patient and patient's caregivers or whoever is going along with the patient or whoever is taking care of the patient there can be given thorough instructions about what to look for and what to be warned about. As instances, our eyes are always on the vitals actually, so if somebody comes to me, friends and family come to me with queries regarding travel, especially patients come to us not for advice regarding dengue malaria, because most of them are traveling either US or UK. And more commonly in the vacation time, as you said, high altitude areas. So I try to give them some nuggets about how to identify hypoxia or hypotension or what can happen in extremes of temperature and how much of exercise can be done. You go out for long leisurely walks and you go out for treks in the altitude region. And one of the other things that I warn them about and to keep note about is access to healthcare in the places where they go to. Sometimes they go to places like Nepal or Bhutan or somewhere where there are not many hospitals immediately like available here. So how to look for symptoms which are sinister and what to be done immediately, what help can be sought for immediately is something that I try to tell them about. This is an excellent area which can be nurtured, I think. Maybe Medicover Hospitals, maybe I started traveling around the city, but Chennai and Bombay. Good one.
Thank you. And if you see all the topics, everybody wanted travel history. So undercurrently we ask that, but we don't pay attention when we are traveling. So travel is fun, but you have to be safe first. Better to be safe than be sorry. Okay then. Thank you.
Now I request Dr. Shoaib Ahmed Khan, consultant nephrologist and transplant physician, to facilitate Nana, Nikhil sir and Srilata.
Okay.
management for giving me this opportunity. Before going to the topic, I would just like to give a brief introduction. All of us know what is antimicrobial stewardship, right? All of us know what is antimicrobial stewardship, that is judicious use of antibiotics. But coming to the diagnostic stewardship, both antibiotic stewardship and diagnostic stewardship go hand in hand. So today we are going to discuss about the diagnostic stewardship. So diagnostic stewardship is defined as the coordinated guidance and intervention to improve appropriate use of microbiological diagnostics to guide therapeutic decisions. It should promote appropriate test ordering, specimen collection, pathogen identification, and accurate and timely reporting of the results to guide the patient treatment. So the diagnostic stewardship starts from what test to order for which particular patient till the proper reporting of the results and timely reporting of the results. So this is what is diagnostic stewardship. So it begins with the procedures that guide the specimen collection, completion of the clinical, demographic and epidemiological data, that is the requisition form should be accompanied with the sample whenever that is sent to the laboratory with all the clinical history, the diagnostic history, the antibiotic history, if anything is there. Then includes the correct storage and transportation of the specimens, how laboratories receive, register and process these specimens, then how appropriate tests are selected and performed for each particular investigation, and how the results are reported and interpreted. So all these are a part of the diagnostic stewardship. So it starts with the test to order for which test to start for which patient, and which sample has to be collected for what particular diagnosis, and the timely report has to be given. So what are the goals of diagnostic stewardship? It is choosing the right test for the right patient, generating accurate clinically relevant results, and right time to optimally influence the clinical care. That is the right test for the right patient at the right time, and it is nothing but the judicious use of the test. So what are the objectives of the microbiological stewardship? It is to deliver the safe, effective and efficient patient care, which is guided by the accurate and timely diagnostic results, including the AST results, that is the antimicrobial susceptibility data, and also for the antimicrobial resistance surveillance data also it gives. So this is the diagnostic pathway which is given by the WHO. So this is nothing but it shows the diagnostic pathway how it should be followed. First, the patient presents to the healthcare facility. Then the clinician sees the patient, takes the complete history and makes a diagnosis. Then the clinical staff and then orders the test. What particular test has to be ordered, that is also very important. Then he orders specific test. Then clinical staff collect the sample. Then clinician starts the patient on the empirical treatment and he waits for the culture reports. Then the specimen and the patient information are sent to the laboratory. Laboratory staff receive and process the specimen, and the transportation of the sample is also very important. What temperature the sample has to be transported. Then the laboratory staff send the patient laboratory results to the clinician and also the surveillance team. Whenever we get any sample to the lab, what we do is we do the preliminary test, that is the staining. Staining, if we find anything abnormal in the staining, immediately we have to inform the clinician because there may be change in the treatment. And also in the culture, whatever we see, the preliminary culture reports, they should also be informed the clinician immediately. Then after releasing the report, the clinician interprets the results. Then based on the results, the escalation or de-escalation of the therapy takes place. So this is the diagnostic pathway. Coming to the laboratory pathway, what exactly happens in this laboratory pathway? It starts with the pre-examination, that is the patient or the client preparation, that is the sample collection. Sample collection is the most important thing in this laboratory pathway. Whenever the patient, we have to collect blood samples for any patient, for example for blood culture. Proper skin decontamination is the best sample. But if the tissue sample cannot be taken, then the next ideal sample would be swab. But if the wound is very big, at least 3 to 4 swabs should be sent from different sides of the wound. It should not be a single swab, it should be at least 3 to 4 swabs covering the entire wound surface. Then after we receive the sample in the lab, we do the competency testing in between the technicians also. So even that is also done. Then we receive the sample transportation, and for each test there is a quality control or quality check which is done in the laboratory. So this comes the examination. After examination, the post-examination is we maintain all the records, whatever are reported, and then the reporting is done. This is the laboratory part.
proper clinical history and sending only appropriate tests is the diagnostic stewardship. This is the most important point. Because sometimes what happens in these serological tests, many times there are many cross-reactivities which we generally see. So it becomes difficult to interpret the results and give treatment to the patient. So that is the reason only appropriate tests have to be ordered. Then wrong time of ordering the test. For example, in typhoid fever, in the first week the blood cultures will be positive, in the second week the antigen antibody reactions. But if the viral test is sent in the first week, it will come negative. So that is the reason the right time of ordering the test is also very important. And wrong sample collected. Proper sample has to be collected for any suspected disease. Wrong container and inadequate volume. This volume is important for the blood cultures. Then delay in transportation. If there is a delay in transportation, then the contaminants may overgrow the pathogens and we may not get the accurate results. Then incompletely filled requisition form. If the requisition forms are completely filled with the diagnosis and the antibiotic history of the patient, it becomes easy for the microbiologist to interpret the results and carry out any further investigations if required. And poor quality specimens. So these are the common pre-analytical errors. And what are the considerations before ordering the test? Is the test really indicated for a patient? And will the test result influence the clinical care of the patient? That is, if we send this particular test and if it turns to be positive, then will the treatment change? If the treatment will change, then only the test has to be ordered. Or else there is a cocktail aphorism, that is, before ordering a test, what will you do if it is positive or negative? If both the answers are same, then do not do the test. Then the test is not recommended. And the third important thing is TAT. The turnaround time of the test is also very important. And was the sample collected before starting the antibiotics? This is the most important part, especially with urine cultures and blood cultures. Always the samples has to be sent before starting the antibiotics, because if the sample is sent after starting the antibiotics, then the pathogens may not grow. But sometimes there may be a doubt that the patient is already on any antibiotics, then when to send the sample. During this time, just before the next dose of that particular antibiotic, the sample can be sent. Then which specimen to be collected and how to transport the specimen. Choosing the right test. Now patient comes with symptoms and clinical history is taken and physical examination is done. After that, we estimate the pre-test probability. If we have the pre-test probability by sending the test, if there is any chance that it turns out to be positive, then only that investigation has to be done. Then choosing the right test. Choosing the right test, the most important thing is the diagnostic utility, the performance of the test, that is the sensitivity and the specificity, the cost effectiveness of the test, the clinical impact of the test, and the lab feasibility. All these points have to be kept in mind. And right time, at what time the sample has to be sent. Sample has to be collected at the right time, that is whenever the patient is having the symptoms and before starting the antibiotics or before giving the next dose of the antibiotic. And reporting at the right time for decision making, that is timely communication once the testing is complete. All the preliminary reports have to be informed immediately. Then general principles of sample collection, this we already discussed. It is collect the samples before starting the antibiotics or just before the next dose, with minimum contamination and as close to the site of infection as possible and during the acute phase of illness. And if more than one blood tube is ordered, then we have to follow the order of blood collection. Then adequate sample containers should also be used. We have to check the expiry dates of the containers and the transportation time, within how much time it is transported to the laboratory. Adequate volume is important for blood cultures especially, and transport the sample as early as possible. So this is the sample request form. It should contain the patient identification number, the patient name, age, gender, and the what type of sample is it, the date of sample collection, along with this from which ward the sample has been sent, the patient diagnosis, the medical history, antibiotic history, the name of the collector, and the type of the wound. Many times we get the requisition forms telling it's a wound swab or tissue, but particular site is important. It has to be written on the requisition form wherever that is sent to the laboratory, because wound swab from abdomen or wound from the perianal site, the organisms may differ, and it will be easy for during the reporting. So the type of the wound and site of the wound is also very important, and date and time which is received in the laboratory, that also has to be noted. Now rationing for information on the requisition form. It allows the correct interpretation of reports by the laboratory, allows differentiation between the
clinicians should be kept informed of when they can expect to receive the results of the tests which are submitted in the laboratory. They should be informed that if the smears are submitted, in what time the smear results will be updated, or at what time the culture reports will be updated, which will help to guide the empirical therapy. Now coming to the blood cultures. So send blood cultures only when clinically indicated and not as a routine. So blood culture yield depends upon the patient selection. That is, whenever the patient is having any signs or symptoms of sepsis, then only blood cultures have to be sent. Then the time of antibiotic administration, that is, the sample has to be collected before starting the antibiotics or just before the next dose of the antibiotic. The collection procedure, how the sample is collected. Volume collected, that is, in each bottle 8 to 10 ml of blood has to be collected. More the volume, the yield will be more. The number of sets collected, how many sets of blood cultures have to be collected. The time of collection, that is, whenever the patient is having the symptoms. The site of collection, that is the peripheral line or from the central line if there is suspected catheter-related bloodstream infections. How the blood culture bottles are transported and storage of these bottles. Unlike other specimens, blood culture bottles should never be refrigerated. They should always be stored at room temperature, the empty bottles as well as the bottles containing the blood. So indications for blood cultures. So the clinical evidence of whenever there is clinical evidence of sepsis or septic shock, fever of unknown origin, suspicion of infective endocarditis, new fever in clinically ill patients, even if the clinical findings do not strongly suggest an infectious cause, or an immunocompromised patient with underlying conditions that predispose for bloodstream infection. These are the indications for the blood cultures. Now, blood culture volume, this is the most critical factor. How much volume of blood has to be collected in each bottle? It is for adults 8 to 10 ml per bottle. In children it is 1 to 5 ml, and in infants it is 0.5 to 1 ml, and single aerobic bottles enough in infants. Blood culture sets. So for each patient, 2 sets of blood cultures have to be sent, and each set means it is 2 bottles, that is 1 aerobic and 1 anaerobic bottle, or 2 aerobic bottles. So per patient 4 bottles has to be sent. And whenever there is suspected infective endocarditis, then 3 sets have to be collected. And for suspected catheter-related bloodstream infection, 2 sets have to be collected, 1 set from the central line, the second set from the periphery. Timing of the blood cultures. They have to be collected as early as possible within the first hour of recognition of sepsis and before the initiation of the antimicrobial therapy. So time different sites it has to be sent. So the transportation of the blood culture bottles, they have to be transported immediately. If delay is anticipated, then store them at room temperature. You have to never refrigerate because cold sensitive pathogens like the Haemophilus may be killed, and empty blood culture bottles should also be stored at room temperature. So interpreting the blood culture results. So whenever we get the blood culture bottles, when we isolate a pathogen from any single bottle, we take it as a pathogen and release it as a bacteria. But when there is isolation of low virulent skin organisms like cons, coagulase negative staphylococcus from single bottle, then we generally consider it as a contaminant. But when the same low virulence organism is there in all the 2 blood culture sets, then it may be a pathogen. So we generally process the blood culture and we consult the physician because we directly don't know the condition of the patient. So we have to discuss with the clinician. So what is CRBS, a catheter-related bloodstream infection? When both the central line and peripheral line blood culture bottles flag positive and the central line blood culture bottle flags 2 hours before the peripheral line, it is called as the catheter-related bloodstream infection, and during this situation the central line has to be removed. And when both the central line and peripheral line blood culture bottles flag positive but they flag at the same time, then it is a bacteremia and not from some other source. And if only the central line blood culture bottle flags positive and the peripheral line is not flagging, then it is a polarization of the central line. Coming to the stool cultures. So stool specimens should be collected in clean specimen containers. They have to be transported at room temperature to the lab and within 2 hours. The urine cultures, the indications for collecting the urine cultures, wherever the patient is having any fever or systemic leukocytosis with no other cause, and in a non-catheterized patient, urine culture has to be collected. Or if the patient is catheterized and having fever and systemic leukocytosis,
not be sent routinely. But in asymptomatic patients, what are the indications of sending urine cultures in asymptomatic patients? These are the only 3 indications. The first one is in pregnant women. The second one is pre-operative urinary tract surgery. So the patient is going for any pre-operative urinary tract surgeries. Or the third one is the patients who recently received a liver transplantation. So these are the 3 indications for sending urine cultures in asymptomatic patients. So sample collection, what sample has to be collected for the urine culture? The most appropriate sample is a clean cash midstream urine or suprapubic aspirate is also collected. And if the patient is catheterized, then Foley's sample should be collected, but it should not be collected from the urine bag or the Foley's catheter tips are not acceptable. The urine, the Foley's has to be clamped and then only the sample has to be collected. So the summary, when should a sample be collected? Whenever the case definition is fulfilled and prior to the antimicrobial therapy. And what kind of specimen should be collected for the bacterial culture? Appropriate specimen from suspected site of infection according to the case definition. So how should a sample be collected? Strict aseptic precautions have to be followed, and using the correct material and the container, then adequate amount of sample has to be collected and proper transportation has to be maintained. And it should be transported within 2 hours to the laboratory. So send specimens for testing only when clinically indicated. Always collect the sample before antimicrobial administration. Focus on asepsis, the site of collection, the volume and transport of the specimens. Always send paired blood culture specimens. More the number of sets, better is the yield. Don't treat contaminants or the commensals. Always choose the antibiotics carefully based on the spectrum, the drug bug, the PKPD combination and the parameters. Insist for interpretative reporting. When in doubt, consult the microbiologist. So coming to the next topic for discussion, this would be the interpretation of the AST report, that is the antimicrobial susceptibility report. So from the laboratory, we generally do the, whenever a culture grows any organism, we identify the organism and do the sensitivity test. So how to interpret the sensitivity result? So there is something called as the cascade reporting. So what is this cascade reporting or selective reporting? So generally we categorize the drugs as the first line, second line and the restricted drugs. So these are the first line, second line and the restricted drugs. So based on this, we generally release the reports. And most of you might have seen we write sensitive, intermediate, resistant and STD in the report. So what do they actually mean? Sensitive is nothing but it indicates the antimicrobial agent is clinically effective when it is used in the standard dosage. It means that whenever a drug is sensitive, it can be given to the patient for the treatment. Resistant means it does not work for the patient, so it cannot be given. So what is intermediate? Many times we see that few drug bug combinations, few antibiotics are intermediate. So what does this intermediate mean? It indicates that the antimicrobial agent may still be clinically effective when given in higher dosage, but there are no clinical trials available. And what is STD? There is a new term which is recently added in the CLSI guidelines, that is STD, susceptible dose dependent. So this susceptible dose dependent indicates that the clinical trials have confirmed that the antimicrobial agent can be clinically effective when used in increased dose or frequency. So it is not same as intermediate. Intermediate means there are no studies that by giving the higher dosage it will work. But for STD, there are studies that if we increase the dosage or the frequency, the drug may work. So CLSI has given few drug bug combinations where this STD is there. It has also given the dosages, what dosage has to be given for what particular MIC. So examples for this is cefepime and piptaz for enterobacteriales, ceftaroline for Staph aureus and daptomycin for enterococcus. So for all these 4 drug bug combinations, the susceptible dose dependent breakpoints are present. And this is according to the CLSI guidelines. Cefepime for enterobacteriaceae. If the MIC is 4, then 1 gram 8th RE or 2 gram 12th RE has to be given. Or if the MIC is 8 microgram per ml, then 2 gram 8th RE has to be given for cefepime. And for piptaz, if it is 16 microgram per ml, the MIC, then 4.5 gram 6th RE as a 3-hour infusion or 4.5 grams an 8th hour infusion. Every 8 hours as a 4-hour infusion has to be given. So this is the standard guidelines which are given based on the MICs. CSF or urine specimens, we do not report particular antibiotics, or if we report also, they do not generally work. So the examples for this is for CSF, we generally do not report the agents administered by the oral route. The first and second generation cephalosporins, clindamycin, macrolides, that is erythromycin and azithromycin, tetracyclines and fluoroquinolones, because they generally do not cross the blood-brain barrier. So they are not reported, even though they are sensitive, they are not reported in the CSF specimens. For the urine specimens, clindamycin, macrolides, digicycline and chloramphenicol are not reported, and for respiratory specimens, daptomycin is not reported. So this is the site-specific reporting of the antimicrobial agents. Now coming to the Stenotrophomonas maltophilia, this morning already sir has discussed based on the intrinsic resistance. So this Stenotrophomonas and Burkholderia are intrinsically resistant to many drugs. So there are only breakpoints available for these particular drugs, that is ticagrelin, clavulanate, ceftazidime, minocycline, levofloxacin and cotrimoxazole, for which this particular organism works. Even for Burkholderia, if a patient is intrinsically resistant to all the BLIs and other carbapenems and also the polymyxins, so only these particular antibiotics work. Coming to the clinical use of fosfomycin. So fosfomycin is being used for the urine cultures. So what is the clinical use of fosfomycin? It is the most common oral therapy for UTI and FDA approved, and it is also being used as a parenteral therapy for other wide variety of infections for pyelonephritis or osteomyelitis or IV line infections. But as per the CLSI guidelines or UCAST guidelines, the breakpoints are available only for E. coli and Enterococcus fecalis urinary isolates only. So that is the reason we do not report fosfomycin for the other samples other than urine. We only report fosfomycin only for the urinary isolates. And coming to colistin, whenever colistin is reported, the clinical and PK/PD data demonstrate the colistin is of the limited clinical efficacy. That is why all of you might have seen the culture reports. Whenever we release, there is no sensitive breakpoint for colistin. Colistin always has the intermediate breakpoint. There is no sensitive breakpoint because there is limited clinical efficacy data. So that is the reason the sensitive breakpoint has been removed. And whenever any other alternative agents are available, that should be chosen over the colistin. But if only colistin is sensitive and other all are resistant, then colistin should not be given as a monotherapy. It should always be given with some other synergistic agent, and the loading dose should always be given. Then MRSA versus MSSA. MRSA, all of us know this MRSA and MSSA, but many times what happens is even for the MSSA infections, vancomycin will be given to the patient for the treatment. But many times vancomycin can be given, but we have to consider that cloxacillin or cefazolin is much superior to vancomycin in MSSA infections. And for MRSA, all the beta-lactams have to be avoided except the 5th generation cephalosporins, that is the ceftaroline and ceftobiprole. Whenever we isolate any MRSA and VRE cases, that is the vancomycin resistant enterococcus, the infection control advice should be there in the culture report. It should mention that strict hand hygiene has to be followed, personal protective equipment has to be worn, patient placement should be there in the isolation room. If isolation room is not available, then the patient has to be cohorted. Ensure a spatial separation of 3 feet distance. Patient dedicated equipment has to be used, and the patient has to be transported following the appropriate infection control measures. So this comment should be present in the culture reports. So this is how we generally follow. This is an MRSA report and we give the infection control advice. Coming to the intrinsic resistance, this is already discussed in the morning session. So the intrinsic resistance comments should always be added in the culture report. The most important drug-bug combinations where the intrinsic resistance is important is for Serratia, Proteus and the Providentia. It is intrinsically resistant to colistin and polymyxin. So the culture report should always contain the intrinsic resistant comments. And Enterococcus gallinarimum cassili flavus is intrinsically resistant to vancomycin. Next, coming to the MIC interpretation. This is the most interesting session, I feel. This is the first case which I wanted to show. So here is a culture report showing E. coli grown in a urine culture having 10^5 colony count. And the ones which are marked in red, it is sensitive to these particular drugs. So which drug to choose for this particular organism now? sensitive to amikacin, fosfomycin, gentamicin, imipenem, meropenem and cotrimoxazole. So which particular drug to choose? Any DNVs who can answer? Amikacin. Why do you want to choose fosfomycin? Yes, sir. So which drug to choose? For this, we have to calculate the therapeutic index or the break point to MIC quotient. It is nothing but the break point to MIC quotient is calculated as the susceptible break point by MIC of the test isolate. So whichever drug is having the highest therapeutic index, that will have the best therapeutic efficacy. So here we have calculated the therapeutic index for these all the drugs which were sensitive, and here we see that the therapeutic index is high for ertapenem, fosfomycin, imipenem and meropenem. All are having the same therapeutic index. Then which drug to choose? Then we have to go according to the cascade reporting. In the urine cultures, the fosfomycin will act as the first line drug. Okay, so this is the first point. Second thing is, this is the MIC guiding table. So the MIC guiding table, whichever dilution is present from the most left side, that is having the best therapeutic efficacy. So here ertapenem, fosfomycin, imipenem and meropenem, all four are present on the left side of the table. But when we go according to the line of the drug, since fosfomycin is the first line, here fosfomycin would be the drug of choice. So here fosfomycin would be the drug of choice. So how to choose the drug of choice? If all the drugs are sensitive, then we have to block the second line in the restricted drugs, that is the cascade reporting. Then we have to calculate the therapeutic index for the first line drugs. But even if the therapeutic index for the second line and the restricted drugs is high, that will not be considered. And the drug with the highest therapeutic index and the first line, and which is to the most left of the MIC guiding table, that will be the drug of choice. This is the second case. Here we have a pus sample that is from the renal axis side. Klebsiella pneumoniae is growing. Here all the drugs are sensitive. So here we calculate the therapeutic index for all the drugs. As we can see, the highest therapeutic index is there for cefepime, that is 16. But cefepime is a second line drug. Many oral drugs are also available. So here comes the cascade reporting formula. So even though the cefepime has highest therapeutic index of 16, it belongs to the second line. But since all the first line drugs are also sensitive, the second line drugs will not be taken into consideration for the drug of choice. So here among the first line drugs, amoxiclav, ciprofloxacin, ceftriaxone, cefuroxime and cotrimoxazole. All of these have a therapeutic index of 4 and 2. But when we see the MIC guiding table, only amoxiclav, ceftriaxone and ciprofloxacin are present on the most left side. That is, the MIC is present on the most left side of the MIC guiding table. So any of these three drugs can be given. Either amoxiclav, ceftriaxone or ciprofloxacin would be the drug of choice for this particular patient. If it is oral, then amoxiclav or cipro can be given. If the patient is admitted, then ceftriaxone can be given. So coming to the communication skills, talking to each other is very important, listening to each other is very important, being patient and documenting whatever we are informing. All these things are very important and we have to get to know each other. I being a clinical microbiologist, I should not think that I should sit in the lab and only do the lab work. It should be like I should go and speak to the physicians and have a friendly relationship with them. It should be a didactic thing whichever is followed. And whenever we inform or report to a nameless, faceless person, there will not be any reliability. But when we know each other and discuss things, then only proper reporting or interpretation of the reports can be done. It should always be an evidence-based medicine and multidisciplinary formation of the team. And more directly involved the two teams are, the more likely they will be to communicate openly and deal with issues collaboratively. So we have to always put ourselves in the other's shoes and we have to mock a mind. And micro and clinical tools should always be done and we have to spend time in each other's department and discuss the cases. The golden lines are communication, documentation, the communication of documentation and documentation of communication. Thank you.
important few things you were telling about coordinators, especially Vidal, first week of fever, we keep seeing it. We should refine ourselves, and most of them we do, but we should also educate our new generation doctors. Especially the important eye-opener for me was usually collect blood samples when there is fevers and chills. We have to ensure whether nurses are giving that space of half an hour between different sets. Unless we keep checking with them and ensuring each time is repeated from our side. I was surprised that it will be interpersonal, lab personal, competency, evaluation.
But we check on a monthly basis. We give one test to two different technicians and then we check the spheres, how they are doing or how they are processing the samples. So that is generally done in the laboratory.
And we are all in corporate setup, we talk to each other. Do you think anything you can suggest for when somebody has clinic in the community and we do see infections? Most of the times the patients require blood cultures, we always send to the lab where we can communicate. But if somebody is doing entirely practice in the community, do you think what are the tips you will give them how to get in touch with their microbiologists, or just they have to make an effort to a particular lab and talk and any suggestions from your side? That's what I'm asking.
Whenever somebody has to send the blood cultures on any OPD basis, they first need to consult the general practitioner only. So then they can guide them or they can
general practitioner to microbiologist in the community. Anything you suggest, or it's just the practitioner has to make an effort to know their lab pathologist and microbiologist.
That they need to know, and if they have any doubt, they can ask the microbiologist or pathologist as to what time to collect, or if the antibiotic is already given, or what is the proper time, or how many sets. Sometimes what happens is, if the patient is neutropenic or immunosuppressed patients, many times we do not get the 4 sets, we only get one single set, that is 2 bottles. So that by communicating, they can communicate because it is difficult to get. So we are sending only one blood sample. Then we can also follow up from our side.
Any questions from the audience? Can somebody take the microphone, please?
Is there any role of sending the central line tips?
No, sir, central line tips generally are not acceptable. We generally tell that if we are suspecting any central line infections, just before removing the central line, blood culture from the central line can be sent. EP tips, Foley's tips, central line tips are not acceptable.
You told within 2 hours, 2 samples we sent to the lab. That is possible only in corporate hospitals. Whereas in outside setup, it will take minimum of 5-6 hours journey time.
Proper temperature has to be maintained during that time. It has to be transported in the ice pack. If it is any other sample other than the blood culture, proper temperature has to be maintained and they should be sent to the lab. Or till they send, they should be refrigerated. If it is blood culture, then it can be kept at room temperature. That is not an issue.
Nowadays, for salmonella typhoid, secondary antibody detector, first week blood culture. What is that? IgM, salmonella typhoid. Is it?
See, this rapid test, sometimes what happens is we get a faint band. So it becomes difficult to interpret whether this faint band has to be given as positive or negative. So generally these rapid tests are not recommended. Better is to go for the blood cultures or the ELISA test sometimes. But if you want to send for the rapid test, that is generally not recommended.
Blood culture will take minimum 3-4 days.
Blood culture takes minimum 3-4 days. Yes.
Last one.
How many days vital titers neutralize how many days it will take? Patient is coming today positive. Again next month again last one also the best way.
That is why we generally tell that the gold standard test is the blood cultures. Vidal test is not generally reliable. And if you want to check for the Vidal test, you have to check for the increase in titers, the rise in the titers. We are sending this week and it comes positive. Then again you send the next week. If there is a rise in titers, then we generally think that it is a typhoid infection.
Patient will feel bad and go to other hospital. They cannot get it within 2 days unless they must to other hospital.
will answer that patient way. See, as patients want immediate result, and especially even for us, they have been treated multiple days before they come and see us. We have to be honest, and those patients are usually less than 5%. We shouldn't get disheartened with that patient. Take 5-10 minutes explain. I think you are doing it already. But 95% will still stick with us. So no need to worry about that 1-2 patients. They will also come as we are honest. That's what the usual practice where we see that. They might be frustrated at that moment, but they'll still come back to us because we are honest. And maybe for typhoid, usually anyway, even if they are on the right treatment, daily antibiotics in hospital also, we see the fever is taking up a week or two to come down in certain set of patients. So it is not unusual to have symptoms in typhoid for a long time. So it's okay, I guess we have tested it.
How long it takes for the antibodies to neutralize the titers to neutralize?
It takes around 4 to 5 months to neutralize.
4 to 5?
Yes.
Suppose a patient has come, say, 50 day or 60 day blood sample,
you may get the lower titers. Sometimes what happens is whenever we see the viral, O and H titers, it is more than 160 or 320 generally we consider. He may have 1:80, 1:40 is the lower age. He may have 1:80, but that he may maintain for about 3 to 4 months. Then that is completely normalized.
Suppose today I have taken 6 months again is coming with fever, history of traveling, history of drinking contact, because I want to do something like that. I want to come to completion. Again, if I do wider, it can be positive because antibodies are present for 6 months.
During that time, you have to consider the titers. That's what I'm telling. The titers, whatever we do, the dilutions. If it is more than 1:160 or 320, then only consider it as positive.
And so you also compare the previous titers with these titers. If they have increased subsequently much higher. Say previously he was positive for 1 in 160. Now he is positive for 1 in 320, 1 in 640. That means this is a reinfection. That's all. If they are decreasing titers, then we have to look for other reasons for fever.
Excellent presentation. And the diagnostic stewardship is a Herculean task in any institute because you have to get the administration, clinicians, nurses, technicians, lab, everything into one structure. Antimicrobial stewardship itself is very difficult. Diagnostic stewardship is I don't know if anywhere it is being practiced in a fulfilling way. It needs a lot of motivation from the individuals and also from the institute. Some allocation of resources also has to be done. So it's a very difficult task, but it's very important also to see the larger picture of antimicrobial resistance. Nice.
Private.
The last but not the least topic of the conference is infections and urinary transplant and with graft rejection by Dr. Shoaib Ahmed Khan, consultant nephrologist and transplant physician, Medicover Hospitals. And I request Dr. Arun Kumar sir, consultant nephrologist, Medicover Hospitals, and Dr. Sita Brahma sir to chair the session.
Good afternoon, everyone. It's a Herculean task to really talk in the last lecture go home on a Sunday. So I'll try to make it quick and try to finish fast. So I thought that we'll cover things step by step as we are taught medicine, the meaning of each word. So before we really go into the depths of the topic, to start off by what is transplant basically? I think transplant is like a marriage. It's a boon to many, whereas it's a curse to a few. So transplant is not always, rosy life is going on. Transplant can be dangerous also. It can be life-threatening and life-taking also, especially if you get a dangerous infection. And what is an infection? CDC defines infection as it's an illness and it's caused by germs. They enter the body and they start multiplying and they're residing in your body like their own house and they start eating you off. That's an infection for you. And infection has many manifestations. But for today's topic, we will stick to the point of organ dysfunction. It is graft dysfunction which has been allotted to me. What is a renal allograft dysfunction? The definitions are very important. It's basically increase in serum creatinine or a proteinuria more than 1 gram in 24 hours. Why the serum creatinine point I brought here is because the usual graft rejection is a rise of creatinine of more than 0.2 milligram per deciliter. Unlike the routine AKI, which we all are aware of, it is rise of more than 0.3 or a rise of 25% of the baseline is known as a graft dysfunction. So we have to be very careful regarding the serum creatinine assessment, its understanding and its management. So graft dysfunction, we have very low threshold. And now comes to the art of transplant. See, this is the life of a nephrologist, that you have to travel a very, very narrow road and fight between infection and rejection. So balancing these things is not really easy. Nephrologist looks maybe, Lakshmikants are always casual like this, but it's a challenge. You have to manage infection one side, rejection one side, and the complex immunology, which has been taught to us right from MBBS second year and just going on and evolving, and we have to be up to date. We will not go to the depth of the immunology for another class. Infection has many implications. It's the second most common cause of death in a transplant patient, first being cardiovascular, and a successful transplant is lost. An opportunity was lost just because an infection brought it down. And the impact of rejection is heavy. There are two types of rejection. First is T-cell mediated rejection. There you can see a neutrophil sitting inside a tubule. That's tubulitis for you. And if you treat rejection, you have increased risk of infection because you treat with steroids, a high dose of methylprednisolone. And second thing is antibody mediated rejection. There you have glomerulitis, a neutrophil sitting inside the glomerular based membrane. And if you treat it still, your graft life goes down for 3 years. And again, you have increased risk of infections. So we'll try to focus it on that. And before we really go into the details of infections and all, just want to know the trail of how transplant has evolved right from 24th December 1954 when the first transplant happened to 2nd February 1971 when Dr. K.V. Johnny, he was a nephrologist who I have served him for some time. He was the first guy who did the first transplant in CMC without on 2nd February. And those days he told me, beta, those days there were very few drugs. We used to give Azoran and steroid sleep. Success or fail, we really don't know. But now the rejections has come down significantly. With that has come up the infections. These infections are really creating a havoc in a transplant sector. So we'll try to focus the topic infection and graft dysfunction. There are three ways to look at it. First is infection which can cause a graft dysfunction. Second is graft dysfunction if treated can increase the risk of infection. And the last is infection and graft dysfunction coming together. So we'll try to assess it one by one. Now, before everything happens, KDIGO, which is our main society of nephrologists, which tells us, dude, don't go for really treating infections, try to prevent it first. And they tell prevention is better than cure. So we screen all dialysis patients for some infections residing in them. We try to vaccinate them before transplant, and we give them antibiotics perioperatively. We give them prophylaxis, and we'll discuss those things one by one each of slides. So vaccinations pre-transplant, definitely Mithil sir has explained. Basically, in practice, we give 3 vaccines. We vaccinate against hepatitis B, pneumococcal vaccines, and varicella infections. Hepatitis B vaccination, we really give a double dose because the inherent immunity is low and seroconversion chances are a bit less. And vaccinations post-transplant are also very crucial. Don't buy out all those things. Remember one thing, post-transplant, no live vaccine. transplanted patients who are on dialysis, patients who are kidney patients by definition, are having an inherent high risk because these people have a background history of bulimia, diabetes, and there is something called protein energy wasting, which is unique to CKD patients. Induction was given. Induction is not a small word for the PTs and physicians. We really have two types of induction agents. One is depleting, second is a non-depleting. Depleting is thymoglobulin, and another was enantuzumab. In the early days, we have seen that you give one dose, all cells go down, infection comes in, patient also goes down. So the enantuzumab is out of the book now. We really use thymoglobulin for high-risk transplant. For a routine transplant, we give induction with basiliximab, which is a non-depleting, and we have methylprednisolone also. And the maintenance immunosuppression, this is very crucial to make the graft survive in a foreign environment which is hostile to the graft. So the standard immunosuppression is tacrolimus, mycophenolate, and prednisolone. And always when we manage a transplant patient, something which stays behind our mind is the net state of immunosuppression. Because that transplant patient can be a lupus nephritis girl who ended up in having a stage 5D and transplanted. She was given cyclophosphamide before, she was given rituximab before, she was on steroids before, and now she has got a transplant. So net state of immunosuppression being high predisposes a patient for a little bit much more high risk of infections. And definitely, since they are using long-term steroids, the integrity of their body basement membrane goes down slightly. And prophylaxis, this is a drug, trimethoprim sulfamethoxazole. Initially it came as Bactrim, it was used right and left by me years back, and nowadays physicians hardly use it. Probably PGs have never even seen this drug called Bactrim, but nephrologists, it's very sacred for us, like this mummy. It's gold for us, and we give it as a prophylaxis to almost every transplant patient. It prevents a hell lot of infections, and most importantly, it prevents UTI. This was a drug which was supposed to be given as a first-line agent for UTI, which now nobody uses, probably only nephrologists. It went out of production also. So various people have made their own drugs, and we use Selvin DS, probably you should remember the brand because not available in pharmacies also nowadays. And a little bit into infections. The infections fall into a certain timetable. It's not like, today I got up, I got some infection. There are some timetables where you have a certain risk of infection, especially the first month post-transplant when the immunosuppression is heavy and you have been in a hospital for 8 to 10 days. There is high chance of getting a nosocomial infection and Candida infection because you were in OT, you were immunosuppressed heavily, ACs were there. Any infections can come, and always don't forget donor-derived infection. It's quite rare when you have a live donor, but when you are into a high-volume center where you do cadaver transplants like CMC or NIMS, there is a high chance of getting a HIV, HCV patient. As Sir has told you to always check in 14 days. You may get that kidney and you may transplant, and the recipient may get HIV or HCV infection, or malaria also may be hiding inside the kidney, which comes inside the recipient. So donor-derived infections are very important in the first month of post-transplant. And first month, always think of sites. So that's how we physicians are trained. Look at the sites. The common sites is urinary tract. Follies was there, instrumentation was done, digestant has gone, kidney has come in the place. So the high chance of UTI, roughly 60% can get them in the first month post-transplant. And you have a high risk of respiratory infection. You were in an ICU, intubated for some time, and that's a higher chance. Certain infections are also very common because post-transplant you have roughly 30 to 35 sutures. So those healing, and most commonly patients who are transplanted are diabetics who are having a poor wound healing. So probably you need to look at surgical site infections, vascular accesses because they are a fistula, and other infections also can come in the first month of post-transplant. In the first to 6 months of transplant, this is the actual honeymoon period for any infection. It can just come in and it can just grow in your body like anything. And we classify infections into these 4 categories, what CDC has classified them. The first being bacterial, and you have a lot of infections over there. Nocardia can mimic tuberculosis, and you have viral infections like CMV, BK virus, and you have fungal infections like Aspergillus, Cryptococcus, or Mucor. Mucor, everyone knows nowadays after COVID, black fungus. So these things we have been seeing since the ages in the transplant industry, and you can get parasitic infections also quite common in the first 6 months. So we need to be very careful in the first 6 months. So we tell all transplant patients, first month is the most riskiest for rejection and infection. 6 months, if you cross, the risk comes down to a significant extent that it's same as general population. So because by this time the immunosuppression has come down to a minimal level and the risk of infection is equal. But however, there is always a risk First is tacrolimus, mycophenolate, and prednisone. So now we'll go to our viewpoints where we thought about how infection can cause a graft dysfunction, and just for the PGs, any dysfunction, be it graft, kidney, native kidney, you always think of three things. This classification has withstood the test of time right from Richard Bright in 1854 till today. You classify it as renal inside the kidney, and a post-renal. This holds true for even a transplanted kidney. So whenever you see a high creatinine, think in these lines and then go forward. So graft dysfunction caused by infection, the prototype is CMV. CMV, cytomegalovirus, that's how it looks like, that's what it does. It does dangerous stuff. So it's a prototype drug, it can cause graft dysfunction. This is a biopsy of a graft which shows the inclusion bodies confirmed by immunohistochemistry, which can cause rejection. So, and CMV is a prototype because it can involve any part of the body. It can involve the bone marrow, lungs, GI tract, liver, eyes. It can cause anything. Hence, it is a prototype. It can also cause graft rejection. So, what the KDO tells before it really infects you, please give a prophylaxis. And international guidelines tell you to give 100 milligrams of valbenazine for the first 100 days or 200 days as per the impact trial. But what you can experience, we all are the jugaad guys, does things in an economical way, sufficient for the patient, good for the pocket. So we have come with our own guidelines which aims as, authorized that 450 milligram once a day for 3 months is fairly okay. The incidence of CMV goes down almost by 95%. So this is what we follow in India, and we need to look at the GFR also. If the GFR goes less than 45, this drug needs dose modification. And if you got a CMV infection, then you need to really give a full dose. That's 900 milligram, morning and evening, till you get a PCR negativity. And if not, then give IV ganciclovir. And this is the virus which has been mutating and troubling nephrologists and transplant physicians throughout the globe. Unlike COVID, it's not so fast because the population is very minimal, but you are very likely to get in Hyderabad. UL97 gene mutation positive patient. The NIMS is facing big time nowadays, and CMV is given an immunity that I won't respond to ganciclovir or valganciclovir. So in this situation, you give pseudocidofovir and fosmanid together. And in India, again, 4 or 5 cases are reported which are having UL54 gene mutation, which again gives us an immunity that I won't respond to all these drugs. Then you have a newer drug called letermovir or Medicover, which can kill this CMV. But the key here is, if you have a rejection, you don't treat rejection because infection can take your life. Rejection will just take your kidney. So in CMV, you really don't treat rejection, you treat CMV. But you don't reduce the immunosuppression in tacrolimus form, you reduce antimetabolites like mycophenolate, you don't give pulse therapies, you don't do plasmapheresis, you just pray to God that may this graft survive, may the patient survive, that's all. So if you have a trade-off, you trade off the kidney, but you don't lose the patient. So the other viewpoint is rejection, which can cause infection. The higher the immunosuppression, the higher the risk of rejection, and we need to watch for those opportunistic infections which are mentioned, bacterial, fungal, viral, and parasitic. And if the patient was treated for antibody-mediated rejection, plasmapheresis was done, they need to look for infections which may happen that was transfused by the blood products or encapsulated bacteria which are at a high risk for these patients. The other point is infection rejection coming together. So again, the prototype here is the BK virus. So this virus was found in a patient whose initial was B and the second name was K, and from there the term comes that it's a BK virus. And this BK virus is there in almost everyone, and once immunosuppressed, it can cause BK virus nephropathy, it can cause ureteric structure, it can cause cystitis, it can be hemorrhagic, and it can cause viremia, urea, and it can be diagnosed by seeing a Hoffen cast in the urine or by a biopsy. That's how it's confirmed. And this biopsy shows the inclusion bodies in the tubules, that's the BK virus over there, which is confirmed by immunohistochemistry, and you have a tubulitis also, you have a rejection. BK virus with a rejection, what to do? So what the guidelines tell is if you have rejection and BK virus, don't worry about the virus, it doesn't kill the patient. You treat rejection first, and then you can later on reduce the immunosuppression. So you treat rejection classically with high dose of steroids or plasmapheresis, and in plasmapheresis probably IVIG has antiviral properties also, you can reduce the BK virus thing. And sometimes the situations are tough. You may have rejection, you may have infection, and you may have a PTLD, that is a post-transplant lymphoproliferative disease. This is a cancer. That's just because of immunosuppression.
So in this situation, I have my article which I got probably IIT around a year back. So in this we have found a person with a tuberculoma, a person with a lymphoma, and a person who was treated for ATT, and after ATT it caused reduced glycogen levels and got a drug dysfunction also. So it's a hell of a challenge. We need a good team to really analyze and take the patient through. As I have told, it's a difficult balance. Trust me, it's very difficult. So while treating an infection like tuberculosis, which is quite common in our country, we may have to give a very important drug called rifampicin. So if you give rifampicin, you have a high chance that drug levels of tacrolimus may come down. So for PTs, always remember three points in each topic. You will have to know the most common causes always. So certain drugs like clarithromycin, you are giving Clalimate for LRTI or URTI, you are giving fluconazole. These things can increase the tacrolimus level, and high tacrolimus is nephrotoxic. Again, creatinine may go up. You may get deceived that your kidney is getting damaged, what's going on. Just because the drug is there, increasing levels of tacrolimus. And if you are giving rifampicin or anti-epileptic drugs like this, that can reduce the level of tacrolimus. And again, the patient may go into a rejection. So we need to be careful. And if you have a transplant patient who is requiring ADT, probably modified ADT will be the way forward, or give rifampicin. We have transplanted one guy around 8 months back who was on ADT. 8 months after that, we transplanted him. We monitored the rifampicin regularly and successfully he was treated. Anyway, the topic is too large and justice to the topic can't be done, especially at this time when everyone wants to go home. And Sunday is the day, when we Lakshmikant sir really enjoy with our carbon fiber t-shirts and roam around. So, and this is my boss, Kamal Kiran, who is really great. We have done 200 transplants in 2 years, and fortunately, hardly any infections. Whether it's the karma of the boss, or the karma of Medicover, or it's just God's blessing on Sharad Reddy and Anil Krishna, we really don't know. But whatever transplants has happened, 200, hardly any infections, hardly any rejections. All previous institutes I have seen a number of things happening, but here with Kamal Kiran, really, it's a fantastic time, fantastic, entertaining and learning experience with transplantation. And just because we really pray to the Nepals many of the times. Thank you.
Thank you, Shoaib sir, for an interesting talk. I think everyone got a coffee without actually drinking it. So it's open for discussion. Any notes you can always ask.
Thank you.
Such an enthusiastic presentation. I have just one doubt. So you give variant secure prophylaxis when you're giving transplant patients. Is that a norm, or you do a preemptive monitoring?
Any person who qualified to undergo a transplant, we definitely check whether he is CMV positive or not. If he is negative, then only he goes into the transplant program. And when we transplant any person, we as an institute, we give thymoglobulin as an induction policy for all, unless they are having certain issues. So once thymoglobulin is given, the depleting induction agent, we give valproate for all, starting on day 5 post-op till day 100.
And your transplantations are usually on this triple immunosuppression for the entire life.
Yeah, triple immunosuppression required for the entire life.
Nice presentation.
I have one question to you. As a general medicine and family care physician, somebody who is heading towards a transplant, what should be my ideal preparation in terms of infection precautions and their work-related life post-transplant? How to prep anybody?
It's a practical question, madam, which we face on a daily basis with patients specifically. Before transplant, they always ask us, so the answer is basically, if you are having an office job, then probably after 90 days, that's 3 months, he can resume normal activity.
because that's when the immunosuppression really comes down to a very minimum level. If the person is, like a person who is working in really heavy public places like this, Pujari in Apati, recently we had a big Pujari in a big temple we transplanted. So for them it's like after 6 months, that's when the opportunistic period of infection goes down, the risk of PCP goes down, that's when we tell them to go for the job. And remaining in the house, really there is not for any barriers at all. That's practiced by Kamal Kiran in a very sensible manner. Here I have seen that we also don't wear any mask over the patient. And certain to aaj se normal ho gaya. अरे POD 1 है. आज से from now you are normal. That's his counseling and probably so probably barrier with family members, and that's not required at all. And it's supposed to be a reverse sort of isolation. Person who is sick should not go over there. Probably that's all. So family has to be sensible enough. And fruits which they eat, that should be peeled off. It should not be with the skin, because with the huge modified, which fertilizers and pesticides which are used, we don't know what's coming in there. And food should be freshly cooked, home food. And only in our transplant ICU, Mata sir has allowed home food to come. Otherwise, all patients get hospital food. But Kamal Kiran has, micromanaged that part also. That patient from day one gets home food. So I think he should feel normal. And job after 3 months definitely should join.
No need of like PMD type of isolation.
Nothing. But PMD is these isolations are in the guidelines. But last so many months which I have seen here, and these 200 transplants, no infections, probably we need to get our own guidelines. The AX has come with 450 milligram of valganciclovir. We also need to reduce the level of isolation, because hygiene hypothesis is also dangerous. A person who is not exposed to microbes is at the highest for getting a catastrophic
Which we
infection.
seen last year with post-COVID.
Post-COVID, yes.
How they became super infectious. Thanks.
Thank you.
Thank you, sir. Now I request Dr. Nanda ma'am to facilitate Shoaib sir and Hamid sir. Mother sir, please.
Yeah, take longer than
Next is quiz for all the residents and DMOs, and I request Nanda ma'am to take over.
Close it like that. Can you please come to the dais?
ఉంటుంది కదా ఇప్పుడు అయిపోతుందా
First question. The choice of anti-mold prophylaxis in patients receiving myelosuppressive chemotherapy. A. Osaconazole, B. Voriconazole, C. Fluconazole, D. Isavuconazole.
Osaconazole.
Next question. 40-year-old male came with complaints of paresthesias of right hand and difficulty in gripping objects since few months. Examination revealed reduced sensation over medial aspect of right hand forearm and grip weakness. Identify the lesion and advise further test.
I think it's carpal tunnel syndrome, so we can go for Turkle's tested.
Leprosy, you should have a biopsy from the lesion. Then coming to the next question, anti-mold prophylaxis is indicated in which of the following situations except anti-neutrophil less than 100, ANC less than 500 for more than 7 day duration, receiving high dose dexamethasone for 14 days, and risk of invasive mold infection more than 6%. Receiving high dose dexamethasone for 14 days. See the correct answer. So for high risk, next question, the 5 high risk patients, they should be hospitalized and administered broad spectrum antibiotic intravenously. Initial monotherapy is recommended including anti-pseudomonal beta-lactam, B. Carbapinum, C. Piperacillin tazobactam, D. All the above.
Should not be all the above, any of the above. Should be any of the above, not all the above. Yeah. True.
Any of the all the above options. So, a HIV positive mother's viral load at 36 weeks of gestation was 20,000 copies. She plans to breastfeed the baby. What infant prophylaxis should be advised and for what duration? A. Syrup nevirapine for 6 weeks, syrup tirovidine for 6 weeks, syrup nevirapine plus syrup tirovidine for 6 weeks, both for 12 weeks. Option C or D?
కాదు ఆడు మాట్లాడుతుంటే ఇటు ఎందుకు పెట్టిన స్క్రీన్
D. Correct answer is D.
Because there is no history of she taking like prophylaxis.
అది ఆపేసి
So we
నువ్వు
should take
ఆడియన్స్
for
పెట్టాలి
take for 12 days. If there is a history of
Oh, chalo.
taking antiretroviral therapy, then she should take for 6 weeks.
Yeah, that. And the viral load is high.
Yeah.
The correct answer is syrup nevirapine plus syrup tirovidine for 12 weeks. Which drug can reduce tacrolimus levels? Piperacillin, rifampicin, fluconazole, pantoprazole. Correct. Mrs. D has reported to ART center 7 months of pregnancy. She is ART NAV and CD4 count is 385 cells. What ART treatment should be initiated on? A. Tenofovir, emtricitabine plus abacavir.
D option. Option D.
Correct. tenofovir, lamivudine, dolutegravir. Which infection can cause graft dysfunction? CMV, BKV, graft pyelonephritis, all of the above. So how many sets of blood cultures have to be collected in a patient with suspected sepsis? 2 sets. For CSF isolate, which of the antimicrobial agents should not be used for treatment even if tested susceptible? Agents administered by oral route only, first and second generation cephalosporin and cefalomycins. All of them. So all the following statements about diagnostic stewardship are true except choosing the right test for the right patient. Clinical history and details are not required. Includes appropriate transport of the specimens. Then coming to next question. Which of the diagnostic methods is not recommended for sputum negative TB? CBNAT, TrueNAT, LPH, gene expert, rifampicin, ultra test. LP. So which induction agent carries the maximum risk for infection? Mesilizumab, rituximab, hemoglobin, alaftilumab. Which of the following drugs should not be used as part of first-line treatment regimen in children with pulmonary tuberculosis? Rifampicin, pyrazinamide, streptomycin, streptomycin. What is the time taken for CBNAT to be done? 1 hour 45 minutes, 2 hours, 24 hours, 48 hours.
1 hour 45 minutes.
Correct answer. But equally distributed. What is the most common cause of traveler's diarrhea? Rotavirus, Coronavirus, ETEC, Salmonella.
The options.
The ETEC. So malaria chemo prophylaxis for pregnant females traveling to chloroquine resistant areas. A. Doxycycline, B. Mefloquine, C. Artesunate, D. Primacine. Malaria chemo prophylaxis for pregnant females traveling to chloroquine resistant areas. Mefloquine. Chemoprophylaxis for travelers dry area, rifamycin, rifaximin, rifabutin, azithromycin. Last question. A 20 years old female presented with low grade fever for 10 days associated with headaches and vomitings. She started to have blurring of vision in 3 days. MRI brain with contrast was done. And CSF analysis was done suggestive of predominant lymphocyte hormones 100 cells with protein 70 milligrams per deciliter and glucose 34. MRI brain with contrast shown below. Comment on the findings and the final diagnosis. Tuberculosis. Tuberculosis meningitis.
Basal exudates.